of Events, Matthew Herper, and Stat General Assignment Reporter and Associate Editorial Director of Events, Nicholas St. Fleur.
Welcome, everybody. I'm Matt Herper, Senior Writer for Medicine here at STAT and the Editorial Director of Events. And joining me here is Nick St. Fleur.
Hey, everybody. How's it going? I'm Nick St. Fleur. I'm a science reporter, Associate Editorial Director of Events, and host of the Color Code podcast. Thanks so much for joining us.
Welcome to the 2024 STAT Breakthrough Summit West. We're really thrilled to have all of you here. and also a warm welcome to those attending virtually. I want to welcome you not only here, but to STAT, which is a special place in journalism. What really makes this place special is that we cover life sciences as the most important thing in the world with the highest quality journalism. Later today, you'll hear two sessions moderated by Casey Ross, who shared a Pulitzer Prize finalist status with our other colleague, Bob Herman. Rick is going to tell you more about that, a lot more about that. But really amazing moderators and great journalism on stage.
Yeah, we're really excited about the agenda. So coming up, we have a whole block of AI content, starting with my own conversation with Microsoft's Peter Lee about how generative AI could change the way your doctor practices medicine. So I know you all use ChatGPT, so does your doctor. We'll learn a little bit more about that. That'll be followed by NVIDIA's Kimberly Powell being interviewed by, and we're going to say it again, our Pulitzer Prize finalist, Casey Ross over there. Let's get that round of applause real quick.
Casey!
All right. And then Casey will do another session where he'll be speaking to Google's DeepMind's Colin Murdoch about harnessing the power of AI to develop new drugs. And then Matt will take the stage with Peter Su about what an AI that can generate, to learn more about how AI can generate genomes and what that kind of looks like, and what the ARC Institute is.
Later in the morning, we'll hear about efforts to address the opioid crisis, moderated by Lev Thatcher. We'll hear from Bob Kocher, one of the architects of the Affordable Care Act, now a top venture capitalist. We'll get to meet Elizabeth Beek and David Schulte, who've been key figures in kind of the fight for scientific integrity.
Okay, and then we'll have lunch. And the lunch here is typically really, really good, so you guys will really enjoy that. And then after lunch, we'll have a demonstration of how AI can change the way doctors document medical visits. We'll look at how wearables have and haven't lived up to the hype about them. Alison DeAngelis will gather 3 of the top startups in biotech and health tech, and then Usha Lee McFarling will look at efforts to reduce black maternal mortality. And then, of course, Adam Feuerstein will interview Cytokinetics CEO Robert Blum. Matt will run another panel looking at generative AI in drug discovery.
If you need it at any point during this litany of amazing stuff we just read, the coffee is out there.
Yes.
We have tea, too, for those of us tea drinkers. Nick and I have sat on the prep calls. We don't think you're going to have any trouble paying attention. We've also looked at the applications for all the people in this room. You're here. This is an amazing group. Get to know each other. Throughout the day, you'll see Nick, myself, and Catherine McPhail. Catherine?
Hey, there she is.
Yeah. With microphones. Even if we don't come to it, you grab us by the arm, ask your question. We want to hear from you. We want this to be engaging and interactive. And now some housekeeping.
Right. And again, to emphasize, questions are so important. You're such an incredible and intelligent group of people here. Sometimes you all ask the best questions, so be sure, if you have something, we don't do like last 5 minutes for questions. We do it throughout, so be sure to raise your hand and flag one of us down. And that'll help kind of direct the conversation as well. So on the back of your name tag, you'll see some important information, Wi-Fi information, as well as a QR code to access our Summit mobile app, hosted on Bizzabo. Please be sure to download the app. Here you'll be able to find the most up-to-date agenda and speaker information, participate in session voting, and connect with other Summit attendees. Once you've downloaded Bizzabo onto your phone, you'll just need to input the email address you registered with to sync up to this event. Also, at the end of each session, we want to know what you thought. When you open each session in the app agenda, you should see an option to rate this session from 1 to 5 stars and provide any other feedback. Please do this. It helps us better understand what you all want to see at our events. Now, as we keep putting on these events, it's really important to us that we're crafting agendas that are reflective of the topics you all want to hear about the most.
If you hear something interesting or unexpected, we encourage you to share it on social media, platform of choice, hashtag StillStatBreakthrough, tag @StatNews. And finally, a special thanks to our Stat Breakthrough Summit West sponsors who have helped make this event possible. Our presenting sponsor, Genentech, and our premium sponsors, the Chan Zuckerberg Initiative and Gilead Sciences. With that, I'd like to welcome you here this morning. I'm pleased to introduce Stat's co-founder and executive editor, Rick Burke. Rick.
Hi, everyone. Thanks. Beautiful day in San Francisco. We're thrilled to be here. I just want to talk for a moment about the amazing work our reporters at Stat are doing. World-class journalism that you'll see showcased here on stage today. From the moment I co-founded Stat more than 8 years ago, our goal has been to build a news organization that covers medicine and life sciences better than any other. Our journalists are authoritative and, in my view, play at the very highest levels of American journalism. They are among the foremost experts on the topics they cover. One way of seeing this is through the awards that Stat writers win. Let me just tell you about a few of them in recent weeks. As Matt mentioned, Casey Ross and Bob Herman were named 2024 Pulitzer Prize finalists in investigative reporting for, and I'm quoting from the citation, exposing how United Health Group, the nation's largest health insurer, used an unregulated algorithm to override clinicians' judgments and deny care, highlighting the dangers of AI use in medicine. Casey and Bob, the newsroom calls them Bob Ross, were showered with other top honors, including the Poynter Journalism Prizes, Batten Medal, which recognizes exceptional journalism that makes a difference to the lives of people in their communities, and the Nickham Award for General Investigative Reporting. For several years, Casey has led the way on health tech coverage, not just at Stat, but among all journalists everywhere. Many other Stat reporters have been honored in recent weeks, including Rachel Coors for co-authoring an investigation. The NIH has poured, headlined, the NIH has poured $1 billion into long COVID research with little to show for it. The Trade-Offs podcast, in collaboration with Stat's Tara Banow and Bob Herman, was honored in television and audio for a program, Can the U.S. Put an End to Surprise Ambulance Bills? At the Society for Advancing Business Editing and Writing Best in Business Awards, Stat won for general excellence for its authoritative coverage of the business of health and medicine, and Stat's Obesity Revolution series won for explanatory journalism for a year-long series about how the new obesity drugs are transforming patients' lives, dividing medical experts, and spurring a multi-billion-dollar business battle. These awards are just one sign of the impact of our journalism. Another is that readers will pay for our work. I'm thrilled to report that there's been a flood of sign-ups for Adam Feuerstein's new biotech weekly newsletter, which is available only to subscribers. Before Adam joined, I didn't know, I met with him, I didn't know if I was going to hire him because he's sort of this controversial guy. And I thought, so rather than hire him, I assigned a profile of him that the headline said, the most feared man in biotech. And that was kind of our vetting of Adam, where I thought, well, he got it through, and our reporter wrote a tough-minded piece and found out this guy is fair and authoritative and smart, and we want him on our team. So here he is, and has this really growing popular newsletter. And you can also, of course, hear him on Read Out Loud, the podcast, every week. I also, if you don't already, I encourage you to sign up for our free twice-a-week health tech newsletter. The writers are all here with us today, and our free Healthcare Inc. newsletter that comes out every Monday. And of course, you all know Matt Herper, who's one of the most respected journalists covering health and medicine anywhere, and is certainly, as we can see today, the most skilled at drawing the most sought after and interesting participants to our events, both on stage and in the audience. Matt is very determined to make sure that everyone in the audience could just as easily be a panelist on stage. And that we strive, and he strives for the highest quality programming we can have. We can't do this work without our subscribers. If you are a subscriber, many of you are, thank you, and we're much appreciative, and that you're part of our community. If not, I hope your being here today will convince you to sign up. Thank you very much.
Welcome to the stage, Vice President and Chief Marketing Officer of Genentech, Dr. Erica Taylor.
Good morning. I'm so excited to be here. You can't see it, but the fog just burned off in San Francisco, which is a treat for us. My name is Erica Taylor, and I am the Chief Marketing Officer at Genentech. I also have the pleasure of leading our health equity efforts across commercial, medical, and government affairs at Genentech, so I'm really excited to be here. But perhaps most importantly, I am also a wife. I am a mother of 2 incredible children, and I've been a lifelong severe asthmatic. It means I navigate the healthcare system with things that you do see and things that you don't see, that sometimes mean I go overlooked and unheard. As I work together in partnership to help build a comprehensive health equity strategy for our organization, I am reminded daily why this work is so important. Especially at a time right now with everything in the world happening around us, where people question these kinds of efforts inside and outside of our organizations, it is important that we stand collectively undaunted and continue to challenge the status quo. The lives of patients, of course, depend on it, and I am privileged and honored to engage in this work to address health inequities. After all, and I spent 10 years as a bench scientist, what is the purpose of developing these medicines, advancing science and treatment for novel and new modalities, when people who need it and can benefit the most can't access it? I'll tell you a quick story. I mentioned I'm a parent, and I have a 14-year-old daughter who is a dancer, a cheerleader, and an athlete. Earlier this year, she had a knee injury. She's fine now. But in the moment where she sustained this injury, it was a pretty scary moment. She's on a stage, she goes down, that heart and throat moment as a parent. And we were out of town, so I was in an unfamiliar city, didn't know really where to go. We ended up transporting her to the emergency department just to make sure that she hadn't done any more damage to her knee. And while we were sitting there, I hand over my insurance card, and you're giving all this information. And the woman looks over at me and my daughter, who, by the way, is in a full, cheerleader uniform, so much glitter. And she looks at us and she says, "You're Medicaid, right? This is Medicaid, right?" And you guys, it didn't even land for me. I was still in here, like nervous mom mode. Is my child okay? It wasn't until I was relaying this instance to my husband, who was back here in the Bay Area, and he's like, "Wow." And I'm like, "Do you think?" It just didn't even occur to me. And in that moment, my poor daughter's like, "What's Medicaid?" And it was one of those moments where, I'm in this moment of fear, trying to make sure that my child is okay, and I'm watching this woman try to calculate what different kinds of care we're going to get because she's made an assumption about us in here. And it goes to show, and it regalvanizes me to continue in this work to make sure these are not experiences that people have to face. Believe it or not, I actually called that woman back. I was so outraged. And I was like, "You better put in there, this isn't Medicaid. I'm really curious as to why you assumed that with no other information than a health insurance card." There was a black nurse sitting at the nurse station, and I could see her going, So, and I laugh about it, but I say this as a stark reminder to what happens to everyone interacting in the healthcare system today. And I said, I come back to the office all the more fired up to continue to engage in this work. But today, we're here about envisioning a future in healthcare that we all want to see. At Genentech, we envision a healthcare system that is diverse, inclusive, accountable, and trustworthy to people who happen to, in that moment, be a patient. We know that achieving this vision is not possible alone. Quite frankly, as a drug manufacturer, we're very often the last couple of miles of a health inequity. Most of these inequities start long before a person ends up in a healthcare delivery center. We all know that. And so in order to really make real strides in addressing health inequities, we have to partner. We partner across the healthcare ecosystem, including industry, other industry partners that are represented here today. Government, researchers, advocacy, and community-based organizations. That's the only way you get to be trustworthy and accountable. And we do this in partnership with the communities most harmed by these inequities. As we journey through today's sessions, I encourage us all to not only listen, but to engage and to question. Question whose voices are present, but whose are missing. Who's included in the data and who's not? Who has access to these innovative solutions and who has been systematically excluded? In what ways can we all use our collective wisdom and our collective power to dismantle inequities that are exacerbating them? Today and every day is important as we always center, as I call it, the person who happens to be a patient in that moment, and do so in our conversations and actions, not only today, but as we go out into this beautiful San Francisco afternoon. Thank you so much again for this invitation. I wish you all an amazing day.
So thanks, Dr. Taylor. Now, here to kick off today's programming, to join me in our first conversation of the day, please welcome to the stage Dr. Peter Lee, President of Microsoft Research. Let's get a strong round of applause over here. So, Dr. Lee, we've spoken a bit before. You were part of our 2024 status list. And when we first spoke, you kind of were telling me a little bit about this origin story you had with ChatGPT. Take us back to that time when ChatGPT was just about to launch and kind of where you were and why it started to be such a big deal on your radar.
Well, first of all, thanks. And don't call me Dr. Lee. That never feels quite right.
Well, then,
especially
Peter.
In a crowd like this, Peter. And it's really an honor to be here and to have a chance to share a little bit. My day job, my normal job is leading Microsoft Research, which is the research division of the company. But I did spend a 5-year stint outside of Microsoft Research rebuilding our health tech business. That was from 2016 up until the pandemic. And so in the summer of 2022 was the first time that I was exposed, brought into the tent, as we would say, within Microsoft on this new model, which we now know as GPT-4 or GPT-4o. And because of my previous work in health tech, I was assigned the task of assembling a small group in Microsoft Research to study, well, what might the implications be for healthcare and medicine?
Right.
And so we started in September of 2022, a small group of us. We were doing some really interesting work. And then in November, and it's November 30th, and I'll never forget that because that's my birthday. But it's also the day that OpenAI launched ChatGPT. That's November 30th, 2022. And ChatGPT just went way beyond any of our expectations. It really, for the first time, seemed to make people realize what AI could be. And on December 3rd, I received my first email from a clinician friend in the Midwest. And more or less the email said, and it wasn't then the only one, there are several, said, "Wow, Peter, this is amazing stuff. And I'm using it to have the receptionist in my clinic write all the after-visit summaries to my patients." And I mean, the emotions were really mixed. I mean, for me, and I think for our little group, we were thrilled. But then, just within minutes, there's a feeling of dread.
Right. Tell us more about that dread.
Well, we were working with GPT-4 for several weeks. Just incredible model. Just exceeded all of our dreams and expectations for what a neural transformer could do. But ChatGPT, that was released in November 2022, was based on a weaker model, a toy model, which we now know as GPT 3.5. And we had already come to the realization that GPT-4 would be prone to issues of bias, hallucinations, mathematical and logical errors. And GPT 3.5 would be way worse than, in every dimension. And so there's an immediate question, should we allow this to happen? And that escalated into a broader discussion within the company about what to do about this.
Give us an inside look. What are those discussions like?
Well, within my group, we had several MDs, 4 MDs. 3 of the MDs were involved in the secret assessment of GPT-4. It turned out that those 3 doctors, 2 of which are still practicing, had different opinions. No agreement there. We involved legal counsel within the company. Is this even legal to let this happen? There is PR and communications. There is senior leadership, business leadership. And I would say, just without getting into too much detail, just as we're seeing in the world today, there was no consensus on what this should be, except that we did come to the firm conclusion that we needed to somehow educate the medical community to get up to speed as quickly as possible. And we adopted this slogan to get the medical community to take assertive ownership and control over the question of whether, when, and how this technology should or shouldn't be used.
So let's just lay the land right now. How is this technology being used right now in doctors' offices? Is it mostly transcriptions of notes? Is it mostly for health records, electronic health records in that sense? How is it being used right now?
Yeah, so I would say right now it's really back office kinds of functions right now, which are really meaningful. And let me say, I'm actually secretly, really, not so secretly, I'm about to say it to all of you, I'm really pleased about this. One of my frustrations when I was working on our health tech business is when you involve techies like me into healthcare, techies get fixated on medical diagnostic technologies. Just over breakfast, I was having a conversation with several people, yet another radiological imaging doohickey. And there's sort of a tunnel vision in technology traditionally. It's very flashy. Venture capitalists who are very techy get impressed by that, and so it just fuels yet more fixation on that. But there's just so much more to healthcare than that. And business-wise, it also diagnostics is very difficult. It's not a growth business today. Maybe it should be, but it isn't. It requires very significant clinical validation, regulatory approvals. So one good thing is that generative AI has sort of forced the technology community to think more broadly. And so one thing you see out in the world now is just rapid, broad deployment of technologies based on generative AI for things like clinical note-taking, for writing after-visit summaries and communicating with patients, filling out prior authorization texts, and so on.
You were talking a little bit about diagnostics there. So where are we right now in terms of where generative AI is it being helped to give out diagnostics in that sense, to diagnose these diseases, and should it be? Like, are we at that stage right now? How are you feeling?
Okay, so I'll give an answer for today, but one of the things to understand is that the technologies that we have today, let's call today's technology GPT-4 class. GPT-4 class, as Sam Altman said famously just last month, is going to be the worst AI you will ever use. So things are getting better and better. But if we just focus on GPT-4 class, in my view, you should not use that to propose an initial diagnosis or treatment plan for a patient. It is just not reliable enough to do that. However, and that's despite the fact that several GPT-4 class models, including GPT-4 itself, are better in terms of medical knowledge tasks than 97% of practicing physicians today. But as was just written in the current issue of the New England Journal of Medicine AI, there is a use for GPT-4 class models today as a second set of eyes or second opinion on the work that doctors and nurses do. And so if a doctor is proposing, based on initial presentation and initial labs, an initial differential diagnosis, it is a very good idea, in my opinion, to use a GPT-4 class model to take a second look at that, to see if there are any gaps, other things that you think about. If a nurse is administering some medication, it's not a bad idea for that nurse to consult with a GPT-4 to make sure that the calculations on drip rates were done correctly, for example.
But if something is wrong or something does go wrong, where does the kind of, I guess, the legal responsibility fall there? Is it with the generative AI in this case? Is it with the doctors? What are those conversations like?
That is what has to be settled. So after the Human Genome Project completed the initial mapping of the human genome, if you're old enough, you'll remember that there was considerable concern about the specter of genetic engineering and the ethical considerations around that. And one of the good things that happened there is that a lot of extremely smart people started focusing a lot of attention on the ethical considerations around genetics, and that dramatically increased the amount of study and framework development in the field of bioethics. And concepts like recourse, which computer scientists refer to as accountability, really started to become a vibrant academic discipline. That has to happen here in the realm of AI. And I'm very optimistic about that because today I actually do see, roughly just, 14 months after the release of GPT-4, a tremendous amount of activity and thought going into this.
So I definitely want to touch on bias. You were talking a bit about bioethics and such, but before we do, I want to ask, I want to let the audience know, if you have questions, Matt is walking around with a microphone. If you have any questions, please ask them. So going to bias now, how do we do this AI? How do we do it more responsibly? How do we limit bias in this case? What do you kind of, what are those conversations like that you're having?
Right. So let's see. There's several levels. So let me be nerdy a minute and just be a computer science researcher, because that's what I am, actually. And so, in terms of computer science research, it's not settled whether biases in text-based large language models, language-based models, can be repaired or not. I would say overall, I think the prevailing view is very optimistic, that we will eventually develop methods for mitigating and even eliminating biases in large language models like GPT-4. I personally don't share that optimism. I think that these biases are really deeply inherent in what these models do, inherent in the same way that biases are inherent in human beings. And so my pessimism about being able to repair biases comes from the same pessimism that I don't believe bias can be eliminated from any human being.
Right, of course.
I could turn out to be wrong. Machines are much more pliable than human beings in many ways, and so who knows? There's a lot of work going on. But the thing to understand, even if you're pessimistic like me, is that like human beings, powerful language models can quote-unquote understand the concept of bias, can quote-unquote understand the idea that biases can be harmful, and let's say come up with your favorite story that shows biased decision-making in some informed consent, medical informed consent situation. Present that to GPT-4 and ask GPT-4 for its opinion about this, and it will quickly, very reliably spot the bias in the decision-making.
So more is like using ChatGPT-4 to kind of double-check, in that case, if
That's right.
biased.
And
That's where you have the optimism in terms of that.
that's right. And that happens even though GPT-4 might itself be guilty of making the same biased decisions.
Right.
So
We have a
there's
question
something-
from Christine Lemke at Evidation Health.
Hi, I'm just curious about the other side of the equation, which is lots of regular people, patients, are using the toy, to see their doctor too, and curious about the impact on the other side and doctors' perceptions and how you're providing maybe tools to help with that too.
Yeah, that's very personal to me. I mean, I think even lots of places have published a lot of stories about how patients have used, say, GPT-4 as a second opinion. There was a great paper out of UC San Diego and Johns Hopkins that was published in the Journal of the American Medical Association about 6 months ago, showing also that patients find the medical assistance they get from a chatbot to be more empathetic, more informative, and in one study out of UC San Diego, more human than the medical responses from a human being. Of course, they're not more human, but doctors are busy, frazzled, and so on, and you get those things. For me, the other thing is just an empowerment. So 13 months ago, my father passed away after a very long illness. And the thing that was very hard, and I've since learned so many people in our world go through the similar experience, the relationship between my two sisters and I during that 18-month period started to fray because it's just a very stressful situation. And a typical flare-up would be we would get a golden 15-minute phone call with one of the specialists taking care of our father, and my sisters and I would start to argue about how to use that time. And so what can happen? Well, I'm a techie, so I dump all of the lab tests, all of our notes, describe the situation, and say, we're going to have a 15-minute phone call. Patty, Jen, and I don't agree how to use that time. What can you tell us? And whether it hallucinates or not, actually, I think it gave very good advice. But even putting that aside, it just brings the temperature down. And when we talk about empowerment, that's a kind of corporate marketing term for a company like Microsoft or our competitors. But that is real empowerment. And I would just beg lots of great startups to start thinking about applications that provide.
Peter, we have a question right over
Sorry.
here.
No, you can but question from Andrew Forsyth at IDF Consulting.
Sorry to interrupt. I wonder if we could go back to your concerns about the bias inherent in these systems. Certainly the data sources are biased. The people using them are biased, but the scientific method tells us how we can manage some of these. We can strap ourselves to the mast and avoid the siren song and have a systematic approach to really question the quality of the information and the responses that we get back. Why can't we rely on that here? And if we could, would that help to eliminate or reduce some of your concern or your pessimism about eliminating bias?
Yeah, so I think that's a very good way of expressing the counterpoint to my pessimism, and you might be right. I hope you're right. I think when I think about bias and language models, I see a fairly substantial gray area between value systems, personal value systems, and bias. There's an overlap there that I personally am not able to separate. And so then the question in that gray area becomes, whose values? Something that you may consider bias maybe is, for me, a personal value. And so that's where I think things get very difficult here. And maybe it all gets sorted out. One thing that you're seeing out of most of the GPT-4 class models now is they're being trained to artfully dodge questions that might be hot button topics. They're actually getting very, very good at that. Maybe that's a practical answer. I don't really
you're not designing against a static picture of the system. And so we have to think about methods that are ensembled, methods that are substantially more sophisticated. And then another challenge that we've been talking a lot about, and this is across all of the computational machine learning efforts at Genentech, not just in my unit, is how do we figure out how to approach target discovery and prioritization? And that's really...
That's obviously the biggest potential benefit, but also kind of the hardest to measure as you're moving forward. You know when you've made a better molecule.
Yeah, the loop is now, when you said 10 or 15 years, I said, oh, we've got it down to 2 weeks. Well, once you get back to this target prioritization, yeah, the loop is scary. It's a lot more elaborate to actually make sure you've made a good decision there. And so there, that effort is going to be really exciting. And, for me, some of this stuff that I want to discuss as we kind of, go through the day with folks here, is just molecules can do more things at once, right? So how do we actually think about what a good target is when we can actually have 3-4 valences, when we have, affinities that are recruiting degradation processes or are pH or tumor sensitive, tumor environment sensitive. When we know that we have the capability of making molecules that do these things or bring these functions together, well, now we have to really up our game in terms of deciding, well, if I get to perturb 3 pathways and have a targeting arm, well, I probably am out in front of what I'm, sort of able to model a little bit. So that's fun.
Yeah. Well,
made with application of AI to structural biology, and I want to start a couple of years back. So it's 2020, and DeepMind shows up at a structure prediction conference called CASP. This is a generations-old problem called the protein folding problem, and you show up and you guys throw down and problem solved. And I remember I was actually at a media fellowship at Harvard Medical School at the time, and so it was, and we were talking with all these structural biologists and others, and half of them sort of had their heads in their hands, were like, how did they do that? And then the other half were like, eureka, let's go. And I just wondered if you could take us back to that moment and what it was like to be able to solve that problem, make that advance, and then sort of what the immediate thinking was.
Yeah, great question. Great to be here. Really, thank you for inviting me. So actually, even before that, so AlphaFold started during a hackathon. I don't know if you're familiar with what a hackathon is. This is a kind of period of a week or two where you just let people work on pretty much anything they want. And a couple of folks had an idea that AI could be used in this way. And so that was the seed, and that was the beginning of what later became AlphaFold. So back to CASP 2020, well, we'd been preparing for a long time. These are really hard problems, by the way, as you probably know, as you all know, these are really, really hard problems. And so we were absolutely thrilled when we were getting the results back to see how well AlphaFold 2 had done. It was like we were like cautiously confident, I think is the best way to put it. But when it came back, we were really, really excited. I remember sitting in the office, and of course, we popped a cork on a bottle of something and celebrated. And then the question is like, well, what do we do with this? This is an amazing breakthrough. What do we do with it? And that's part of my role, actually, DeepMind. I'm from an AI background. I've been at DeepMind about 10 years. I'm also now president of Isomorphic Labs. So a lot of respect to you all in the room, because I'm learning a lot about this industry and the incredible science you all do. So I'm looking at this, well, what do I do with this? And so we looked at a whole range of different things, interestingly. We looked at agriculture, we looked at catalyst design, and then we looked at pharma. Having spent probably 6 to 12 months looking really hard at that, we realized this was the area that we wanted to go into. Not just because of AlphaFold, actually. That was a really important catalyst. But when we analyzed the problems that we understood, the bottlenecks that we could understand, we felt that there was potential for AI to help unlock other bottlenecks. So that was the origins, if you like, of AlphaFold 2 and how it came about, but also Isomorphic Labs, which is the AI-powered biotech that we launched about 2.5 years ago now.
And the news, of course, is the advent and release of AlphaFold 3.
Right.
And an exciting moment in the sense that it can render the interactions between not just proteins and model those, but a wider universe of biomolecules, including RNA, DNA, ions, residues. talk about the applicability of that, where you see this now taking us in terms of the ability to practically apply that and make a difference on these really, really hard problems.
I will do that. Actually, could I just double check does everyone know AlphaFold 3? Great, half of you. Brilliant, thank you. So AlphaFold 3, as Casey just said, is a method of predicting the structure and the interaction of a whole range of different biomolecules. So this was the foundation, actually. AlphaFold 2 was the foundation of isomorphic labs, because we could all of a sudden understand the structures of proteins to provide the starting point for drug design processes. So AlphaFold 3 takes it to another level. It's more accurate at predicting the structure of proteins, and it can begin to understand the interactions of these proteins, including protein-ligand interactions. Now, of course, for drug design, that's incredibly important. And so we're putting that to work really hard at isomorphic labs. Right now, we have our own internal pipeline. We employ not just AI folks, but also medicinal chemists, computational chemists, drug hunters who have done this before. Really important for us to understand how this works. So we're putting it to work in isomorphic labs. In addition, as you can imagine, we have a whole range of AI models that extend AlphaFold 3 and complement AlphaFold.
Fold 3 has solved with one click some of the hardest problems our field has had. Going back to Kimberly Powell's point about AI accelerating path to n equals rare or n equals 1, can you speak about the future of availability of your extraordinary tool for academic and nonprofit research?
I certainly can, and it's very humbling to hear that it's had such a great impact. Thank you for other areas where, maybe not surprising, we are building AI models. So as a first step, I hope AI will not just allow us to do this quicker and faster and maybe at lower cost, but also allow us to come up with better predictions of how these molecules will perform without having to go through an experimental cycle. So doing more in silico or in a computer, reducing that design, make, test cycle. That's number one. Number two, I also hope it's going to allow us to begin to drug targets that were very difficult to drug before. And we are investing.
A case example of health inequity. And I would challenge you at DeepMind and others in the room here to think about the other end of the continuum as well. That is, to what extent can we use these technologies to improve how the drugs that are being developed in incredibly efficient ways now, or will be, or could be, how do we make sure that they get into the hands of those who need them most? HIV is a great example. Pre-exposure prophylaxis has existed for years. That was discovered years ago. And people still don't have access to it in the ways that they need. So can these tools be used to help us close the gaps in terms of health equity, not just in drug discovery? Thank you.
Yeah, it's a really important question. Thank you. So maybe the first thing that occurs to me is it is around drug discovery, which is that you would hope, as we apply more and more digital technology to this work, it will improve the economics, number one, and number two, increase the chance of success, which again improves the economics. And once you can do that, you can tackle maybe neglected diseases or other diseases which have been very difficult to tackle before. So I think that's a really important outcome. I think the second part of your question was for existing drugs. How do we get those to the people that need them? Can AI help out, get them to maybe other parts of the world that don't have access to them today? not clear to me immediately how AI would directly have a bearing on that. I suppose if in general you can improve the economics, then that will give you greater ability to maybe distribute these drugs to parts of the world that maybe can't afford them today. So I'm not sure I've got a clear answer on how you could do it directly for drugs today, but I hope if we can improve the overall economics, we can do this important work.
I wanted to pull out something that's changed in AlphaFold 3 from prior versions, where there's a diffusion model, which is the engine of that system. And with a diffusion model, these are commonly used in imaging AI that we all may know, generative imaging AI. And with that, while you get the increased power, you also have the problem of hallucination. And I just wondered if you could talk a little bit about the danger of that potentially leading to, people down rabbit holes, or just to sort of make misapprehensions, or misunderstand or interpret the confidence of the model and how to apply that. How do you address that?
Yeah, it's a great question. Diffusion models have been a really powerful AI innovation in the last couple of years. You'll see them turning up in image generation and actually video generation as well. We use them. And if you remember in the very early days of the internet, depending on how old you are, when you first saw an image load on your screen, it would be very fuzzy, and over time it would become crisper and clearer. And what's going on behind the scenes is actually that's what a diffusion model is doing. It's taking a very noisy output and just making it kind of clearer and clearer, maybe like you're focusing with a telescope or something like that. So it starts with a slightly kind of random setup and makes it less random. And because of that initial random seed, as you say, Casey, there's a risk and a reality that it hallucinates or just makes things up, is another way to put it. So how do we solve for that? Well, two things that we've done for AlphaFold 3, for example. One is we've actually used AlphaFold 2 predictions to help train AlphaFold 3, because it was pretty good at presenting something more credible around intrinsically disordered areas of the protein, which are the particularly difficult areas, of course, for us to represent. And the second really important thing, AlphaFold 3 and AlphaFold 2, I believe as well, provides a confidence rating for different areas of the structure that it predicts. So it's like, I'm really confident about that area, but you know what? I wouldn't trust me on this piece. So that helps reduce people going down rabbit holes, because they can focus on the areas that, or at least not focus too much time on the areas where there is a kind of less confidence. So that's
and you have good correlation between the confidence and the accuracy.
Exactly, yes.
Yeah.
Casey, we have a question back here from Nadine Bassan.
Thank you. I have a very quick question. On protein design, data is kind of the crux of the matter, right? You're going after undruggable targets. How are you kind of accessing all of the existing, or do you have a feedback loop of what you're trying in order to make the model better? I'm guessing the more data, the better, but Novartis and Lilly only have so much, so thank you.
Yeah, so data is a great question. And actually, step back for a moment. Normally in machine learning, there's the three things you need are computers, you need data, and you need researchers to train the computers how to use the data. And a lot of the breakthroughs in AI you've seen in the last couple of years have been greater availability of data. Actually, the T in GPT stands for transformer. That innovation was created about 7 years ago, interestingly. It's been the scaling up with data that's made the difference. What's really interesting for AlphaFold is the data was available for decades. And it was an algorithmic innovation that allowed us to kind of tap and make sense of that data. So for me, I'm learning data may be slightly different in this regime. Three areas we think about when it comes to data. The publicly available data like PDB, and that's one of the reasons why we like to give back. So that's an important source. Generating data yourself, I think, is another really important source. When it comes to existing data, existing experimental data, this is potentially valuable, and it's also very tricky. When you think about data, you've got to think about, first of all, can I digitize it? Secondly, can I get it all in one place? Thirdly, how do I error correct it, fill in the blanks? Fourthly, does it have the right distribution, or is it all about one particular model, because often, rightly in pharma, you kind of have this funnel process. By the time you get down here, you're focusing on a very small handful of molecules. When you're training a machine learning model, actually you want a whole variety, including the ones that failed. And then finally, it's about volume. And I think it's an easy mistake to make, is to equate volume with value. I've got lots of data, and so it's really valuable. That's not always the case. And so thinking about those three different sources of data are the ones we consider, and you just have to be very careful about existing data as you can analyze that.
Well, in the 2 minutes we have left, one of the, I think, exciting things that's happening is that the innovation in the AI isn't happening sort of in isolation on a parallel track. You're seeing a lot of advances and improvement in the experimental techniques as well, cryo-EM and X-ray crystallography, and sort of, and I wonder how you see these two advances moving in parallel, talking to each other in a way that begins to produce real significant breakthroughs and advances, and how you see that sort of fitting together in the work that you're doing.
So back to the data question, if we've got these advances in cryo, EM, et cetera, that's great, because that creates more data to train AIs and they get better. So there's a wonderful kind of partnership there from that respect. I think I see other companies building kind of labs in the loop, where they come up with a prediction, they put it in the lab, they generate some results, it feeds back to AI, and you kind of continue in this loop. As I think about AlphaFold, and as I think about what we're doing at isomorphic labs, we're modeling almost at the atomic level. We're modeling how these molecules come together and interact. And I think these kind of labs in the loops will be important. They tend to operate at kind of abstraction a couple or two above, and they can be very effective for a particular path or a particular kind of program. I think we're taking a slightly different route here, that we're trying to model what's going on at a very fundamental level. And it's not clear yet exactly how necessarily we will incorporate a lab in the loop there. So I think there is opportunity, and I think there is a kind of this new interesting path where we're building kind of very foundational models that understand the nature of reality in some sense of biology and chemistry at a much deeper level.
Well, it's really exciting work, and thank you so much for being here today, Colin. It's been a real pleasure.
You're welcome. Nice to see you all. Thank you.
Thanks, Colin, and our Pulitzer Prize finalist, Casey. I will say that every chance I get. Here for our next session, please welcome to the stage Dr. Patrick Su, co-founder and co-investigator of the ARC Institute and assistant professor of bioengineering at the University of California, Berkeley. Dr. Su is going to kick us off here, and then he'll be joined on stage by Matthew Harper. Great.
Thank you very much. I'm delighted to be here to tell you about some of our research training AI foundation models on the code of life itself. So 6 years ago, Frances Arnold, the inventor of directed evolution, wrote in her Nobel lecture, "Today, we can for all practical purposes read, write, and edit any sequence of DNA, but we cannot compose it." She ends by saying, "However, evolution does." So we started wondering, how can we imitate this language of evolution? Machine learning is starting to revolutionize the study of biology. Using models like AlphaFold or ESM, we're now able to predict the structure of proteins, design them, understand how they interact with each other, with ligands like small molecules, look at macromolecular complexes, or even predict the complex folds of RNA. However, despite the complexity of these molecules, they're orders of magnitude less complicated than an entire cell, right? Which is formed by the complex interactions between all these diverse molecules. It's a stunning array of combinatorial possibilities across multiple levels of regulation. So in short, it's very, very complicated. So we started wondering if all of this complexity is fundamentally stored in a single linear DNA genome sequence, could a machine that learns the evolutionary distribution of these sequences model something about the complexity of functions across these different molecules that governs an entire organism. So the problem with this, though, is that biology uses a different language. It's foreign, and it's not very human interpretable. High school students learn on the left this central dogma of molecular biology, where DNA is transcribed into RNA, which is translated into proteins. What you'll see, first of all, from left to right, is that this sequence is continuous, it's directional, and from bottom up, there is a sort of hierarchical information flow. So there's a lot of structure that's actually embedded inside of this central dogma. So we wondered, what would happen if we trained a model on a diverse corpus of whole genomes? Could we actually learn the language of evolution? Inspired by that, we called the model EVO. So we teamed up with Brian He, who's an investigator at the Arc Institute and also at Stanford, to lead a team of AI and computational biology researchers from across the Bay Area to try to tackle this problem. So what the main problem that we try to solve was just the size of these genomes. You need to be able to fit all of that into the right context length. Many biological molecules that are core to life are really small, like the tRNAs on the bottom of the slide, that are important for protein translation. However, at the scale of whole genomes, like phage, a type of bacteria, or a virus that infects bacteria, they're really long. They have multiple genes embedded inside of them that interact. EVO is able to handle these. Now, at the context length of this model, we're able to operate and process information even at the scale of whole genomes. So we pre-trained the model on a large corpus of 80,000 bacterial and archaeal genomes and millions of sequences from phage and from plasmids, constituting overall 300 billion tokens of nucleotides tokenized at single nucleotide resolution. What we found is that EVO is a protein language model. It's also an RNA language model, and it's also a regulatory DNA model. Previously, researchers in the field have trained task-specific models, specialized for each of these molecular modalities. But what we found was that EVO was able to predict protein fitness, non-coding RNA fitness, or the activity of promoter RBS pairs completely in a zero-shot fashion, something that, with performance that's competitive with these more specialized domain-specific models. Moreover, EVO is able to make predictions over the entire genome scale. We ran a computational experiment where we could put in stop codons computationally into every single gene in a genome and ask, could this model classify genes that are essential from genes that are non-essential in a completely unlabeled, self-supervised fashion? What we saw was that EVO was able to do this. And so in the future, it's possible that we'll be able to replace really laborious experimental assays like CRISPR screens, which costs tens of thousands of dollars, can take a year in the lab, instead with forward passes of a neural network. These models cannot do just prediction, they can also be used for design. And so we asked, could EVO be used to design CRISPR systems, which I've studied for the last 14 years? They're composed of proteins and of RNA across these two different modalities. And when we fine-tuned EVO on lots of genome crops unlabeled that contain CRISPR systems, we saw that EVO is actually able to reason across these modalities to co-design CRISPR-Cas9 or other types of CRISPR-Cas enzymes. Next, we thought we'd try something even crazier. Could we actually generate sequences at the genome scale? So we prompted the model with a special species token and let it rip. What we saw is that if we let the model just generate sequences, it's able to make genome-scale sequences that look like real genomes. They have the sort of robust coding architecture on both strands, and in fact, you can analyze them with bioinformatic tools that were developed for natural genomes to look at these sequences that were generated with AI. Embedded inside of these genomes are proteins, and when we pull out those proteins and look at them, we can see that they have ontologies that match with natural protein functions that are essential for life, and that they have the right distribution of protein structures that reflect natural distributions of alpha helices and beta-pleated folds. So we think of this as a foundation model for biology because it's able to learn across whole genomes to basically reason across these different modalities, something that's previously been the domain of more specialized task-specific models. We think there are important bioethical questions here. So we're teaming up with Tina Hernandez-Boussard, one of the directors of the Stanford Center for Bioethics, to develop frameworks for the safe and open evaluation of these models. Moving forward, these models will need to be aligned with experimental data and with human preference in order to improve the quality of its predictions and generations. We're also interested in following the scaling laws for DNA that we revealed in this work for the first time. Moving forward, we're also very excited about understanding multi-gene interactions, something that's been a long-time goal of the field of systems biology, and also a core goal and mission of the ARC Institute to understand and treat complex diseases. So this work with Brian He was led by Eric Nguyen, Michael Pauly, and Matt Durant, and we're very grateful to the whole team that contributed. Thanks very much.
So I want to ask you about ARC, but I want to ask you about a different kind of boat first, which is the ship of Theseus. Anybody know what the ship of Theseus is? This is a philosophical problem that I made Patrick cut from his slides. But the idea is if you take a boat and you go on a long trip and you got to replace the mast because it breaks, you've got to replace the floorboards, you have to replace the boards in the side one by one. And by the time you come back, you've replaced every part of the boat. Is it the same ship? So do you want to explain what that has to do with Evo?
So the question that we ask ourselves is if we could actually generate these long sequences, could we actually install them directly in bases? And you systematically swapped out 100,000 bases at a time, such that the final genome has been completely swapped out. It's been designed with AI. Its sequence identity is totally different from where you started. Every single piece has been swapped out, and it's just as different from any known genome in natural sequencing databases. Would you consider this a new life form?
If it lived.
If it lived, this cell will divide, it can grow, it can function. Would this be a new species?
No.
Even though it's the different genes that do the same things.
It happens to us every 7 years or 10 years.
No, they're not identical sequence. They're new sequences.
They're completely different sequences that are just as different from natural sequencing databases as they are from each other, right? And you're not changing individual proteins, right? Swapping out an individual protein wouldn't be an impressive result, but you're doing this at the genome scale. Right?
So I'll want your questions in a minute if you guys can find time, but I want to then ask, so if you take an academic lab out of academia and you start a new nonprofit called the ARC Institute, is it a new lab?
Yeah.
But tell me, to give people a sense of what ARC is. I mean, maybe we cue up the video. This is cool.
So here's ARC.
I can't watch it. I'll get really dizzy.
We're a nonprofit research institute. It's independent. We have our own operations, our own administration, our own space. We're partnered with Stanford and Berkeley and UCSF, and we bring together faculty from across the Bay Area into this single physical roof to work at the interface of biology and AI to try to accelerate scientific progress and tackle complex diseases. One of the things that we're doing, in addition to this PI-driven model that's very familiar in universities, is building out a technical staff model, more like you'd see in biotech industry or in frontier AI research labs. So we're bringing together professional R&D scientists working across experimental and computational technologies to really kind of tackle institute scale projects, right? Not R01-sized individual academic projects, but the kinds of grand challenges that takes hundreds of people to tackle. There's a space of problems that can be venture capital funded that won't be funded by the NIH. And that's really the core of what we're trying to do at ARC.
That's something people get very nervous about, this idea. You just said some of these could be venture capital funded, private money. How different do you think of this is from the history of science? I mean, vaccines probably wouldn't have happened the same way without the Rockefeller Institute. Genomics wouldn't have happened without Tiger, arguably. So, how do you think about your place in the world as a nonprofit research institute?
I think there's a long and illustrious history in the United States of biomedical research institutes, starting with Rockefeller in 1901, sort of after modeled after the sort of European tradition of Institut Pasteur or the Koch Institute in Germany, right? But these are collections of brilliant scientists, and their main goal is to publish papers and accrete knowledge. One of our goals is to actually be able to follow our discoveries through into drugs, into new powerful AI technologies, and things that actually move out of the lab into the real world that helps patients. Right?
Any questions out there? So, but what's different ethically then about running this kind of nonprofit where you will take some of that venture capitalist money where you will look for other sources of funding. Like, what do you worry about?
Well, I think there are different ways that you can use capital for the different sort of phases of a project, right? When you need to do curiosity-driven exploration, right, it's important that you're able to do so in a sort of long-term minded way, right? Lots of these platform companies that have been getting spun out, right, end up axing after a couple years the sort of brilliant platform promise to focus on the sort of first 2 development candidates in their pipeline.
It's a classic biotech problem. Like you build a whole platform, invent one drug, and kill the platform.
And so the goal is, if you spin it out, right, how do you have the right type of focused commercial capital to sort of turn over the right cards, right? It would be an IND enabling study card, it would be a phase 1 card, but that can be potentially a much more capital efficient way to do it if you sort of align it with the structures that are doing the discovery.
Last chance for a question? We got one.
We have a question over here.
Hi, Patrick. It's Pierre Theodore from Genentech. Can you reflect on how this will change the nature of training the next generation of computational biologists and scientists? Do you envision that the universities will have sufficient computing power and the capacity to train the next generation? I just would love to get your reflections.
Yeah, it's a great question. I think in Gen AI, right, you see that the sort of dynamics of the field are really starting to stretch what's possible in academia, where the major breakthroughs in AI research are happening in these industry labs, and they're not publishing their results, right? I think today in biomedicine, a lot of breakthroughs are still happening with trainees, graduate students and postdocs working at the bench. But as these 2 fields start to merge more and more, it's possible that a lot of biomedical research starts to look a lot more like what we're seeing in AI training and research, right? So it's a big question for us. I think one of the things that ARC is trying to do is to provide a middle space where we have 30 PhD students on site at ARC. With our university partnerships, we have students on site doing their thesis, but we also have a private H100 cloud, right, that we use to train the EVO model and future versions, right? And so, providing the resources to unlock the talent, right, is something that, we were sort of uniquely able to do in this work.
There's been a lot of activity in this kind of founding institute spaces, and all the way up to like companies that look more like institutes, like Altos, but also, the group in Boston. And what do you think? Is this solely due to academic pressure, or is there a pull from things that you can do? Like, is it due to the pressure of just not being able to get enough from the traditional funding model? Or are there other reasons to be doing?
I think if you look historically, there's actually been lots of experimentation in how we do science as a country, right? With sort of the doubling of the NIH itself in the 60s and 70s, folks, used to just start labs directly out of graduate school. The system that sort of is fossilized today is not how it's always been, right? And so I think it's great to see lots of experimentation from an Arena, in Altos, and other places. And I think end of the day, all these places will need to figure out not just a 2-year or a 5-year roadmap, but what a 10 and 20-year roadmap looks like. I think we're geared to think through the sort of 30-plus year time frame where we can have various subs that get spun out when the time is right.
I'm fascinated by that image of the system being fossilized, and maybe you're not seeing what it actually looks like as a living organism. That's a really great image. Well, thank you, Patrick. This was fascinating.
Thanks for having me. Thanks, everybody.
And now, before I get off stage, I'd like to. This is actually it's quick, but this is one of my favorite parts of the day. Before we break for coffee, we're going to share. You're going to see it first time anywhere. A story will be going up, so you can read that too. Idea Pharma's 13th annual edition of its ranking of companies that do the best job in creating innovative medicines and bring them to market. Invention, as Mike will tell you, and innovation. Please welcome Mike Rhee, CEO at Idea Pharma.
Hey, so I realize I'm standing between you guys and coffee, so I will keep this short. I'm on for 5 minutes. One thing that always struck me, I'm a big fan of The Princess Bride, and if any of you remember that kind of key line in that movie, you keep using that word, but I don't think it means what you think it means. That was an idea that we kind of applied to innovation in our industry about 15 years ago. And the key question that we asked ourselves at that point was, well, does innovation always equal the same thing? Because we have an industry that talks about it all the time, but seems to barely understand the concept of innovation. And of course, innovation means the creation of value from an invention. So these two things pull apart that way. And we thought, well, what's the most interesting question in our industry? If you gave the same drug to two different companies at the beginning of phase 1, would it end up in the same place? And every time we've asked someone that question, no one's ever said, well, of course it will. It's going to end up in a different place. Like, well, why? What are those companies doing or not doing to those drugs that makes a difference to where those drugs eventually end up? So, one thing Matt knows about me is I'll continue to use music references. And I wrote a piece about the Beatles a little while ago and how non-obvious it was that the Beatles would get signed, because they went to many companies before that. And what happened after that, and they went from, their very early jingle pop songs to Tomorrow Never Knows within about 3 years. So this was non-obvious that A, they would get signed, and then B, they would become successful. And the other part that's really important here was that when you get to an album like Revolver, there were 40 different musicians made Revolver. So people think about these 4 guys, but the Beatles were many more than 4 guys when they made this stuff. And that applies to our industry as well. There are many more than 1 or 2 people involved in discovering and developing drugs. Typically, it's a team of about 100, 200, 300 people. And it's getting more and more expensive, as we saw in our analysis this year, up to about $5 or $6 billion per approved molecule. And this is a number that's getting bigger as we go, rather than smaller as we go. The number of the probability in phase 1 is not getting better. The probabilities in phase 2 and phase 3 are not getting better. So we're continuing to see problems stacking upon each other. So I mentioned the difference between invention and innovation, and it is possible to measure this stuff. You can see the same drug in 2 different companies going into very different places. But we reckoned that we look at innovation, revenue generated by new products. And a bet I had with someone about 5 years ago was, I bet that there would be many more blockbusters in the future. They bet the opposite, that there wouldn't be any blockbusters in the future. This was a common theme at that time. And of course, we're looking at a couple of years now. We've seen the biggest ever pharmaceutical products. Comirnaty, $30 billion a year. Who thought that was possible? Just 10 years ago that a pharmaceutical product could generate that kind of revenue. But Keytruda's getting close. So we're seeing this time and time again, that drugs are making more and more money for the people who do it well. But there aren't that many of them now. So invention is a lot more obvious, right? The people are putting all of our energy into invention, calling it innovation, but it is invention. And this is where we see these things start to pull apart. So, as Matt said, this is the first time anywhere anyone's seen this year's ranking. And there are new players who've made a very big difference. No one's surprised, I bet, in this room that Novo Nordisk have come top of the innovation index. And just an unbelievable breakthrough. But you look at the kind of length of time it's taken, from a Gila monster's saliva all the way through to the GLP-1s, making the difference they have. But again, I'll get back to that story, because this was a non-obvious thing to invest our money in, right? So Novo and Lilly, who you see here, were the 2 that saw the opportunity in this space that everyone was getting away from before that point. Now, on invention, what's interesting here is how little change we see in the invention ranking. So companies that have been good for a long time continue to be good at building pipelines. And J&J have historically, for the 13 or 14 years we've run this index, been at the top of this. And their investments in oncology and other places have really made a difference to them. But Novo Nordisk, no one's surprised that they're there. But GlaxoSmithKline, I suspect, is one that's surprised to many people. But we've seen them break through and begin to deliver in areas like oncology and other spaces. So it matters that they're there. Pfizer, I think, will be surprised. 9 approvals last year for Pfizer. The world's first and most expensive gene therapy approval. So Pfizer have done continually well, despite the pressures that their CEOs faced and share prices faced and a bunch of other things, even post-pandemic. But the fact they did so well during the pandemic is clearly a tribute to pay to them as well. The fact they were responsive enough and serendipitous enough to take those discoveries and do something with them clearly mattered as well. So, that's important. But one thing we do keep coming back to is serendipity. people use that word as if it means luck. Serendipity isn't the same as luck. Luck is seeing the thing in the first place. Serendipity is deciding what to do with it. And actually, that's the story of our process from discovery through R&D, to actually launching something that someone wants. So seeing what you just found is not an obvious exercise that most of the companies we work with, who get so excited about their pipelines, but forget that these have to be bought and paid for by payers and healthcare systems out in the world. So understanding the value of the gold that you've just found in your bath is really something very different here. And these case studies do keep happening, so we continue to look for the case studies out in the world. And we talked about Keytruda, cumulatively $100 billion into Keytruda. But look at this, back in the early days, it was second. Launched at the same time as Opdivo, but it was second, and there's about $10 billion difference in revenue in those first early years. But these are the only two that have gone on to make significant revenue. No one in this room or any room can tell me whether Bavencio or Tecentriq is a better or worse drug than Keytruda, but it's making nowhere near the money. So this question, if you gave the same drug to two different companies at the same time, would they become equally successful? Well, no. This happens now. This happens in the presence of all of the information that we all have available to us. We all have, the same levels of databases and, insight into what the drugs do. We still couldn't tell you, what the future curves of any of these drugs look like. We've seen Tecentriq start to tick up recently because of the investment there. The sad truth is most of these drugs, though, are underwater. They haven't repaid their R&D costs yet. That's going to be a significant issue for our industry as it continues to launch drugs that if you're third or fourth or fifth to market, you're going to be underwater all of your life. Most drugs that we launch don't make any money for the companies that launch them. So that remains a non-trivial problem for our industry as we begin to understand the causes of invention and innovation in particular. So this is the chart that will be out on STAT and our white papers today. And, you begin to see some interesting things. For the first time, you've got a Chinese company, definitely investing in discovery and development. And they're doing pretty well. They're not just, cutting and pasting from what they've seen before. The companies that we've seen do well have done well consistently. So, excellence is what you do consistently. There are some companies, I'm afraid, Derek, Novartis has begun to sort of drop down here. A few of the larger companies have begun to fail at the task of launching drugs. They've forgotten that. That's a discipline that we need to be good at, launching and making money from our drugs. But, we've seen Novo Nordisk, who really have only focused on one area, do very well in that area. Not so much in terms of the breadth of their pipeline, though. And other companies that have huge pipelines really waiting to make a difference to the marketed world. And does it matter? To come back to that first question, this is a subcut of what we look at in the white paper. This is called the freshness index. And this chart really shows how much of last year's revenue came from drugs you launched in the last 3 or 5 years. Now, if you look at this chart, you'll see how many companies that we know as everyday companies are making less than 5 or 10% of their revenues from new drugs, 5-year-old drugs. We'll go all the way halfway up the table until we get to someone breaking through that 10% barrier. Now, if you're making all of your money from old drugs, those are drugs that are creating the issue that we're all facing with the IRA and a bunch of other things where, we're going to rely on pumping those old drugs as hard as we can, for as long as we can, to pay for pipelines which aren't paying for themselves these days. So does the industry have a sustainability issue? Maybe, if it continues down this path. And the companies that you see at the top here are ones with only 1 or 2 drugs launched recently, so of course they're going to do better. But, Pfizer, AbbVie, Novo Nordisk, Lilly, these are non-small companies that are beginning to make a very big difference to, how they play this game as they go forward. So, this is a kind of revealing metric. Most of our companies are below water most of the time that they're launching, and the number of drugs that do return their investment is declining. So, we'll continue with the message that a kind of serendipitous scientific engine with a strong commercial engine, one that delivers commercially successful, insightful drugs to market, gets them through payers, gets them into the hands of patients. That's not a trivial exercise, and it's one that our companies in many cases, do ignore. They focus on the invention side, but aren't focusing hard enough on the innovation side of the metric. So I think that was my 5 minutes, Matt. Thank you.
Thank you so much, Mike. And with that, we're at our first coffee break. Right outside this room, you'll find snacks, coffee, and tea, and also our social media corner. If you want to go over there, they're taking videos of people. If you are interested in TikToking, go see Alexander. Please check out our sponsor and staff booths as well. Enjoy. There are Pop-Tarts. I want one. We'll resume programming here at about 11:05. Thank you very much.
with a lot of serious effort to try to do something better. It's going to be a lot of work. But that to me is what accounted for that political dynamic, which we also saw to some extent here, and we've seen to some extent, up in places like Seattle too.
And I think something that I jump in and say too is it's like really a shame is that I think universally both policymakers and people in academia across industries, people feel like the war on drugs was a failure, that it led to mass incarceration of people of color, disrupting communities, and it just didn't work. I think we're still seeing that people who leave jail, there's a study out of Boston, they're overdosing over 20 times the rate of the general population, like going back to using. The overdose death rate in carceral settings is increased massively, over hundreds of % between 2011 and 18. And so I think the criminal approach or the punitive approach to treating addiction like a criminal problem rather than a medical problem, we've like lived that part of history and we've done it. And so I think the hard part as people that work in this industry to see is that conflation of harm reduction equals compassion and medical problem, and that's not working. So let's go back to a criminal approach. And I think that that's really not.
But we seem to have a hard time treating things as dials. Instead it's, well, we got two choices. You can have a carceral, racist war on drugs, or a free-for-all and you can't do anything. And I think the challenge is, addiction is a real disease. It is a health problem. And people also do things when they're addicted and when they're on drugs that harm others. And people who don't use drugs are part of our city, our country too. And so we have to both provide that compassionate care, but also say, of course you don't like violence in your home. Of course you want to be able to walk down the street. Both those things are true, and we seem to have trouble saying that at the same time. It's got to be, it's got to be just punishment, all carrots, all sticks, and we can't seem to.
Totally, and I'm curious what Bron thinks, but I think that something I hear from my patients every week, like these are people that are using drugs, that are living in the Tenderloin, like nobody's happy with the state of affairs. Like my patients are like me, like all of us, are saying like, I want a healthy community that feels safe. Like that's part of facilitating their recovery. So nobody wants this. And I think like Bron said, or Keith or both of you, like to say, it's harm reduction's fault that sort of a multifactorial loop of like the COVID pandemic and all of its economic instability and housing crisis accentuating over years and income inequality, et cetera, is all harm reduction's fault is not quite right when we know that harm reduction leads people to treatment, like 5 times more likely to enter treatment if they engage. So it's,
Then we get to the point of like behavior change, right? We're talking with folks who have been doing this behavior for so long and things are not going to happen overnight. Like, why don't you just get clean? Well, that sounds good, but in reality, let's think about our own behavior change of when your doctor said, don't eat all those 5 donuts, stop drinking 2 cups of coffee, stop smoking all those cigarettes, right? Like think about our own individual behavior change where something we were doing was harmful and someone's telling me I need to stop it. Like I only had 1 cup of coffee when I should be on 2 right now. So I was like, I don't want to be too wired up for this panel, so I'm going to have 1 cup of coffee, but I had to make a conscious decision about that, right? And which hat I was going to wear, right? Because, we're part of the hat club here. But behavior change is hard, and it's about meeting people where they're at within that behavior change. We have a program called the East Bay MAT expansion where, yes, as we're doing syringe access and overdose prevention, it's like having open dialogue with people with lived experience, saying, hey, what's your relationship with your drugs? What's great about your drug use? But what's also effed up about it? And what do you want to do? Because today is not the day. You just got some drugs in your hand. You just got some sterile syringes. You're about to go shoot dope right now. Let's talk about how you're going to do that as safe as possible. Did you test your stuff for fentanyl? Are you using with a friend? And then maybe a month later, you're like, I'm tired of this. My veins are like tore up. I'm getting abscesses. But now I have this rapport with you. You didn't judge me when I was in here injecting. Now I'm ready to get on Suboxone or Butte. We've created this relationship with people with lived experience who are not going to judge you, turn their nose up at you when you were severe in your addiction, and now you're ready to change that behavior. So it's really about addressing that behavior change is hard.
And Suboxone, for those who don't know, is a common medication used to treat opioid addiction that can hopefully quell withdrawal symptoms and help people, stop using, fentanyl they're buying on the street without experiencing really, really awful withdrawal. Keith, I'm curious for your reaction to that, because you've written that, in your view, destigmatizing drug use, the way some corners of the harm reduction world have attempted to, has been, I think in your words, a profound mistake. So how does the scenario Bronze just laid out play into your view of, whether drug use, whether there's utility to stigmatizing using illicit fentanyl, or whether there's utility to, as Bronze says, meeting people where they're at?
Yeah, everything Bronze just said, I think is great, and I think that work is great. The point that piece we're talking about, first of all, we're going to make some things different. We want to have compassion for people who are addicted, not make people ashamed of being addicted. We certainly don't want to make seeking help shameful. And at the same time, fentanyl use per se is a bad, dangerous thing, and want to discourage people from doing it. And I think actually that is broadly agreed, even if people like ideological say, no, that's judgmental and all that. But if you just think of really simple, if your 16-year-old came home and said, I've got two friends, one friend wants to watch a football game, one friend wants to use fentanyl, which, you wouldn't say, well, 6 of one, half dozen of the other, no big deal. You would say, no, that's really dangerous. Don't do that. Please don't do that. And please tell your friends not to do that. And that is just good health advice. And so and we want to do that because there's lots of bad choices we could all make, but we don't make them because it never even gets to the point that we think about making them. We just say, that's just not the kind of thing I would do, period. And we do that in part through stigma. We do that by saying this is right and this is wrong. And if you're skeptical of this, I'll just give you two behaviors that were not stigmatized at all when I was a kid, and they're stigmatized now. Driving drunk and hitting your wife. Those were subjects of jokes when I was a kid. I'm 58 years old. They're both now way more stigmatized, and boy, am I glad that people have the sense that that is wrong. It is not funny to drive drunk. It is not funny to hit your wife. It's wrong. And that is how we create guardrails and have a society together. And so we have to have some of that around drugs.
We have an audience question in a sec. I want to let Aisha respond first, though.
Yeah, I think that Keith makes a great point that primary prevention is important, that we want as few young people and new people using drugs that may lead to an addiction. Where I'd push back is that I don't think stigma is good for any medical problems. I can't think of whether it's addiction, depression, needing to lose weight, whatever it is. I think HIV, my area of interest, I think is like a beautiful example of harm, of really a victory of harm reduction. We had, in the 80s, 90s, the AIDS epidemic in this country was an infectious disease that was a terminal illness that was associated with an incredibly crushing amount of stigma related to sexual behavior, drug use, et cetera. And over the last few decades, with, really in large part due to people living with HIV and harm reductionists fighting against that stigma and creating a broad coalition with industry, academia, public health, government, et cetera, really partnered to create treatment options, to disseminate treatment options, make them accessible, and incorporate harm reduction using principles of destigmatization, having people out of the shadows and into care. And that's been a profound victory. Like, we've taken something from a terminal illness to a chronic disease for most people. And that's phenomenal. And I think that a model that really hits home for me as I see people who both use drugs and or have HIV. And I think that we also see data that people who inject drugs that are sort of surveyed behaviorally, over 50% of those in San Francisco described feeling discriminated against by a healthcare provider and delaying seeking care because of that. And that delay in seeking care for an abscess or their HIV that turns into AIDS or hepatitis not only leads to increased likelihood that that person dies, but increased costs, I think is just bad for our whole system. So what
I would say about HIV is Stigmatizing people who had HIV was, terrible, awful. But stigma was part of the success, and one of the things we stigmatized was unsafe sexual behavior. And we're telling people you should wear a condom, you should get consent, you should be careful. That is also, that's telling people some things are right and some wrong. So,
and that's what I think. I agree. The parallel is I don't think that telling people they're a bad person or like someone that hits their wife because they use drugs or have an addiction.
You're not saying you're a bad person. You say that's not a behavior you want to do.
I think that I really just feel clinically when you think about any relationship you have with your doctor. Like the way that I move forward with my patients is trust and them feeling like they can open up to me, and together we make that positive change. And I think to feel like shame and stigma again have been really associated with poor outcomes in both HIV and addiction.
Well, speaking as a parent of adolescents, a slightly different view is that you can tell somebody, I really care about you, and you did something wrong. You're a good person, but you made a mistake. And that it's not actually loving to say, no, that wasn't a mistake, you can just keep doing that. That's part of how I give information about how to get along well in life and could be done in a loving way. So.
There's a lot to come back to here. Let's go to an audience question.
We have an audience question from Nathan Diesel, who is also wearing a hat.
I'm a member of the Harm Reduction Hat Club. I'd like to ask you to bring it back locally. You mentioned the Tenderloin. I'm wondering if you can share a story of success, how harm reduction has improved life in the Tenderloin, and actually what you think it would take to really clean it up so that it's not so messy.
Aisha?
Yeah.
For whoever.
Anyone. I think one story that comes to mind, I help run a status-neutral clinic that's low-barrier services for people who use drugs for HIV prevention, treatment, hepatitis, et cetera. And I think that I saw a patient a couple of months ago that comes to mind as someone who'd been connected with me through street medicine services, who was interested in Hep C treatment only. Was using opioids, addicted to fentanyl, not ready to engage with methadone or buprenorphine, are sort of two most potent treatment options for opioid use disorder. And from coming into clinic, sort of meeting warm faces and spaces and feeling welcomed for the first time, which he had said ever in his life, accessing medical care, and like coming in weekly and picking up meds from us. It, like Brahms described, is this like process of trust and relationship development where people are like, you know what, actually, I'm just using because I'm going to be sick. I'm going to be dope sick if I don't. It feels like I have the flu and being thrown off a cliff when don't have access. So, but I don't trust that whatever you're offering, whatever you're selling is going to work. I had a bad experience with Suboxone or whatever it is. But so slowly over time, they were open to trying methadone. And that person is now successfully connected to treatment at the methadone clinic at San Francisco General, and unfortunately still experiencing homelessness, but has their Hep C treated. And I think is an example of that's a really common story in harm reduction of how that access to sort of non-judgmental care can lead to treatment. And then I think to your other question, which is a really tough one, which I'm very curious to hear everyone's opinions on, is that I'd say, again, like taking lessons learned from the HIV example. Like I think that if we want to relive history, let's not relive the war on drugs history, let's relive the HIV transition history, and really like come together and create sort of broad coalitions in like, we need a research pipeline for addictions that don't have fantastic medication treatments like stimulant use disorder. Like, can we use generative AI? Will someone here help us? And we need, methadone and buprenorphine reduce death by 50%. Like, they're phenomenal. Why aren't they everywhere? Like, we need to scale up and out. We need harm reduction, more places so people feel welcome, and housing and access to, food, employment, things like that. So that's a tall order, I realize, but.
I'm going to build on that, a different sort of way of looking at it. I volunteer in the Tenderloin at something called St. Anthony's Foundation. And feeding people, without judgment, they would not call it, this is harm reduction, but I think it's the first thing is you have this need right now.
Basic need.
And I'm going to I'm going to take care of you, and I'm not going to ask a thing of you. Now, I can't prove it, but I will bet you money that there are people who came just hungry, maybe for a long time, and eventually struck up a conversation and then got engaged with, some of St. Anthony's services for mental health, for addiction, for housing. But it started with that sense of come into my heart and I will hold you close.
I love that.
We're a little low on time, so we'll close with an audience question if we have a moment for it. Two things I want to hit on before we're done. We've talked a little about law enforcement, and I don't think we've talked yet about compulsory treatment. So, Bronze, maybe you can start. What should the role of law enforcement actually be if it's not the way law enforcement was behaving in 2021 in the Tenderloin, but it's obviously not a full-on return to the harms of the war on drugs? What should that look like? And also, what should be the role, if any, for a legally mandated, maybe law enforcement mandated drug treatment?
Oh, you want me to go in deep now? Say, listen, I do
2
not
minutes
have the
too,
answer.
yeah.
Oh, in 2 minutes. Okay. Ooh, let me just get straight to the point. No. Law enforcement need to do what is within their job. They're not mental health therapists. They're there to, I guess, mediate the most severe circumstances. Someone's got a gun to somebody's head, right? They have a thing called macro in Oakland. It's an alternative to calling the police. So they come and they kind of assess the situation. If this is nothing life-threatening, the police don't need to be here. They might just need to calm somebody down, give some resources, do some other things. Now, if there's a gun and there's a situation and somebody's life is threatened, then that's when it is. But in New York, what they're doing is they're actually working with their law enforcement. And Sam might quote me. Sam, if you see this, Sam is the executive director of On Point, the only authorized safer consumption space in the United States of America right now. And they're working with law enforcement. And he's like, that's so profound because everybody assumes, don't mess with the police, because when police show up, sometimes people die, and a lot of the times it's people of color and black folks are dying, right? And so it's about finding that medium to work with the law enforcement, see where they need to intervene, see where they do not need to intervene, and then access the other resources that are available. I don't know if they have a macro in San Francisco. I'm very Oakland bound. I grew up in the city and in Oakland, so I'm familiar with the Tenderloin, how it looks, and I'm always just kind of like, why are they not cutting the checks? There's so many what we call no shit science things that folks can do to clean it up and offer more resources. But the first thing starts with access to mental health services. Why is a person even on drugs in the first place? What is the trauma that they were dealing with to have them in this chaotic stage of use that it results in how the Tenderloin is looking? Maybe they need to do a pilot project, a demonstration project, a community survey to be like, what's your quality of life look like? You're living on the side of the road right here. What is it like for you?
So for that person on the side of the road, very quick last words, Aisha and Keith, compulsory treatment, law enforcement, what needs to look different, what shouldn't look different that's currently on the table?
Yeah, I'll say real fast, I was an opponent of Prop F because I don't think compulsory treatment works. We don't have the evidence that it does. Massachusetts tried higher overdose rates. And the big problem, I think it takes away the focus from 800 people died from overdose last year, and we don't have enough treatment for the people who want it. So 30% of in a UCSF large behavioral health or survey of homelessness, people experiencing homelessness, 30% of people experiencing homelessness that use drugs wanted to access treatment and could not. That's unacceptable, So why are we focusing on compulsory treatment when we really need to provide enough treatment for all?
Keith, last word.
I oppose Prop F. There are times, though, when you need to intervene because a person is not in a fit state to make their own judgment. And the most obvious one is in an overdose. Person can't consent because they're unconscious. And we say, well, I'm just going to make a judgment that you're not in a fit state to do that. And I think everybody agrees with that. And then it's just a question of how far out do you put that? If someone's standing in traffic and they're high on meth and you think they might get hit by a car, is it okay to go grab them, or is that a violation of their rights? And we're trying to figure out where that is. And I think sometimes it gets a little too polarized that no one believes that should ever happen. But I think we all believe it. It's just how far out until we get to the point where we're saying now it's too much of an invasion of rights versus a protection of their rights.
Well, to be continued. That's all we've got time for. But thank you so much for the conversation.
Thank you, man.
Thank you, everyone, for being here.
That's good fun. Good fun.
Please welcome to the stage Venrock partner Dr. Bob Kocher, and to moderate Stat Bay Area correspondent Mohana Ravindranath.
I was a proper doctor, and my parents used to be really proud of me. I was at Dana-Farber and on the path to be a professor at Harvard, and that's like good. I don't know, seemed pretty good. And midway through that, when you work inside of a hospital, you just discover like that these things are like chaos and not managed as carefully as you would expect, and that the patient care like happens sort of through heroic actions by the nurses and people, that it just doesn't work right. And so I really wanted to learn how to run a teaching hospital. So I went to the person running the teaching hospital, at that time, a person named Jim Mongan, and said, Jim, how could I get your job? And he looked at me with this look of bemusement and shock of like, who are you, young person? Like, what are you like? But you have such hubris. And he said I had to go get business training. And so he said to go to HBS. My wife then said I couldn't take out more debt, so I didn't. I went to McKinsey instead to learn business stuff, and I worked with hospitals for a bunch of years. And as I learned more about hospitals, I realized that there's this entanglement of incentives and how they're paid that work against them always doing what you'd hope that the right thing. There's remarkable heterogeneity of everything they do, that nurses and doctors don't like being told what to do, that patients don't match a pathway quite right. Like, we don't just have pneumonia. You have pneumonia with diabetes or pneumonia with Alzheimer's. Like, they're multidimensional. And so running a hospital ends up being really hard to do, and you have all this labor and no margins. You can't and you have no room to wiggle. And so I spent the rest of my life trying to figure out how to untangle the incentives of healthcare to try to align them better, to try to incent better quality, to try to reward productivity. But I also have this now humble, healthy respect for running a hospital is really hard. And whenever you tell a doctor to change something, they say no, and then they say it's going to harm somebody somehow. And you don't want to do that, so you're reluctant to change it. And so hospitals have remained remarkably unchanging because we're scared of hurting people. And you learn that with experience, that you can't just change the weaning protocol on the ventilators. And so I think it'll be hard for them. I think that they're going to arrive and then realize that it's a lot more complex, and you need to be a lot more careful. And you can't break things. You have to be really careful. And then there's a lot of costs that are incumbent, and you have to get people to cooperate. I think they're going to be really skeptical. So I think it's going to be very, very hard.
Do you think that the ownership structure that they're proposing, and the deal is not closed, does that place any sort of undue incentive upon the clinicians to adopt technology, even if they're not comfortable with it?
I think it creates lots of tension, because I think the presumption that GC will have is that they're going to adopt all the technology, and you'll have this sort of showplace of how it could work together. But if you're a clinician, you're going to be scared that it's not going to work perfectly at first, and you're going to be reluctant. Also, it's hard to learn new stuff. I mean, we all should learn how to learn, but it's a lot of workflow change. And when you're a clinician, you're typically seeing a lot of patients a day, and you're kind of tired. And so having them say, let's take an hour more and teach you how to use the new thing, it's going to take a lot of, it's not going to, people won't want to do it. And so they're going to have a hard time motivating. And these workforces tend to be, often are unionized and often sort of not used to being managed. So I think it's going to be a hard thing.
Yeah. Looks like we have a question back here.
We do. We have one from Peter Marshall from Decoy Therapeutics. Sure.
Sorry, this question is about 5 minutes out of date, but I think it applies to what you were just saying. It struck me that your two worst pitch ideas were both oriented around trying to solve the so-called epidemic of loneliness with software, which sounds like a terrible idea. What other areas in healthcare, or would it also be a terrible idea to use software, or where is it dangerous? Where do you need to sort of think about the downsides of trying to solve problems with software and AI in healthcare and health tech? Thanks.
There's some of the remote monitoring technology with the AI, I think, have a bunch of risk. Because it's advising patients to make changes to their medicines or lifestyles in ways that may be imperfect. Sometimes your lab values are abnormal not because of diabetes, but because you have an infection, let's say. And so having these things be fully automated, I think, creates some risk for patients. In the area of cancer care, where I think there's a lot of opportunity to have technology, AI, and large language models and ML, everything, improve genetic interpretation, there's still a lot of unknown things here. So I think the biology is not caught up to the computers. And so I think there's a lot of chances for it to make mistakes there too. Today, the AI works best for things like pathology slide reading, because it never gets tired, it never skips a cell. It's quite good at radiology with radiologists overseeing it. It's good for dermatology, where, like mine, for me, rashes are harder to interpret than for the AI. So it has some really good uses too. But I worry that when it's operating on, where it's giving patients suggestions with biometric data, that it won't always understand if the data is actually the right data.
Anna, we have a question back here from Sophia.
Hi. Ventures had a shaky couple of years, especially in digital health, kind of after the peak of 2021. I'm curious your perspective on ideas, possibilities that you're excited about, but don't think that venture is the right financial vehicle to make it a reality or bring it into the world.
Can you elaborate a little bit more? Like when you say ventures, what types of things are you thinking of?
Sure. Venture is a really expensive form of capital, and the returns it has to generate to be an appropriate financial vehicle have to be large. And I think there's a lot of ideas that maybe are good that the world needs, but can't generate the returns that a venture capitalist like yourself needs to see in order to invest in. So I'm curious if there's things you're seeing in the world that you're getting pitched to, that you're excited about, but are ultimately deciding, actually this just isn't a good fit for this type of capital, but I'm encouraged by X, Y, or Z.
Yeah, good question. I think brick and mortar businesses are hard for venture capital to invest in because they typically take a bunch of time to sort of create profitability and can't grow at the rates that you would hope for. So that's one area that's, I'd say, overall hard. Other areas, though, that I wish that there were more innovation are both related to, I'd say, geriatrics and children. These markets have really large unmet needs. So adolescent health is an area where it's hard to find expert clinicians. It's hard to get appointments. Particularly adolescent behavioral health is a tough spot. Getting neuropsych testing for children, autism care in children that need help. There's just not much supply. It's hard to make these businesses sort of dynamically growing and very tech-enabled, but I think that there's really big unmet needs there. Similarly for old people, delirium, dementia, safety at home, good home care and support. Also, like proper use of medications particularly for anxiety and depression. It's very hard to get good care, hard to get access. There's not many people trained in it, and obviously a big growing population. But these businesses also don't lend themselves to technology. They're hard. They're very local, and so those are spots where I wish there was more stuff. Medicaid's another area generally that's hard because the reimbursements are so low that it's just hard to build models that can work well. And in Medicaid, there's been, I think, 13 million people who've lost Medicaid coverage now in the last year through redeterminations. And so you have turnover that's so high that just when you get the patients like on the right track, they lose coverage. And so that's been a really hard area too. So.
Where should the people building solutions for those kinds of problems go, if not venture?
Yeah, angel investors or, foundations, local nonprofits. Sometimes you can get, local health systems who have a mission to support population health, to support these things, are some ideas, but it's hard.
Mohana, we have another audience question if we have time.
Hi, thanks for taking the question. This is Will Tran. Looping back to the conversations this morning about AI tools in drug discovery, I wanted to ask, do you think that AI tools for drug discovery, will those be developed in-house by pharmaceutical companies, or will there be third-party software providers that can specialize in that?
It's a great question. It's an area outside of my area of expertise, so I don't have, I think, a better view than you. I just hope that they're created and that they work. I think we have such an expensive and hard process to bring to invent new drugs and bring them to market that I'm very hopeful. I do not know, though, who's better equipped to invent the tools.
Nick earlier had asked Peter Lee from Microsoft about the potential for generative AI to be used in emergency medicine, and I thought that was an interesting question. Given your sort of medical background, do you see there being a role for maybe some kind of AI assistant or something?
I don't think generative AI for emergency care is what I would hope for. I'd like to have AI that's not generating new ideas, but actually give me the right ones. I think machine learning maybe has a better role. As a person that's done many emergency room shifts, most of the time you don't need a big computer to tell you that the person who has the cut needs to have stitches or that the pink eye is pink eye. So it's really for, I think, trauma where you're trying to like react very quickly, having a reminder that I didn't skip a step will be valuable. And I think that's where these tools can be helpful, is they're saying, wait a minute, did you check this? Or you haven't reviewed that. The other thing in the emergency room, if you've ever been to one, there's all these patients sort of waiting, and then the one doctor's doing something over there. Is having it check results of labs and imaging that's coming back to give you a sense of, hey, this one needs your attention, because it's just hoping, today it has to be me remembering to go check on the computer or having somebody grab me and tell me. So there's some spots where it can help, but I don't think it's going to be like a game changer.
Sure. Well, we only have a couple minutes left. I want to ask you a little bit about Washington.
Yeah.
You have the tech experience, the health experience, and sort of the Washington regulatory side as well.
That's where we first met. You were writing the Washington newsletter.
Right.
Yeah.
Do you think that Washington is really equipped to be able to regulate health AI in a way that doesn't inhibit innovation but also protects patients?
No. But that's not, you wanted a better answer than that. I've been speaking with regulators at the Senate and at FDA and CMS, actually yesterday at CMS. I do think that they have a humility and that they have a desire to not impose regulations right now on AI, because they don't know how to do it in a way that protects patients, that rewards innovation, that's going to work right. And I think they're actually more thinking about AI in a much broader sense of how do we think about AI across all use cases, what are the basic protections that we should have for Americans before they jump into like the more micro version of what you do for healthcare per se. I think we're not close to having regulations come down that's going to be different than the current regulations we have on regulated software products.
How do you think Washington could get better at this, if at all? And maybe the tech
well,
industry
that's like a philosophical, political question. Like right now, the Supreme Court's trying to push the administrative state back to Congress, saying Congress needs to legislate exactly what we should do, which I think is a bad idea, because Congress couldn't possibly have the expertise to do this today in the current way we structure Congress. And so if we're going to do that, I think Congress has to actually get much larger staffs and have expertise in healthcare and energy and in all these areas, if they're going to write legislation that's that specific. Today, all legislation written by Democrats and Republicans have big sections saying, Secretary of some agency shall do this. And then the agency figures it out. And what we're seeing with the Supreme Court right now is challenges to agency authority, pushing it back to Congress, saying if Congress doesn't say exactly what it's going to do, you can't make it up. So if that's going to be the answer, we have to then have Congress have a lot more expertise. Like today we have a Congressional Research Service that does really good work, but it's like a very small group of people. That would have to be much larger, I think. And Congress would then have to write much longer bills. And you would hear about 10,000-page legislation, not 2,000 pages. It would have to be a lot more detailed.
Do you think more people from this industry should be going to Washington to educate people? What's the solution then?
I mean, please go run for Congress and make it better. We could do better. But yes, we need more participation in government, I think. We need to have people who bring expertise to bring it to government. Government needs the help. I hope so.
Then maybe you can go back to Washington then.
Maybe. So,
well, that's all the time we have. Thank you so much.
Thank you so much.
This sponsored conversation with the Chan Zuckerberg Initiative, please welcome to the stage Vice President of Science Technology, Patricia Brennan, and Head of AI for Science, Theophanis Karaletsos. And to moderate, Stat General Assignment Reporter and Associate Editorial Director of Events, Nicholas St. Fleur.
We have had a packed morning about AI. My goodness, we were learning about AI and loneliness for a second there. We were learning about AI and drug discovery. And I wanted to talk to you both a little bit about AI at CZI. So tell me, what are you all doing at CZI at the intersection of AI and biomedical sciences?
Sure, I'll start.
Perfect.
Thanks, Nick. It's great to be here. It's wonderful listening to the talk so far. So at CZI, like everybody right now, we're very engaged and excited and optimistic about what AI is showing us it can do at the intersection of biology and technology. everything we do at CZI is really grounded in our long-term mission to cure, prevent, and manage all disease. And so when we think about AI right now, we're really focused on bringing together some key components of what we believe will be needed to get us to that mission. One is around compute. We heard a little bit about this earlier this morning, but what we know is that in many cases, researchers today are limited in their ambition because of lack of access to necessary compute. There's great strides being made on the commercial side and the large companies, and so we want to, if you will, reduce that barrier to access. Second is around data. We have a long history at CZI already in aggregating, integrating, and making data available for model development. And so we're going to continue to do that and really expand some of our efforts in that area and work with the community. And then the third is beginning to actually build an AI research team within CZI that will drive some of those efforts. And there we have a vision around building what we call a virtual cell, or this idea that we can aggregate knowledge and integrate models so that not just computational biologists, but all researchers can really drive insights faster and do analysis at a greater pace.
I definitely want to talk a bit more about the virtual cells, but going to Theo. Theo, you're newer to the company, you're newer to CZI. Tell us a little bit about what you're hoping to kind of bring in this role and what kind of inspired you to take on this work over at CZI.
Interesting. So what inspired me to come to CZI in particular is CZI is positioned as a nonprofit, which means we're able to do open science. We can share everything we do, and we're uniquely positioned to share all of our work together with the scientific community, platformize this, and really try to bring about a broader change in how people think about digital biology. And what inspired me to come is clearly to be able to do these things in the open and have that influence on the community widely.
So tell us a little bit more about what CZI is doing like right now with AI. What's really getting you excited or jazzed about that?
So the way to maybe convey that is we're planning this virtual cell work, right? And it's very early. We just started working on some aspects of this work, and maybe the easiest way to get into that is to explain a little bit what we mean by virtual cells.
What do you mean by virtual cells?
And think about virtual cells in the following way. They're going to be machine-learned simulators of cells and their complex behavior under different conditions, in context of other cells, and so on. You can think of them as machine learning systems that will integrate a lot of knowledge across cell biology. And when that works, it will have influence, broad influence, to be able to have an increasing knowledge of these complex emerging behaviors that we will see in these machines to be used across, biomedical research, various things. So how will these things do that? Virtual cells will model all cell types, right? They will try to understand cells by themselves and cells within tissues in that context. They will give us a broad understanding of how cells will behave across perturbation. They will integrate the different biological entities that we can think about, such as genomes and transcriptomes and proteomes, understand their spatiotemporal relationships and understand their dynamics, such that we can try to simulate various outcomes there. So there's a lot to build.
And Patricia, it looks like you wanted to add to that. Tell us a little bit more about how you feel these virtual cell models will add to our understanding or to this field of discovery.
So I think, if you think about it in some context, like how being able to predict in the clinical setting, for example, of how a disease might progress even before that has happened, or what actually the implications will be of a genetic variation. So I think there are some applications all the way across from basic research in terms of accelerating that, enabling hypothesis generation, all the way through to physician or clinician applications.
And what else do you feel is the potential of AI as you both see it, as you both are using it and working with it over there at CZI? Is there anything else that's really, keeping you guys excited or on your toes?
So I'm extremely excited and optimistic at we're at this very interesting moment where you can see work that's been happening for the last 10, 15, 20 years is really beginning to pay off and beginning to show more than promise and potential, but actually beginning to show results. So, for me, as we think about virtual cell and really aggregating knowledge that's out there, it's about making that accessible to the broadest set of users. And then the second piece is around changing and accelerating how science and basic research is done, so that the computational and the biology really is coming together through systems, through platforms.
And what about yourself, Theo?
I completely agree with the points Patricia said, and I will add the point that I find extremely exciting is this: how will people use this? How will researchers use this? And we're in this wonderful moment in research and technology, really, where we can make it very easy. And I think when we have these complex systems that will abstract complex behaviors in cells and tissues, and we want them to be used for biomedical applications, we need to make it very natural for researchers to interact with them, to feel like research assistants, really. So imagine that if someone wants to ask a question, what will the effect of a mutation on the spatial-temporal trajectory of a patient be? You would like this virtual cell platform system to allow you to query data and run the models and aggregate results for you, suggest experiments for validation, and maybe suggest experiments to fill the gaps of their knowledge. But I think that's a very exciting vision to come together.
Patricia, you were talking a little bit, and thank you, a little bit about accessibility and how you're able to make it, I guess, more accessible in that respect. Could you elaborate a little bit about that? What is it about CZI that helps make all of this work, I guess, more accessible?
So one thing about CZI, we're enormously privileged as a not-for-profit, as a philanthropy, as a tech-oriented philanthropy, to be able to look at problems from the perspective of really how we can have a differentiated impact and maybe address aspects of a domain or a problem to either catalyze change and bring the community together in ways that may not naturally happen in a market kind of setting, and also to be able to provide researchers. So what the work that we're talking about today is really, we will be collaborating with the research community, and to be able to provide researchers with tools and capabilities that can accelerate their work, that allows them to spend less time on some of the things that they're doing today and get faster to insights and new discoveries.
And Theo, before we end off talking about like the future, are there any other collaborations that you want to share or talk about that really gets you excited about this kind of work? Patricia was talking a bit about why that's so exciting to her, the collaborative aspect.
Yeah, we do a variety of collaborative things with the community, right? We both collaborate with top academic labs on thinking about some modeling aspects together. We organize the community to think about joint efforts where we think about what are shared challenges we will have that we can all impact moving faster. And one aspect that I'm particularly excited by is, when we want to build large-scale machine learning models of complex things, the engine, really the gas actually for this, will be data. And no individual entity will be able to collect the right or sufficient data to do this. And we believe that in collaboration with the broader community, we can bring about the data sets that will be shared, that will be both diverse and representative for things.
That's important. And sticking with you, Theo, so what's next for CZI? What's on the horizon here?
Well, as I was saying, it's very early still for this vision. We have to build a lot of these components, and we're very excited to build, a transition where we start with the virtual cell models, the platform, engaging with the community to find the right ways in which we want to test and benchmark these things, and really talk with people about which demonstrations and which data sets do we really want to have together.
And Patricia, to end us off, what are you most looking forward to?
For me, it's about bringing tools and scientific discoveries to the broadest group of global users, so that they can, in turn, drive new discovery and new insights into mechanisms of disease and health.
Patricia, Theo, thank you both so much for your time, and thank you to CZI for your sponsorship.
Thank you.
Thanks, everyone.
Please welcome to the stage science integrity consultant, Dr. Elizabeth Bick, former analytical scientist, Dr. Scholtel David, and to moderate, Stat West Coast Biotech and Life Sciences reporter, Dr. Jonathan Wozen. thank you everybody for being here. I know we are the one thing standing between everybody and lunch, but I promise this will be a really fun, interesting conversation, and we're going to want you all to be part of it and to keep up some of the audience participation we've had earlier today. So thank you, Elizabeth. Thank you, Sholto, for being here. Thanks for being willing to talk about the work that you do as scientific sleuths. And I want to start off with actually a really big picture question. Why do you do this work? Why are you so passionate about it? Because just from conversations we've had in the past, it's tedious, it's time consuming to pour through hundreds, thousands of papers. You've sort of made a number of people quite annoyed. I think, Elizabeth, people have threatened to sue you on a few occasions. We talked about that. It's tough. So why is this something that you're each so passionate and so invested in? Maybe start with you.
I'm passionate about it because science papers contain data that other scientists build their work on. So I feel if there's an error or suspicions of misconduct in a paper, that we need to tell the world about it, because other people might waste a lot of time and money trying to replicate those results.
Yeah, I mean, I'm really interested in science. Obviously, I'm a scientist. People ask me quite often why I do this. I think it's fun, it's interesting. I care a lot about what's in papers. I like reading and understanding lots of different papers. Errors are just a very interesting way to see what's going on in science. I care a lot about animal experiments. This is something I look at a lot of papers which have animals. So when that goes wrong, that can really upset me. And yeah, I think it comes sort of naturally that being someone who's super interested in science, that I would go after this stuff. It is tedious, but I get a lot of pleasure from sending emails. I used to do Yahoo Answers quite obsessively, so this kind of structured approach to problems and interacting with people online is something I enjoy. So that's kind of important to me, that it is something I take some pleasure from.
Well, I remember, and also Schultz, I remember one of the things we talked about in a past interview. I think you said something that stuck with me, which was people often like to say that science is self-correcting, but the reality of that is sort of slow and messy and imperfect. So you sort of see yourself playing a role in that process.
Right. Yeah, I think that's often one of the first things people say when they talk about what is science. Well, it's a self-correcting process, but I'm sure Elizabeth's experienced this. It's actually very difficult to self-correct science, and people are quite resistant sometimes to those efforts. So yeah, I think adding some efforts to correct science is important. It's something we can, like anyone who's a scientist can do it. And I'm not an academic, I'm not at a university, so for me it's a good way to join in with science, right? I can still give people advice on their papers in Nature, even if they don't like it. I can still join in, so that's important to me as someone who's not at a university or doing much kind of science in labs at the moment.
Yeah. And as always, feel free to raise your hands with questions throughout the conversation. Maybe just another question from me. Can you each talk a little bit about how you actually do this? What is your approach for reviewing papers, identifying issues? And I think people would probably be interested to understand, how do you understand if something is a sort of innocent mistake? Negative controls may all look the same, positive controls may all look the same. If there's some sort of manipulative intent to deceive there, how do you go about assessing those things in your work? Maybe Elizabeth, start with you.
Yeah, so I look at photos in scientific papers, and not all scientific papers have photos, obviously. But photos are the data of the paper. They're proof that something happened. And I specifically look for duplications, and Sholto does too. We focus on these photos. Are two photos the same but representing different experiments? That could be an honest error, or it could be done intentionally. Do they overlap, or perhaps with a rotation or stretching or mirroring, things like that? Or do photos contain duplicated elements within a photo? So the same cell is visible 10 times. So the latter, photoshopping basically an image, there's always an intention to mislead there. But is that really misconduct? that is hard to tell. We just look at the photos and we can raise concerns. It's up to institutions and publishers to investigate these cases.
Yeah.
Yeah, you asked sort of two questions, a little bit about the process, and like Elizabeth, I do spend a lot of time looking at photos and other kinds of errors. I might look at molecular biology reagents like primers and make sure they have a sensible amplicon. And so I read a lot of different things in papers. I do tend to write much more about images these days, and that's partly because image comments are a bit faster to write and easier for everyone to understand. But when it comes to kind of differentiating between what is fraud, what's an innocent mistake, I think all mistakes are important. The thing I try and keep in my head when I'm reading a paper, if I find an error, is would this lose marks in an undergraduate project? And if that's true, then I don't think it should be in the scientific literature. So that's kind of the standard I'm working to. When it comes to kind of large-scale problems where the same person has made lots of the same kinds of mistakes, that's hard to understand from an innocent perspective. And sometimes you should be very careful about making accusations of fraud, but I think sometimes it may be important to call a spade a spade. I don't want to shy away from making an accusation if it feels obvious to me. Otherwise, we'll be speaking like lawyers all the time, and I don't want to do that.
We have a question in the back from Rita Redberg.
It has a lot of potential to do good, but also to create fraudulent data, fraudulent photos, fraudulent articles, and I'm wondering sort of how you see that going forward. And I mean, as certainly from a medical journal perspective, it's very scary because although we ask authors to say who contributed, people are not always forthcoming.
No, it's a great question, and it's absolutely frightening to me what AI can generate. Like, we can use it for a lot of good things. You can, for example, generate a pathology training set using AI that is, not tied to particular patients. But it can also generate a lot of unique photos that are not real experiments. And so I'm afraid this is already probably already has infiltrated the scientific literature. But it's very hard to tell these images apart from real photos. They look so real. And especially cells are much easier to generate a fake image of cells or histology than a photo of a human face. There we can still capture that perhaps the AI generated, put the nose in the wrong place or put too many fingers on a hand. But with the cell, it's much easier to fake a photo and fake an experiment. So I'm very worried about what it can do. And I feel that publishers are not putting enough effort into trying to deal with it. How are we going to find these fake photos?
Yeah, I remember, Elizabeth, something you said in an interview with my colleague Debbie Balthazar that really caught my eye was, I don't think I will be able to recognize a good AI-generated image anymore.
Absolutely, yes.
And for a lot of us in this room who sort of think of you as having the eagle eye, instinct to spot these things, that is kind of a terrifying thing.
Right, yeah.
Maybe, Sholto, to ask you on the flip side of this conversation about AI, I know you've used to some degree, software image twin, right, that relies on AI. And I think you had published a sort of a preprint form, a study where you compared, how efficient that software was at detecting things versus, you. So maybe you can sort of speak to what the sort of positive opportunity here in using AI.
Yeah, so Image Twin is a software that helps you find similar areas in scientific images. It's really powerful. It's very fast compared to doing it by eye, especially when it's making comparisons, and it can do things like compare the images in a paper to lots of previously published images in open access papers, so you can catch that kind of reuse that would be really hard to find manually. So yeah, there's opportunities here for AI to help ensure the integrity of scientific papers. Image Twin, it's not a kind of magic bullet in some ways, and certainly it can show you the similar areas. It can't tell you whether those are problems or not. It can show you that two images have appeared, but there's lots of reasons, good reasons, to have two similar images in a scientific paper. So there's still a lot of, having someone evaluate what Image Twin finds. It can't currently decipher whether something is good or bad. It just shows you the similar areas.
Yeah.
We have a question over here from Christy, Canada.
So expanding on that question of automated screening for potential errors. So what are the opportunities there, and who should bear that responsibility? Is that the journal? Is that the university? Is this a third party that, should we have a screening system? What are the options available, and what's reasonable to do?
Well, it takes the role probably of everyone. I mean, first of all, we don't want people to cheat, and we don't want people to make errors. So I guess the primary responsibility is with the authors. But we need to have safeguards in place to catch errors and to catch fraud. And this could happen at multiple levels. So some universities are starting to buy the software like Image Twin or Proofic to screen outgoing manuscripts just to catch potential errors. But a lot of publishers are also investing in having software like that to screen incoming manuscripts. So I think it will happen at many places, but of course the fraudsters, the real fraudsters, are going to find ways around it. I mean, there's many ways using AI perhaps to generate unique photos, and so it takes the village, it takes the role of everybody to be concerned about it and to put safeguards in place.
Derek Lowe has a question.
Yeah, I was curious. You may or may not be able to answer this because, after all, you're only two people. But do you see any trends in this? Are you able to see any trends? You would think that this would be going down as more people realize that folks are watching. But on the other hand, as you're saying, there are great tools that could make it go up. Which way do you think it's going?
I would say from my experience, I tend to look at different areas over time, like non-coding RNA, particularly in the last 5 years, has been a complete mess, really. There's so many poor quality papers, and I don't see any particular trend up or down, but I have quite a narrow focus on particular eras of types of papers, like Western blots in 2008 to 2015, a whole other kind of mess. So, I don't see things particularly going up or down, but I don't have a sense of it getting better personally. But I have quite a kind of narrow focus on different eras and different types of papers, and so that's my perspective.
I see a huge influx in the last 2-3 years of presumably ChatGPT generated papers that are very low quality with dozens of authors from dozens of different countries, presumably who all bought an authorship on these papers. So those are paper mill generated papers that add absolutely nothing to the scientific literature and might even sort of dilute it. And so I see a huge influx of those types of papers. And I'm just worried that it's only going to get worse because these papers are clearly nonsensical or clearly very low quality, and they still get accepted in PubMed indexed journals. So people are not paying attention to this.
Lots of questions, Jonathan. We have one from Nicole Van Groningen.
Hi, thank you. Yeah, I'm just, you talk about these fraudsters, and I wonder from a big picture perspective, the incentives that they're under to, publish or perish, because I'm assuming so many people don't go into this field thinking, yeah, I'm gonna make a error on these studies, right? Mm-hmm. And I'm personally, as a practicing physician, there's even more pressure in my field. Medical students are under increasing pressure to publish research articles to even get into residency. Stat wrote an opinion piece about this recently. So I just wonder if you could talk about kind of the incentives, how we may realign those. I know it's a little bit out of scope, but even it's kind of backing up the problem a little bit more upstream.
Absolutely, I completely agree. I think as we're focusing way too much on metrics, and for example, if a professor or somebody's hired for a tenure job or a faculty job at a university, people might look at who published the most papers, what are their citations, what are the impact factors, and those are all decent metrics, but they're also lazy metrics because they don't necessarily tell you which person is the better scientist. So I think as long as we focus too much on those metrics, we're going to have people game the metrics. We're going to have people, citing themselves or having their friends cite them or generating fake papers just to build up a resume. And so I think we need to think about other ways of how to define a good medical doctor how to define a good scientist, and that don't necessarily look at how many papers somebody published, but actually what is the impact of their science. And it's much harder to measure that, obviously, but yeah, we're focusing too much on those metrics, and that's going to have people more and more starting to cheat.
I just want to answer quickly as well, add something. I 100% agree that the kind of motivations, incentives that exist don't necessarily trend towards increasing quality. I'm a little bit of a, I don't like publish or perish, because I think a lot of scientists who get caught doing this are at no risk of perish, right? They are more towards the flourish end of things. And some people are being caught and then kind of point to publish or perish, but people can make better choices about how they do science, and sometimes it might mean a slightly less illustrious career. It might mean, taking a risk on not winning this particular grant or something. So I do understand that there are some scientists, maybe people that especially depend on visas, supporting families, but then there are some very, very senior scientists and academics who've been caught doing stuff that's really regrettable, and they're not at risk of perish. So, that's something I'd like to add.
We've got a question here.
Hi, Rick Pierce from Decoy Therapeutics, and I've enjoyed the reporting that you've done. Wall Street as the SEC, drug companies have to answer to ICER. Should there be an independent body funded by the journals themselves, who are actually publishing and have the responsibility to support a group like yourselves or others, but an independent body that would regulate and really be there as a watchdog? Because there is a lot of money for grants, but also from industry. I mean, some of the people you've pointed out.
Yes, I mean, we have already some of those bodies. We have the Office of Research Integrity in the US that oversees NIH-funded research, but they're heavily understaffed and heavily underfunded. Only a fraction of NIH money goes, to supervising that, and they also don't seem to have a lot of teeth or a lot of actual output. So there's very little, like Schulte already referred to, like there's very little consequences for people who are getting caught. There's very little independent research being done. So I absolutely agree. We need independent institutions that are independent from the universities, but also independent from the publishers, because those have obviously a lot of financial gain in publishing as many papers as possible. So they're definitely not an independent party in this, I would say.
If you had a scoring system like Dana-Farber had X number of papers that were false, you now drop down like the draft. You're not going to get anything more. That would definitely cause some people to look at the papers a lot more seriously at the top.
Right, well, that's the exception. There's a lot of institutions who try to keep these investigations really within their walls and don't give any output. They try to hide that misconduct happened in their institution. And so very often the outcome is that there was no misconduct found. And that's just hard to look at. You see all these Photoshop papers and you're like, how can this ever be the outcome? Because there was clearly somebody, falsifying the photos here. But the institutions don't want to admit that. And then there's just very little I can do. And people like us look like complete idiots because we raised our voices and the institution told us that there was nothing to worry about. And it's just maddening. And that is why I'm happy that, that now national news agencies and Stat News are giving attention to that. Because if we really want to work with the institutions or the publishers, nothing is going to change.
Jonathan, we have an audience question here, and then we also have one in the back from Rick Burke. So I'll start over here.
James Robinson at UC Berkeley. I was wondering if there's your perception. It seems to me that there's three levels of this. There's the individual fraudster. There is the paper mills, let's call it the commercialization of fraud. And then the third level is the geopolitical. A lot of these paper mills that are, in fact, in Russia, they're in Iran, they're in China. They're not randomly distributed. It's part. I was wondering whether you see this as moving into cyber crime, cyber warfare, and whether NATO and the place will have a role in this as this destabilizes parts of science that have biowarfare or other strategic implications.
I mean, I think you're right. first of all, that there is these differences in where certain types of paper come from, and you've named some of the offenders there. And you're also, I like your categorization of individual researchers and then these kind of for-profit activities and the fact that they come from specific countries. This can sometimes be a little hard to speak about. People feel uncomfortable, but Iran is a source of a large number of a certain type of problematic papers. I don't know if it's certainly a type of cybercrime, right? I don't know if it has strategic importance. It does seem true that there's potential for some areas of research to become so flooded with fraud, it becomes hard to know anything. And I think non-coding RNA research, I actually read recently a line in a paper from someone who was basically said it's hard to know much more about the function of this RNA because there's so much research fraud published on it. No one really knows what's true. And so, there is a large quantity, and it can certainly affect whole fields of research. I don't know if it amounts to something kind of even more nefarious. I can't tell you. But a couple of good points there, especially about the location of these papers, where they come from.
Mm-hmm. Question from Rick.
Hi, you both play such an important watchdog role, and it's kind of scary stuff because you're pointing the finger at as Sholto, you said, senior scientists, major institutions. I'm just curious about the kind of pushback you get from these big name people, and if you all could give an example of a person or institution that just didn't take this well and was difficult for you, and maybe to leaven it, like just what comes to mind first, and maybe to leaven it with someone, this was a big name person, but they really respected and responded in a grateful way to what we pointed out.
I have some stories. I criticized, so I'm a microbiologist by training, and I've criticized the work of the most published microbiologist in the world, who happens to live in France. And he published about hydroxychloroquine. It was one of the first. And so I criticized that paper. And then I found, then he criticized me just on the way I look, and that I'm a woman, and things like that. And then if people do that with me, I will dig deeper. And so I went over all his almost 3,000 papers and found several examples of problems. And other people joined me, but he threatened to sue me. He actually, it was just all, I was, how do you say? It was dismissed, but it was a scary time because, the work we do is completely unpaid. I'm being funded by Patreon, but there's nobody supporting our work. I would not be able to pay the legal bills. There's nobody behind me to do that, other than the full support of a lot of people on Twitter. A lot of people signed support letters for me. But it's a very scary situation, and I still will do this. I'm so convinced of the errors in these papers and the right that I have to call them out that I will keep on doing this, even if nobody funds me.
And just for the audience's benefit, his name, the researcher's name.
I'm not.
Okay.
I don't name.
I think the initials are DR.
Yeah.
Yes.
There we go.
Sounds like the right name.
I think for me, probably maybe surprising is that you can point the finger, and the biggest risk and the most annoying thing is that most of it is ignored, right? Most of it is ignored. That's probably the major thing that surprises people. I've been very surprised about big response about what happened with Dana-Farber and the fact that they decided to take some action. It's really the huge exception, right? I've written well over 2,500 comments about different papers. The email goes in a box when you do that, and people get alerted to it, and maybe authors tend to engage with that process between 10 and 15% of the time. So actually what is happening most of the time is that people just ignore it, and then if you are able to reach someone at an institution, they will often delay it to the point that it becomes very difficult to pursue, or also just ignore you or dismiss it, as Elizabeth mentioned. So I think the big headline for me is, rather than people fighting back against me, I haven't had much pushback really, to be honest. It's that they use a different kind of strategy, which is to ignore the situation and just sort of hope it goes away if they can for long enough. So that's a really important role for media that I think can help change things. And certainly, I don't think Dana-Farber would have flinched if it hadn't have started being published by media like Stat, and also at the student newspaper at Harvard as well.
So I have, if I could ask a quick question, Jonathan. Sorry, it's such a good panel, we're all jumping in. But how do you deal with the difference, though? It's very easy. It's Matt talking. It's very easy for me to DDRO. Well, look, hydroxychloroquine did nothing for COVID. We kind of wish nobody had suggested it. But some of these cases are cases where you have researchers who worked on important medicines, important drugs, some of the Dana-Farber cases in particular, multiple myeloma drugs that were really effective. And so something about the whole story hung together, yet you have these glaring examples of what may be errors, what may be fraud. How do you keep perspective across where a problem with an image fits into the whole scientific story?
I mean, do you want to answer?
Yeah, you'll go ahead.
Okay. I mean, on the one hand, I'm very comfortable to be blinkered and go paper by paper because I think each paper should stand on its own merits and be correct. When we talk about the Dana-Farber case and the fact that a lot of multiple myeloma drugs were developed and tested there, I think it's the case that actually, a lot of that innovation may have happened outside and then the clinical trials happened there. And I don't tend to look at too many clinical trials myself, but yeah, I mean, I understand that not every mistake is necessarily a fraud. Not every mistake undermines a paper, but I do think all papers should be correct in the end. And when it comes to kind of impact and getting things right, I think first we have to get things right, and then hopefully the good impact happens. And rather than kind of doing papers for the sake of impact and being right being a second thought, I think you can see how that quickly spirals, right? So I tend to just focus on making sure that, as far as I can, that everything in a paper is correct, and I hope from that will stem good things, right? And if you have it's a complicated question, though. Yeah.
Well, if I can maybe follow up with a question on the Dana-Farber case, you sort of published a blog post back in January, bringing a lot of issues to light with maybe 50 plus or 60 papers at this point from some of the top researchers. I think one of the things that you got a little bit of pushback on was how that was written, right? The tone of the piece. Specifically, I think the title was Dana-Farberification. And there was a line about, CEO Lori Glimcher saying, no doubt she had built her career on papers that include some impressive contributions to art, but perhaps not science. I know you don't get responses from a lot of the people you reach out to, and a lot of times they're dismissive or rude. Just wondering, how do you think about the right way to call a spade, and is there ever any worry about the tone undermining the sort of substance of the message?
It's an important question, and I understand that some people are not comfortable with the tone that I've used. And the first thing to say is that I'm writing for the For Better Science audience, which is a particular group of researchers who post very regularly to PubPeer. And so this, the blog post is written for that narrow audience. Like I said before, my experience is being mostly ignored. And so when I write like that, there's kind of the attempt is to attract enough attention, and a lot of the time is to bait a response from people who would rather not ignore you, because some people, although they would never respond to a query about their paper, they may respond to a personal insult. And so at that point, you could have gotten your foot in the door to discuss the more substantial things. I don't think you should be careful. Don't applaud it. Look, I don't think it's not a good situation to be in. But this is my logic and how I think about things. And I've, before writing about science integrity, I've been on YouTube for a long time. Like I said, I've been in the trenches on Yahoo Answers. I'm bringing a different kind of type of debate in some ways, my own way. And I'm not the only person who writes like this, right? I mean, if you think what I've written is lamentable, you should read Leonard Schneider's blogs. That's something else. But I understand there's a worry about the tone. And the closing thing I'd say is, until there is an effective way to elevate concerns about papers and have them reliably addressed, then a space is being created for people to make up how they're going to do it. So if the publishers and journals want to create a way to elevate concerns about papers and have them reliably addressed, then there won't be any room for me to come in with kind of blogs that jump the shark, right? I'll just follow the process and it will get fixed, but it's not happening at the moment. So, I think there's space open for people to decide how they want to try and address things.
Plenty to talk about here. Well, thank you guys for taking to heart what I said earlier about being an active part of the conversation. This was really interesting, really fun. Thank you, Elizabeth. Thank you, Sholto.
Thank you so much.
Thank you. And can we get another round of applause for Jonathan here? Sholto, David, Elizabeth, Vic, wonderful job. That was a hot session. You know what else is hot? The lunch we have for you outside. Okay, so here's how this will work.
Hello.
We have a buffet-style lunch, open seating available on both the first and the third floors. You can take the stairs right out here down to the first floor and either of the 2 elevators up to the third floor. Enjoy, and we'll see you back here in about 90 minutes.
I'm really glad that people joined in. So.
Yeah.
Hey, everyone. See if my mic's on. There we go. Welcome back. How was lunch? Great. Who actually got dessert? Raise your hand. Great. Yeah, well, they were all gone when I got up there. So, welcome back. I was at the doctor recently because, I'm in my 40s. And I gave a long medical history. And then it had one of the really great, like, Epic-based medical records where you can go in afterwards and see and the doctor's notes were shown. The history was in there. And it was entirely wrong. So I'm really looking forward to watching this next session. I do wonder whether this might be having, as a journalist, watched AI transcription go from being something I couldn't use to something I use almost all the time. I'm really curious to see this applied to medicine. So we'll be kicking off this afternoon's programming with a demo. Here to answer, can AI fix medical documentation? I'm thrilled to welcome to the stage Dr. David Kim, Executive Vice President, Clinical Institute's Memorial Care Health System and Chief Executive Officer of Memorial Care Medical Foundation, Dr. Shiv Rao, CEO and founder of Abridge, and to moderate, Catherine McPhail, programmer for editorial events at STAT. Give him a big hand.
Awesome.
Great. Well, thank you, David and Shiv, for joining us. So as we have covered this whole morning, there is so much potential for AI in healthcare today, but as Matt mentioned, one of the biggest areas that we're seeing generative AI being applied and deployed within patient care is in the form of ambient scribes, which listen into your doctor's visit, they transcribe it, and they can automatically summarize it into your medical record. I'm very excited that today we're going to put one of those tools to the test. In this scenario, Dr. Shiv Rao will be playing the role of the doctor. You are also the CEO of Abridge. And then Dr. David Kim will be playing the role of the patient. I myself will be playing the role of a family caregiver. And we shall see how this tech works.
Awesome. And we'll try not to give you a brain transplant this time.
Although some would argue I would need one. But
yeah. So David, do you mind if I use this note-taking solution called Abridge? It's going to help me focus on you instead of all the distractions that get between us.
Not at all. Go ahead.
Okay, great. So now all I'm going to do is hit this button, and I'm going to say, David, I heard you're having some shortness of breath. What's going on?
Yeah, I've been having a little bit of shortness of breath over the past couple of days. Comes and goes.
Yeah. And is it worse with activity?
It does seem to be a little worse when I go up and down stairs, but I don't know how new that is.
Okay. Have you had any chest pain or chest pressure at the same time?
No chest pain, a little bit of chest pressure every now and then, especially at the top of the stairs.
Okay. Any lightheadedness?
Not really.
Okay. Any swelling in your ankles or in your feet?
No, I do remember a couple years ago I was in the hospital because I was short of breath and I had some swelling. I can't remember exactly. It had something to do with my heart, but I can't remember what they said.
Okay. All right. We'll get back to that then. I know you have that history of asthma. Have you tried albuterol recently?
Yeah, it's been a while. I think it was expired, and the copay was pretty expensive, so I haven't picked it up in a while.
Okay, got it. All right. Well, I'm curious, Catherine, as his sister, anything new that you're sort of noticing about him?
Yeah, well, David, you didn't mention, he hasn't been leaving his room recently. He's been kind of down. I'm a little bit worried about that, and I don't know how that's affecting things.
Okay, yeah, we should talk about that as well. So, in terms of your shortness of breath, we should take this seriously. I'm worried it could be related to your heart. And you mentioned you were in the hospital. I'm looking at my medical record right now, and you were in the hospital about 3 years ago, and you had what we call stress cardiomyopathy, or broken heart syndrome. You were under a ton of pressure, I think, at home and in your work. And you got better, but I'm always worried that could come back. Mm-hmm. But then also you have a history of diabetes and hypertension. Those are risk factors for what we call angina, or a blockage in your heart. So long story short, can you come in this afternoon to our lab? We'll do some testing.
Yeah, no problem.
Okay. So I want to get some blood tests, like what we call a CVC, a basic metabolic profile. We'll get a BNP and a troponin. Big words, but basically that'll help us understand how much stress your body's under. But then I also want to do a couple studies. an EKG, and an echocardiogram, get a sense of how your heart's functioning.
Okay, are any of those going to hurt?
No, super easy, super fast.
Great.
One other thing, your sister mentioned that you've been a little bit down lately. And now I think in terms of your mood issues, we have a new service. We have a behavioral health therapist who can call you next week and give you some strategies to deal with that. Does that sound okay?
Yeah, it's always been hard to get in to see someone. Can you get me in to see someone?
Yeah, this is a magical clinic, and it's going to work out. Now, like the last thing, your diabetes. I saw you at the airport a couple weeks ago. You're at McDonald's, 20 Big Macs in front of you.
Yeah. I was hungry.
Yeah. So you do live in San Francisco. I'm going to ask our nutritionist to call you next week. We're going to start you on a low-salt, vegan, diabetic diet. You're going to love it.
Great. Sounds delicious.
Okay. All right. I think we have a good plan. So we have that conversation, and now I can kind of describe what the technology does, and we can look at the output. So we didn't do this time, but if we spoke in multiple languages in the same conversation, we would still create one English note. So one of the first steps is to recognize the words. So if we spoke in Haitian Creole or Brazilian Portuguese, as some clinicians are using a bridge in Boston, or Vietnamese, as folks are using it at your health system at Memorial Care, the technology still needs to recognize those words and then decide what belongs in the note. So what do I, as a doctor, need to put in the note for other clinicians to read? There's clinical communication that happens. What do I need to put in the note for revenue cycle to keep the lights on? What does also need to get into the note for you, for the patient? So let's look at our note and get a sense. So here it is on the mobile form factor, and you saw that took a number of seconds, but let's look at it on the desktop where we can kind of geek out just a little bit further. So there's a style for a note. It's an archetypal note structure called a SOAP note. And there are bookends to it, where it's the patient story at the top, the clinician's assessment and plan at the bottom. Let's look at a couple of these sections, or at least those bookends. The patient with a history of asthma, diabetes, hypertension, and stress cardiomyopathy presents with intermittent shortness of breath that's been, let me make this bigger, that's been ongoing for the past couple days. The shortness of breath seems to be worse with activity, particularly when going up and down stairs. Also reported occasional chest pressure, particularly at the top, denies chest pain and lightheadedness, not noticed any ankle swelling in his, or in the feet swelling, albuterol inhaler, etc., because of the cost of the copay. Sister reports you've been less active, staying in the room more often. Now, when we scroll down to the assessment and plan, the other kind of key section of the note, it's pulled out 3 problems: shortness of breath, depression, diabetes. It's summarized the story or a differential I could have discussed, but also the next steps like CBC, BNP, BNP troponin, EKG echo. Now, last thing, and then we can kind of have a discussion about this, hopefully. If there was some part of this note that I didn't remember, and it's interesting, like we see that clinicians maybe don't remember about 10% of the conversations they have. Maybe they're preoccupied, thinking about something else. I can trust and verify. So I could go to maybe this part of the note about your sister and highlight it, and you see what happens on the right. It shows me where the evidence came from. And if I wanted to, I could even listen to it. So for example, I could click on any part of this section.
Down. I'm a little bit worried about that, and I don't know how that's...
And I can trust and verify that that actually happened. That works not just for things that the patient might have said, but it also works for things that I said. So for example, if I question whether or not I actually ordered these tests, shows me where the evidence is, and I can listen. Okay, so I want to get some blood tests, like what we call a CBC, a basic metabolic profile. So you get a sense of that aspect of the technology, but then the last piece is their structured data that's also being pulled out. For example, here's an ICD code for Takotsubo syndrome, and I never said Takotsubo syndrome, but it does, actually, it's the correct ICD for stress cardiomyopathy, which is one of the problems that we discussed.
You know, I was a real doctor not too long ago, and you asked, like, why would a doctor not remember? Because it was important for me to talk to my patient and keep eye contact, which means I wasn't tapping in the computer, and I had 20 patients to get through. So oftentimes I wouldn't get to the note by the time I finished the visit. I would wait till the end of the day, and then 19 patients ago, I have to remember, was it the left foot or the right foot? Was it 2 days or 3 days? And I've had 20 encounters where it can get confusing. And this is a life-changing piece of technology for someone like me 10 years ago.
David, when you first saw this technology, what stood out to you the most about it?
So I'd love to tell this story. So he was in Pittsburgh, I was in Orange County. We were Zooming. We did this exact same demo. And when I saw the note come up, I started crying. And I'm not a particularly emotional person. And the reason I became tearful is because the profoundness of the kind of solution this is going to bring to our physicians who are just so tired and burnt out. I mean, we read about it, but I see it. I talk to them every day. And this is not just a tool to make their life better. This is something that is a paradigm shift in how they are going to think about taking care of patients. And it has nothing to do with medicine or surgery. It has all to do with being able to connect and talk and be a person talking to another person, trying to take great care of them. And it enables that in a way unlike anything I've seen in my career.
Do we have any questions from the audience?
We have a question right here.
I'm also a physician. This is amazing because I've seen this attempted, and this is the most successful that I've seen it actually implemented. Are you using it at Memorial Care, and how is it integrating into your EHR and any feedback you've had so far?
So it's, we have about 70 docs on it now, I think. We're up to 70 across all different specialties. Probably about half primary care, half specialty. And in that specialty, some medical subspecialty, some surgical. It's been very well taken up. In the beginning, there was some concern about, I don't want to have to press a button and then push a bunch of buttons to get it into the EMR. But that was really more an education around creating some templates that you could just basically, it just gets pulled in automatically. On average, our doctors are saying it's saving them between 5 and 10 minutes a visit, which over 20 visits is 200 minutes. Right.
Okay. Catherine, we actually have a lot of questions in the audience.
Great.
We'll start right here first, and I'll ask everyone to kind of keep their questions short.
You suggested a plan for the patient.
Yeah.
Would it sit there and start to suggest a plan if you didn't suggest a plan?
It could in the future. And I think that these early innings are really about doing the best job of capturing what was actually discussed. You might have also recognized or seen in the note that it is doing a little bit of translation in spots in the most safe way possible. So for example, if David mentioned that he was waking up in the middle of the night short of breath, then maybe we would have translated that as paroxysmal nocturnal dyspnea. If he said he was short of breath lying flat, maybe it would have translated that as orthopnea. So it is a note that I, as a clinician who still sees patients, could be proud of, and maybe has minimal edits to make, but at the same time, we're not doing clinical decision support. That's a very important line that we're looking to not cross anytime soon.
We have a question over here.
Thank you so much. As a patient, my doctor has used this technology, and I'm super excited about it. My question is actually about bias in medical documentation. We know that it's been through data that Black patients have had more negative notations in their medical documents, et cetera. And so I'm wondering how this technology can address that. Is it a way that helps reduce bias, or has it been tested in terms of the ways that bias has been showing up in medical documentation?
I think that one of the great aspects of this technology in its ideal state is it's really reflecting the conversation as it happened. And so if there was bias in my assessment, in my differential, for example, if I sort of came to a conclusion that this was a certain type of etiology for his cardiac disease as opposed to another, or if I dismissed the behavioral health issue or those concerns because of some predisposing bias that I had, then that would be reflected, in the summary. And so these notes that are generated are really only going to be as good as high quality, if you will, as the conversation that we had. But it should not actually inject any new bias.
But it can be used as a tool. So I'll give you a parallel example. One of my docs came and said he didn't like it, and it wasn't helpful for him, which was strange to me. And then when I listened, he didn't really talk to his patients. Right? He goes in, asks him a question, kind of cuts him off, gets to a diagnosis, gives a prescription, he's out the door.
Yeah.
So then when I listen to it, I'm like, the problem's not a bridge, right? Yeah. The problem is the doctor. So that's not necessarily the kind of bias you're talking about, but then it becomes a tool to go back and talk to a doctor of, hey, it looks like you're interrupting patients really quickly. And it turns out that you're interrupting patients of color even more quickly. Up until now, that's a sacred encounter. Who's listening to use that as a tool? And so that's where this type of thing, it will require leaders to put context and operationalization of that type of training, but it gives us a tool to be able to do that.
You know, in the last time I got feedback on the quality of my conversations with patients was third year medical school in a motivational interviewing class. And so this is the opportunity, I think, for all of us. And we've had so many clinicians. We had a PCP recently who said that it almost felt uncomfortable 30 years into her career to make so much eye contact with her patient. And we've had others sort of look at this transcript because, as you can see, it's not just the summary, but there's also the transcript. And they sort of recognize all the disfluencies, all the ums and ahs in their speech. And they feel like it's a tool that's sort of coaching them, you know, in terms of their own communication skills. So, yeah.
We have a lot of questions. A quick one right here from Joel.
Hi, very cool demo. How do you measure the accuracy of the transcription and summarization, and does it take medical context into account, where like obviously some mistakes matter more than others?
Yeah, absolutely. The entire stack is really built upon or built with this context of a medical conversation. And so think of a pipeline, for example, and maybe one part of it that we can unpack is speech recognition. So we have an in-house speech recognition model that is multilingual, as we sort of mentioned. And in addition to being multilingual, it's really trained or tuned for medical conversations. I'm convinced that no doctor really knows how to pronounce an oral oncolytic. We all mispronounce these names, but we all expect this technology to recognize our mispronunciations. So that's one example of a treadmill that we're on as a tech company in this space, where we're always improving our technology to recognize all these new symptoms, diagnoses, procedures, medications across all the different specialties at any given large health system. But it's the same story for any part of the stack, whether it's on the information extraction side or on the summarization side, in terms of creating that note in the way that any given doctor would expect it to be.
I think we only have time for one last question.
We have one right here in the back.
Hey, Shiv. So Epic has been very good to companies in this space. What happens to, and I'm not trying to be specific about your company, but what happens to the space generally if Epic decides that they want to be not quite as good to companies in the space? How do you handle that?
I think the really exciting moment right now in the industry in general, and I think it's not just healthcare, it's in any given industry out there. Big companies, large companies, everybody in between are recognizing that we're all AI companies on some level, and that we all need to be, and that we can leverage these tools in any number of ways. And large companies, for example, and Epic's a great example, have been incredibly innovative in terms of leveraging the latest and greatest tools to deploy any number of features. And I've been stoked to be at a health system that is now deploying features that can help with my clinician inbox. And at the same time, I think these large companies and these small companies are finding ways to fit together. Where can we be complements for each other? And I think in our specific space, I think where we really plant a flag is to go deep on the science. We go deep on all things related to speech recognition, for example, but this is a treadmill even across every part of what we do that we'll never be able to get off. We will never be perfect for any given doctor out there, but we'll always aspire to be. And that's a treadmill that not every large company wants to be on. And so I think the moment that's also incredibly magical, and one of the reasons why we've been able, and I think this space has been able to create so much impact in so little time, is that there's an acknowledgement across the industry that that we can really deploy these technologies together, as opposed to necessarily think in silos. And so our partnership, we are in the workshop program. We're a co-development partner with Epic, and it's been an incredible privilege for us to be at the same whiteboard with them, figuring out where can we push the boundaries and really deploy the best possible experiences for doctors, but also most importantly for patients.
And I know we're out of time, but just to dovetail on that really quickly, if you can win the hearts and minds of docs, they'll pick it up, they'll implement it. That's hard to pull back, right? Because now docs are going to get almost irrationally attached to something that they feel like is making their day better. And then I'm going to go into their office and say, I'm sorry, Epic has a different choice, we're going to do something else. Or Cerner's got a different choice, we're going to do something else. That's a difficult conversation to have, right, with a bunch of docs. And so that's where this is such a tender time, where if we can introduce this in a way that doctors feel it's really a partnership, it's really making your ability to take care of patients better, that's a win for everybody. Epic, Abridge, Memorial Care, healthcare.
Yeah, and that's how they see it. They're actually pushing this technology out there, promoting it.
Great. Well, thank you both so much for showing this to us.
Excuse me. That was a great session and a great demo. You guys have been so enthusiastic. I'm so happy to see the energy, especially after lunch. So thank you. Keep that up, especially as we welcome our next session. We have a stat startup panel here to discuss what it takes to be a startup from 3 interesting new companies in the healthcare universe. Please welcome to the stage Dr. Gilad Amalji, CEO and co-founder of Ultima Genomics, Dina Radinkovich, CEO and co-founder of Gamito, Akira Matsuno, President, Chief Financial Officer, and co-founder of Tune Therapeutics, and to moderate, Allison DeAngelis, Stat Biotech Startups and Venture Capital Reporter. Let's get a strong round of applause for them, everybody.
Hello, everyone. Well, we're all kind of wondering how we're going to follow that demo. We were watching it behind the scenes, and I think everybody here was pretty impressed by what they were seeing. My name is Allison DeAngelis. We've invited some lovely startup executives and founders to talk a little bit about what it's like being a startup in the year 2024. But first, to kind of set the stage, because everybody is in a little bit of a different kind of field of biotech and health tech, I'm going to invite everybody up to give you a little mini elevator pitch for what their companies do, starting with Akira, if you wouldn't mind standing up and telling us about Tune Therapeutics.
Right out of the gate. All right, great. We're right after the great demo, so tough act to follow. But thanks for having me. My name is Akira Matsuno. I'm one of the co-founders of Tune Therapeutics. One of my other co-founders happens to be sitting in the back here, Fyodor Urnov, along with Charlie Gersbach. We helped co-found Tune. So we're an epigenome editing company. And what does that mean? Epigenome editing is the ability to be able to modulate gene expression across any cell without any DNA damage. So when you think about kind of the possibilities of what that can bring, think about what defines diseases, right? How many diseases are ultimately defined by the presence or the absence of a gene? And there's some, but the vast majority are really based on the misregulation or dysregulation of gene expression. So when you think about the application of epigenome editing, can you apply that to the treatment of the broadly applicable disease settings? And we believe that the answer is yes. And so we are now 4 years into this journey. We started out, as I mentioned, partnering with Fyodor and Charlie, actually right about kind of 4 years ago. And we were quite fortunate to be partnering with the Emerson Collective and NEA, and are in the process of trying to head into the clinic for the first time as a company this year. Our first program is going to be in chronic hepatitis B. So the interesting thing to think about is that for a genetics medicines company, our first program is actually not in the rare disease. There are 200 to 300 million people in the world today that have chronic hepatitis B. And our actual approach and the therapy that we're developing actually does what most folks who are able to spontaneously cure their disease, they actually lay down an epigenetic mark that prevents the virus from replicating. And so rather than having that happen spontaneously, we want to be able to do it deterministically for the 200, 300 million people in the world who have that. And the twinkle in our eye is actually, as we think about beyond just these common diseases, is to think about things like regenerative medicine. So coming back to the idea of epigenetics, all of your cells in your body have the same DNA, yet they don't have the same function. They have very different attributes, and those attributes are defined by our epigenetics. And so as we think about the opportunities that lie ahead, we're really excited to be able to apply this platform across many, many diseases, across regenerative medicines and other areas of improving human health span.
Thank you, Akira. Dina, I'm going to have you swap in. Dina is particularly sad that she didn't bring any
tools to display with you. She was talking about she could have brought in a petri dish and do some experiments. But can you tell us a little bit more about Gamito?
Yes, absolutely. And I'll try to stick to the 90-second elevator pitch so that we actually get some questions. Gamito is a women's health biotechnology company. We are leveraging the advances in cell engineering developed in collaboration with Joe Church's lab at Harvard Medical School. We take stem cells and we derive cells of the female reproductive system. The first product we're bringing to market is in solving the infertility crisis. So today, 1 in 5 couples experience infertility, and with the current socioeconomic and demographic factors, the problem is only going to raise. So currently, IVF process involves about 2 weeks of painful hormonal injections that carry side effects, and our first product candidate under the program for TILO changes this 2-week process into something that can be done over 2 days with 0 or up to 2 injections, with the eggs being matured in a dish. We're preparing and working on our manufacturing requirement to hopefully initiate a phase 3 trial in the US later this year, and already cleared for commercialization in some ex-US jurisdictions and have reported ongoing pregnancy that we're monitoring. Beyond turning IVF into something that is hopefully a more commonplace and accessible technology, we have a robust pipeline in women's health, from ovarian cancer and menopause. So really hope to fill in this void in biopharma in women's health, so that if you're a woman affecting your reproductive system, you have better treatments available to you that are more in line with the rest of kind of modern medicine.
All right. And last but not least, Gilad from Ultima Genomics. Can you tell us a little bit more about Ultima and its mission?
Yeah. Hi. So I think in the previous session, you realized just how hard it is for doctors, and now doctors with computers try to diagnose patients based on their very subjective descriptions of shortness of breath or headache or anything else. But in the end, there's data. There's data in us. There's epigenomic data like you just heard about. There's sequencing data. There's protein data. There's RNA data. And at the end of the day, we do DNA sequencing, which is the reading of DNA, which has been done for a while. First human genome was sequenced 20 years ago, so the ability to read 3 billion letters of human DNA. We just do it at a scale, order of magnitude faster, cheaper, more accurate. And the reason that's needed is because biology has only a single mechanism for storing information, DNA. That's the source code. It gets transcribed, RNA, proteins, epigenomics impact it, but in the end, when you want to read it, you read DNA. And we started the company 7 years ago with the premise that every data industry always needs more, always has hyperelastic demand. I grew up in the semiconductor industry, where every time you could make your compute power twice as cheap, you didn't shrink your market. People wanted 3 times as much compute power. And that's the famous Moore's Law, and it's been going on for 40, 50 years. Our premise that biotech, healthcare, has to have the same underlying principle once you start treating things as data. So we started the company 7 years ago. We were fortunate to raise decent chunk of money, over $600 million from very good VCs, Costa, Lightspeed, and Founders Funds, Andreessen Horowitz, General Atlantic, and a few others, Playground. And we were in stealth mode for the majority of those 7 years until we had a product. It's a very ambitious product. We worked very closely with the Broad Institute of MIT Harvard, where we were still in their basement with a code name and getting it to work. We did stealth a little bit over a year ago. We formally launched the product a few months ago. Now we are many of the world's leading genome centers, the people that read DNA for a living for others. We are at many of the clinical companies looking to use DNA. We'll talk about applications in a second. And with kind of advanced research hospitals and places like that. And I'll keep it short, but why would you want to read more DNA? So the premise was Moore's Law. There's got to be needs for more data, but what is the need for more data? In real simple, we have 3 billion letters per cell, but as you just heard, those cells are not all behaving the same way. We have 30 trillion cells in our body, and there's many of us. So you use sequencing to really, now sequencing, and people use the word AI a lot, but sequencing and AI really come together in 3 applications: population scale. Now I can read the DNA of 1 million people, compared to their electronic health records, apply AI, and understand why someone got COVID worse, someone's better, someone's aging, you can really understand population scale. The other one is within me. If you take a blood draw, you'll get about 10,000 copies of my floating DNA. Am I healthy? Is something going on in my liver? Do I have early stage cancer? You want to be able to read all copies of that shed DNA. And the third one is really transformative ability to understand cellular biology. If you compare perturbing the cells, CRISPR, with the ability to read what those cells are doing with sequencing, put in the animal model, those are the three kind of massive drivers right now of the need for more sequencing.
Thank you. Okay, we have a lot to get into, and obviously you are all three kind of working across different areas. I want to start off, though, let's talk about the financing, the money of it all, and how you guys have gotten your companies up and running. Some of you mentioned, and have talked publicly about the fact that the financial markets, being that the way that they've been the last couple of years, has forced you to change, and kind of tweak some of these plans that you laid out. Can you tell us a little bit about how the amount of money that you've been able to raise, the capital that's been available, has impacted your plans? Dina, can I start with you?
Yeah, absolutely. So to kind of provide a background, right, when we were working in stealth mode with the sponsor research agreement with Harvard Medical School, working on our programs, once we got preliminary promising data for the first program for TILA, which I've explained, it's a product for in vitro maturation of human eggs, we then raised the Series A round, came out of stealth, and we had a pipeline of different products. And at the time, I would say, like, the general consensus that was in 2021, the general consensus was like, oh my God, you have to work on this like robust pipeline and menopause, and you have ovarian cancer, and you beat your ovaroids beat like the previously mouse chimeric models, and mice and primates do not replicate biology. So let's try and solve all of these problems at the same time. Certainly, as we know, the situation, the cost of capital has changed. And one of the things that we've done at Gamito was to prioritize a program that is delivered in vitro, right? So it even has a different regulatory classification in different jurisdictions. We were able to show human efficacy in vitro up to date, and certainly are working on further trials. And we prioritize that first program, and the program that we can go to market faster, go to like late stage clinical faster, and then focus. The plan is to kind of use the proceeds from that program to fund the additional pipeline. And I think we've shifted from the point of let's try and solve everything in women's health. I mean, kind of like in that environment to, okay, let's be a profitable company. Let's, start with IVF first.
Mm-hmm.
So I think like one thing that certainly I think startups in this environment are struggling with is, and trying to do, is be very adaptable to the change in market, which we've had in a couple of years. And I think that has really worked well for us, is that we're now working on like pivoting the company really to the commercial stage, and being like a lot more efficient and careful about funding new programs.
Because you said that IVF is an area that's, where your predominant focus is right now, but it's also an area that the FDA has kind of not touched very heavily. You guys are working through a clinical trial process and are working with the agency, and how has that impacted the kind of capital that you've needed to raise?
So to provide a bit of a background, because there's not that much biopharma innovation in this space, IVF was never approved by the FDA, right? A lot of kind of IVF innovation just became part of clinical practice. That being said, a lot of the interventions used in IVF today did go through FDA approval, so the gonadotropin, hormonal injections, and others. So there's a lot of variation. And I would say one of the biggest risks and challenges that I had to overcome with my team was not only in biotech, when you start a startup, we were just chatting about it in the green room, right? You have to believe in a scientific hypothesis, and you take a risk that what you're building may not work. An additional layer that we had to take when we started on this journey was like, okay, even if we develop something that it works, how would it be approved? And that's the way why we are very fortunate that we received clarity from the late the product candidate for TILA, because it's in a dish, it's not given to the human body, but it's part of the IVF process. And we're thankful now to have kind of aligned that for major markets. But I would say that is a difficult situation, because depending on the studies you need to do to go to market, it completely changes what type of company you want to be, which investors you want to go for, and how you're going to structure like their return and make sense. Do you need to raise 50 million or do you need 5, and who do you go to?
Yeah, Akira, how much was Tune's first amount of fundraising? Was it like $40 million?
40 million. That's right.
And genomic editing is not an inexpensive area of drug development. So how has like the financing that's out there impacted how you guys have chosen your first indication and have chosen your clinical plans?
Yeah, I mean, I think, you know, to a certain degree, at least for us, the first question was, and you're right, like the underlying premise is that anything in sort of the gene cell therapy space, there's no aspect of it which is, you know, very inexpensive to try to develop. And so I think obviously that was just fact. You know, for us, one of the real big challenges over that first year was actually just to figure out where are we going to put all of our priority sort of resources around, like what is the indication? You know, we have, in some respects, kind of our challenge, similar to yours, was there was a lot of different areas that we could go. Right? The platform scientifically lended itself to a lot of different settings. So how do we prioritize that? How do we match, you know, the uncertainty about kind of drug development and discovery with a balance sheet to be able to match that and to be able to also account for the fact that we can't have perfect timelines. Something will go wrong. Something will take longer. And this is all happening in the midst of, you know, the kind of COVID rise. And so, you know, all of that impacted how we thought about how much cash we needed, how much cash we could get, how quickly we could go. You know, and those are still discussions that we need to have today.
Yeah. Meanwhile, Gilad, you mentioned $600 million, I think, you've raised over the 7 years, most of which you were in stealth, but you guys came out of the woodwork with what, I mean, some would call pretty audacious plans in a field that's dominated by one company right now. It's Illumina is the biggest sequencing company out there, and you guys launched and said, well, we are going to launch a sequencer, you know, a sequencing technology that's significantly cheaper. So how did you guys plan for that? And I mean, particularly kind of plan to launch and move very quickly into commercial.
So from day one, we knew that this is an expensive project. You have to take on a lot. It's a complex instrument, chemistry, molecular biology, and so forth. And we have, in a way, less degrees of freedom because you need a sequencer. Once you have a sequencer, it works for many platforms, and you can still control how fast you go, how much you spend, and you want to be always responsible. But anyway, it's clear where you're going. It's clear where the market will be. To us, and I think to all our investors, it's clear that the role of DNA reading in the world will grow and grow. And then just it becomes a question, well, are you the winner? And what is this the right technology? Is it the right team? Is it the right investors? And once you do, then you have a path and you pursue that path. So I think it's a much more execution-focused play where you know exactly what you're going for. And it's always nicer to be in a zero-rate environment where money's flooding, but then it's also hard to hire talent and lots of things. I don't think on the long term it has a lot of meaning on our trajectory. So we just try to be responsible for the way the markets are, but keep going straight.
Did you guys ever internally take a tally, each one of you? Like, how many investors do you think that you've pitched at this point?
I don't
Do
know.
some quick math.
We were stealthy, so we kind of never. We were more like introduced from one to the other. I don't think we pitched much at all. I think we kind of skipped the usual stuff.
That usual stuff. How did that play out for the rest of you?
Well, that's a good question. I mean, 75 probably plus.
Ooh. I don't know, maybe about 20 or so, 20.
But in those 20, I mean, you were able to get Bob Nelson from Arch Venture Partners is an investor in Gamito. And I think that you also have Anne from 23andMe.
Yes, that's correct.
Is an investor in Gamito. How did that come about?
Well, actually, so my co-founder and chairman of Gamito is also the founder and chairman of largest fertility clinic chain in North America. Actually, no, second largest because that was a recent merger, but a large clinic chain in North America. And he is actually the one who introduced us to Anne. They knew each other from before, from a previous venture. And I obviously was in venture capital before. I'm a medical doctor by background. Was also a part-time partner at Salt Ventures. So I was working with a lot of early stage like venture deals. I was, we had a lot of capital allocators. The SALT network was very helpful to me as well to kind of identify understand how venture capital works. I always joked, I mean, I was born in Serbia, so I went in my teens on a scholarship. I was in the UK, that's where I finished my medical school, and then my first flight to the US was also on a scholarship for the British Computer Society, and I ended up here now. But my first introduction to venture capital was through a F-Factor competition, which was like X Factor for STEM in the UK. And I remember it was Founders Forum, and I remember people, like everybody was telling me, I was asking people, what do you do for a living? And they were like, oh, I work in VC. So I was Googling what is, VC, what is this company that everybody works for? So I was 19 at the time, okay. And then, so that was kind of like, right? And I think like venture capital is not yet a democratized industry. It is very much on like introductions and who you know, and there's a lot of this signaling and heat, and and you would kind of want people to kind of always review the data, but it's always like, oh, what does this person think about that person, right? And for me, coming from like a geographic area where venture capital doesn't exist, and then entering here, I think my previous jobs were very helpful, so that I understand the dynamics and therefore can leverage what we're building into kind of hitting those boxes that I think people want to get checked when they invest in a company, and I think that was very helpful. And as you said, we did really well, and are continuing to do well in especially in women's health, which is not so much of a hot area. Although I would joke that we were like in AI even before AI was interesting because we do artificial insemination. But
well, I mean, on the topic of AI, I'm curious. In your interactions, and your lifespans as companies, I think to your point, Dina, like there are certain trends that happened and places where venture capitalists kind of triangulate and say, well, I'm really excited about this one company and this other company's like them, so I'm going to invest in them too. And that's sometimes how things work out. With the kind of augment of AI over these last couple of years, like have you guys been fielding questions about like, well, how are you using, technology in your various startups, or has that wave not really reached you?
I think we internally always, again, from day one, used kind of deep learning or AI to make our machine work. But that's like deeply embedded inside the machine. That's the way how it reads DNA and trains itself to read it better. What's exciting of the last years are users, our potential customers. Our customers are suddenly saying, again, cell biology is incredibly, if you think speech is hard, and it is hard, cellular biology is incredibly complicated. It's full of anecdotes and examples and edge cases and this and that. It's not the beautiful, simple DNA makes RNA, makes protein, everything's easy. It's really hard to understand. And it's just a field that's ripe for AI. So we see it in people trying to develop ultra-large scale models for understanding cells, and we see it at the human level and with the population level. So it's a field that was ripe for AI. It's not gathering as much hype maybe as ChatGPT, but you see it clearly in all our users, accelerating the scale of what we do. So realizing that you need quantity to train and get quality.
Allison, we have a question over here in the back.
Go
if you're
for
ready
it.
Great. We have a question from Manish. John?
Hi, it's Manish from rb. Question actually for Dina on women's health. So as we know, the field has been under-researched and underserved because it's been underinvested for chronically a long time. What do you think it'll take to raise greater awareness and to get much more investment? Because it feels like there's so much opportunity, especially with the work you're doing.
Manish is also a founder of a great company in women's health. I would say, I don't know is the real answer, but I think what we can do is try to do our best. And I think, as you pointed out in your question, people are often looking for previous success, and then they kind of follow the same, even though it is a little bit of a parody, because in terms of venture capital, you're supposed to take like weird risk, right, for outsized returns, but still you're looking for like a paved path perhaps, or where everybody else is going. So I don't know how you kind of compute these two thoughts in your head, but it is kind of true, right? Like right now we're seeing AI, obesity, right? Like, and everybody's kind of flowing in there. And I hope women's health does become that, and I hope companies like ours and yours and many other great companies in this space will show great return on investment. I think we're here because we really care about the impact that we hope to to achieve, but also because it's a great business. So ultimately, I mean, we're talking about like a massive market of half the population. And I think that, like, in the end, the financial returns will probably be what will drive the change. With that being said, certainly, like, I think it's being a lot more discussed. And as everyone knows, I mean, I told you before, like, I recently had postpartum hemorrhage. I delivered a baby about just over 3 months ago, and my life was saved by an invention of another women's health startup. So I remember from my hospital bed sitting in there and writing to all of my investors and my team, like, we have so much work to do. And I think that's what is exciting, because unlike many other better funded areas, you still have conditions that affect like 10% of the population with no first line treatment. You have known pathways with quite a lot of data, not drugged. So there's a lot of low hanging fruit from a biology perspective. And I think with the right execution and the right team, there will be outsized returns, particularly because valuations also tend to be lower in women's health. And I think a couple of people will get really rich from the investment side, and we'll see a lot of change.
What are the biggest challenges ahead of you for each of your companies at this point? You know, some of you have mentioned that recruiting has proven to be a bit of a challenge, or something that you didn't expect to be as difficult as it was. Also, I mean, commercialization. A couple of you have had to make really, sharp choices in which markets you pitch to first. What's been the hardest part about being a startup founder these days?
You want me to go?
It's all been easy? Oh, that's great. Okay.
I said my biggest challenge was, I think our biggest challenge was like navigating the regulatory landscape, because you don't know what you're going to be. I mean, I think the biggest thing is like the hardest problems to solve is the one that you don't really know what you're dealing with. So I would say like obtaining that clarity. Now we have a very clear execution path, and it's more an execution risk, and a lot of kind of the scientific risk has gone already. Although in our industry, you're always there's always a risk. I would say navigating the regulatory path globally, and certainly our product candidate, as I mentioned, is differently regulated in different jurisdictions. So in some places we have a reproductive tissue designation, in some places it's still unregulated, in some places it is a biologic, right? So I think obtaining that is a big one. And then perhaps, I mean, going to your question, Manish, again, is sometimes like lack of like comps in previous companies, and kind of successful companies in different stages of development. I think it's a big problem for us in the field, because you have to educate people a lot for them to feel comfortable to even like conduct diligence, be able to assess, spend time with you. And if you already have like, even venture funds, right? Like they also had a hard time with this high interest rate environment. So they're also not growing teams. So if they have a team that's already very educated on a couple of hot areas where there are like tons of companies, for them to spend like additional month to get educated, to be able to diligence, to spend time with, I think that is hard to get on that priority list.
I'm curious, Akira, talking about the regulatory environment, when Tune was started, we hadn't seen a CRISPR drug hit the market yet. How has the experience with the regulatory side been for you guys, like before that and actually post this first CRISPR approval last year?
Yeah. Can I answer that question briefly and then answer your previous
You can answer,
one?
yeah, absolutely, whatever order.
So I think on the regulatory front, I think, fortunately, I think one of the things I mentioned was one of the really unique things about our platform is the ability to modulate genes without doing any DNA damage, right? And so when you think about that, you can think about it not from just a single gene perspective, but multiple genes at a time, right? A lot of that element is fundamentally different because your DNA isn't getting nicked or cut in any way, right? And so that just opens up the world with regards to possibilities, and regulators recognize that for us very, very early on. So we didn't have to necessarily fight that battle. That was actually kind of an understood element. And I think, as more data continues to come out from not just us, but from the field, that I think has become even better understood. But I actually do want to just quickly address the prior point, which is, when you think about, at least from my perspective, building companies, and everyone here has done them, there's kind of three elements that kind of come together: science, capital, people, right? And different points in time put stresses on those different elements. And you know, for a long time, the capital element was much easier, much more accessible. It's been harder as the cost of capital has constrained or had gone up. But at the end of the day, right, like no matter what you do, and to your point about the parity element, I think it's, you know, people is the biggest driver, and which is why it's so hard, right? For a company to be able to recruit the right phenotype to come in when you are, you know, the 3 people in the proverbial garage, right, to the 15 to 20, that, you know, to the speed, which is kind of the big strategic advantage that all of companies that are young have. How do you preserve that when you are trying to get employee number 75, 100? Are they the same phenotype, right? For us as a company, you know, I mentioned we're headed into the clinic, fingers crossed, this year. You know, you're actually shifting, you know, now the phenotype just within the org, right? You're becoming a preclinical translational company, clinical company, when you've been a research discovery company, right? And now you're bringing in different capabilities. And so as you're kind of managing all of that, right? How do you get the right people? How do you find the right, you know, folks who are curious, you know, have that kind of bias to action, but also, you know, willing to do all of the things that are not so glorious about being in a startup, right? And so I think that part of it is I think on one hand fascinating and what differentiates startups, but it's also really hard.
How do you find the right people?
I'd love to hear from the rest of the group, but I mean, I think...
Is that still an open question?
Well, I mean, I think there are traits, right? I think there are definitely traits for folks that at different stages in time may be great, and, you know, that person who was great when there was 50 people may not be great when the company gets to 1,000, right? Just those skill sets are different. I really think a little bit about, like, how resilient are they? Like, how much, you know, how many unexpected blows can they take, right? You know, how can they deal with uncertainty, right? Like, you know, can they make a choice, or are they going to be paralyzed? You know, are they willing to do the things that nobody, you know, really wants to do, but someone has to do them, right? And all of these elements are important. You know, I think technically, those are the easiest things to look at. You look at someone, you know, you can ask them very great technical questions, and you can have a good assessment. But it's all of those other elements that actually make these companies go. And those are the hardest ones to test, right? So again, sort of curiosity, I'll call it resilience or grit, to me are fundamental, in particular early.
Gilad, I'm curious, the uncertainty aspect of it all, how has that played out for Ultima, given that, you know, you're recruiting in a base where you're headquartered is also right where Illumina is headquartered? I would assume that, you know, you're only having, you know, such a big, you know, so much of an available set of candidates. How has it been finding the candidates who are willing to deal with the uncertainty of being in a startup?
So they're a few hundred miles south. So San Diego, mostly.
Oh, sorry, that's right.
But they have presence here, and we are mostly here. But basically, agree with every word that was said about the quality and the personality that you need in a startup. But before that, you have table stakes. You need these technical skills. What we do as sequencer is just a very complex beast. It's got optics and lasers and robotics, automation, machine, deep learning, real-time software. You synthesize molecules. You grow your own enzymes. There's a lot of skills. So first thing you need, just to, you know, to clear the bar, you need to have skill. You need to be really, really good at designing imaging optics or whatever. So that's and those skills don't have to come from sequencing. Sequencing is how it all comes together, but it comes together in other disciplines. Or we hired people from the semiconductor industry, which are really, really good at automation robotics part, where I came from. We hired people from other biotech companies, which knew the enzymes and so forth. And we did hire people from sequencing, but not en masse. We're not a clone of the incumbent. We're trying to do things very different. The technology is very different. Our approach is very different. So we did not see that as a major issue.
What's the advice that you wish somebody had given you, or that you could give yourself when you all were all getting your company started? The things that you know now that you wish you had known.
I think I was always paranoid about when the markets are going to turn, and I knew this company had to be highly funded, so we always raised early. You can say we raised too early in the beginning, so dilution, stuff like that. I think that's immaterial compared to the size of what we're going on. So far so good. I can't. I'm sure I'll have things to say, but so far so good.
I think maybe I'll turn it a little bit into sort of thinking about what was important early on and why I think we've benefited from that, which is, coming back to the kind of another element of the people element as it relates to capital. A lot of times you are fortunate to bring in capital into your company, but you're actually bringing the person or people behind that capital, right? And I don't know. I think from my perspective, one of the keys around that is, do they share the same horizon that you do, right? Or the team does, or the founders do. And that's a really hard thing to kind of decipher, because you won't really know until things get really bad, right? And so how do you make that judgment, early on? I think to a great extent, we've been super fortunate around that, but I think that is one of those things, not necessarily in this company, but in other companies, that I've learned that, that mismatch in what I'll call horizons of what you think this company can become or what you define as success is one of the really big things that is maybe not evident early, but when it becomes evident, it's too late.
No, I think I completely agree. It's really thinking about all the partners, being very careful about all the partners you bring to the table, and ensuring that you can work together as a team, and kind of, we'll always have a debate, but similar set of values on how you define success. I think that is a very important thing that we certainly learn even more along the way, and that I would advise earlier founders to think about, and not necessarily even over-optimize always for perhaps immediate financial terms, but kind of that long-term picture, because biotech is really a long game, right?
Yeah.
Nothing is going to happen overnight, and I think that is an important part.
All right, everyone, please join me in giving our panelists a round of applause. Thank you for joining me. All right, pour me on out. Ooh.
For this sponsored conversation, please welcome to the stage Vice President of HIV Clinical Development at Gilead Sciences, Dr. Jared Bateton, and to moderate, STAT co-founder and executive editor, Rick Burke.
Going after an HIV cure presents one of the greatest scientific challenges of our time. We're not running kind of blindly towards it.
There are days when the complexity can seem overwhelming. And then I'll have a meeting with someone who's just solved a tiny problem in that big complexity, and I'll think, okay, the whole thing can come together.
And together, we're building a road towards solving the unsolvable.
First of all, as I was saying, this has been a great audience, so it's so good. The questions have been great. It's really been a great day. And Jared, it's great to have you here. And tell us a little bit about your journey. I mean, you've been involved in fighting HIV for decades, and you were internationally. Can you tell a little bit about your background and how you ended up at Gilead?
Yeah, thanks, Rick. And it really has been a great day, and great audience, and great questions, and great interface of topics. I've been working on HIV my entire career, and I think like many people who work on HIV, we'd like to see nothing more than not have to work on it at all anymore. I've been working almost 3 decades, first as a clinician and epidemiologist, and I've seen patients in the US and I've seen patients globally, including across East and Southern Africa. And I have been able, like many people, to see the evolution of what HIV has been, from from deadly and no therapies whatsoever to where we stand today, where we've got pretty incredible tools, treatments for many people, a single tablet once a day, and prevention that can keep people from having HIV at all. And yet, everyone who works in HIV is always hopeful and dissatisfied with where we are right now, so we've got a long way to go.
Could you talk about your role?
Yeah, so I work at Gilead Sciences. I've been there for 3.5 years now, and I came to Gilead in part because of an amazing history. The first place to build a fully encompassed single pill for HIV, the first place to develop a PrEP medication for HIV, and 3.5 decades of dedication to making medicines for HIV. And I came to help lead the HIV development program to make the medicines of the future in treatment, in prevention, and, like you heard about just there, also leaning in towards an HIV cure. And really focusing on what people need, thinking of how far we've come, but what's going to get us those last miles to be able to really meet people where they are and meet the needs of the community today.
When you talk about how far we've come, can you talk a little bit about your perspective of what the whole, just going back to what things were like 25 years ago or whenever? Has it been that long? However, just talk about the sort of the panic and
I think the history of HIV, and it's great to be in this sort of breakthrough day, is a history of innovations and breakthroughs and striving against tremendously terrible odds. Of course, 40 plus years ago when HIV first came around, a deadly disease that no one understood, didn't even understand what could have been causing it, and then to evolve quickly to be able to make tests and therapeutics, and then therapeutics that turned HIV from a deadly disease to one where people now live a full normal lifespan with HIV treatment. That has been incredible. And I think many of us remember the photos of a handful of pills that people with HIV would take, and now for many people it's a pill once a day. And still, the challenges of HIV remain. The third of people in the United States who are living with HIV aren't treated, and it's not because their virus is special, it's because the medicines that we make aren't fully workable in their lives. There are 1.3 million new infections around the world every year that are still occurring in spite of great medicines for treatment and prevention. And a lot of that is driven by the stigma and discrimination that has accompanied HIV since the very beginning. You talk about fear, and there's been fear in people with HIV and people fear in communities. And so that kind of fear, that stigma, that discrimination drives people away from getting the kind of therapies that they need.
What Gilead, of course, has been sort of identified more than any other company in sort of AIDS, HIV prevention. What's the challenge now for the company to vanquish HIV, and how big a challenge is it? What are the next steps going forward?
Vanquish is a great verb, and thanks for using it. I mean, I think the vision statement that we have for Gilead HIV is to end the epidemic for everyone, everywhere. And I think we'd like nothing more than to drive that home. The big challenges these days, and the thing that we're working on the most, is making longer-acting medicines. Medicines that would, for the person who's challenged to take a daily pill now for treatment or prevention, could lean in and be once a week, or a pill once a month if our science can get there, or an injection maybe once every 6 months, so that somebody doesn't have to think about getting something every day, so someone doesn't have to carry that pill bottle home where their roommate or their aunt or their mother or their friend may find it. And that, or even having that readily pill bottle on the bus going home with them. The ability to make the chemistry to develop long-acting therapies is incredible. To think about something that you could take and it will still be working next Saturday or beyond. That's really amazing. And so we're leaning in on that, and at the same time recognizing that it's not pills alone that's gonna solve the epidemic. Gilead works really hard to build partnerships with community, with advocates, with scientists, with people affected by HIV, so that we're able to, as we build pills, we're making pills that are going to actually make the big impact in real people's lives.
Despite all the enormous progress and strides, why hasn't this been vanquished by now?
Yeah, it's like we talked about a second ago. It's amazing to think of the innovations that have happened. And I think HIV innovation really can stand up to any other innovation in health for the dedication and the ability to go from nothing to something incredible in just decades. And at the same time, stigma, discrimination, homophobia, transphobia, gender and other disparities really hit us all the time in HIV. And so to be able to make medicines that are person-centric, that meet people where they are, that's where we've got to be hitting right now. And so as we're thinking about the medicines of the future, we're in with communities from the time things are back in the laboratory, the things are in our chemistry laboratory. We're talking about how we can make a medicine that's going to really work within an individual, within an ecosystem of community and society.
How big is this portfolio for Gilead in terms of the overall company and all the things that Gilead does?
Gilead has been a leader in virology work since its very beginning and continues, and particularly HIV, but as well other things in virology, viral hepatitis and COVID. And we're really proud of that history. So obviously we drive hard and drive big still in our HIV work. And Gilead's also really lucky to be able to have expanded into other therapeutic areas, oncology and inflammation, where we have learned and work really well together. The science actually interfaces really well across oncology, virology, and inflammation. And I think equally importantly, that passion that's always driven us to really make huge differences in a global disease, those things have translated from our HIV work to other virology, to oncology and inflammation too.
And when you joined the company, you had a different background and sort of all this international work and so forth. What can you talk for a second about what sort of perspective, what you brought to Gilead?
Yeah, so you're right. So before I came to Gilead, I spent my entire career before Gilead was in academia. I was a professor and taught and saw patients and did a lot of research. And coming into Gilead, it really brought together all the things that I went to do in my very first work in global health and HIV. I worked in Kenya 25 plus years ago when there was no medicine and essentially no testing even. And it brought home all the things that I want to do in the world in terms of big impact. Gilead has a world vision to end this epidemic for everyone, everywhere. And that is whether you're here in San Francisco, here on the Embarcadero in San Francisco, here in the Tenderloin in San Francisco, like we heard about earlier, whether you're in the Central Valley of California, the southeast of the United States, or the southeast corner of Kenya where I used to live. And to be able to think about building medicines that fit into people's lives everywhere in the world and tackle a global epidemic, that's what's translated from my previous life into this life.
I have to ask you, what moves faster, the academic world or the corporate world?
Actually, Gilead, I think, has always been known for its nimbleness and its imagination. And there are thousands of people down in Foster City and here in Gilead, all rowing in the same direction and all with the same passion that I'm talking to you with today. And so we get a lot of things done and pretty fast.
And what's your timetable for this big challenge?
Continuing on my last point, I think everybody who works with me at Gilead probably would say that my timetable is faster, but it is what we're doing. What we're doing over these next years, this rest of the decade, is thinking about all the innovation steps we can build in treatment and prevention, especially, to be able to really meet the world's goals. And the UN has a goal to try to end HIV as a global epidemic by the end of this decade, and we're all in on trying to meet that same kind of deadline.
So you feel that same urgency?
We have that same urgency. And then, of course, leaning in towards cure, like we heard about before, which could be the biggest scientific challenge certainly of my life.
Jared, thank you so much.
This is
really
great.
Interesting.
Thanks, everybody.
Dina was talking a bit about her birthing story, and having to kind of overcome some issues that had happened during that moment. Next up, we have a session that's on maternal health with a focus on Black maternal health. These are 3 startup founders who are trying to combat the crisis of Black maternal mortality. Please welcome to the stage Kimberly Seals-Allers, founder of Earth App, Simone Tate, founder and CEO of Poppy Seed Health, and joining us virtually, Melissa Hanna, co-founder and CEO of Mommy. And to moderate, Usha Lee McFarling, national science correspondent at STAT.
Hi, everyone. I know it's that 3 p.m. all-day conference doldrums, so we're here to wake you up with this panel. And hi, Melissa. Thanks for joining from Los Angeles. We're going to talk about a really serious topic, but I want to take a minute to just say how thrilled I am with this panel. We have 3 people representing successful, game-changing, well-funded businesses, and they are all Black women-founded. So I just want to take a minute. We got to celebrate that. Okay. We're really going to delve into what you're doing and how you're changing things. And I want to start, though, with just getting us all on the same page with how big this problem is. And Melissa, maybe you could just concisely, what are the statistics? What do people in this room need to know if they're not really up to speed on how serious the Black maternal mortality crisis is in our country?
Well, hi, everyone, and thank you so much for having me as part of this panel and the session today. The Black maternal healthcare crisis is a national crisis. It's so important for us to understand the stats that a Black birthing person in the United States has, on average, a risk of dying during or shortly after childbirth that is 3 to 4 times higher than a white birthing person in the United States. And the primary reasons for that are really structural, and we see these challenges across the country. We're talking about systemic racism, bias in care, and bias in the structure and delivery of that care, the access to care, and the way that Black birthing individuals are treated throughout the pregnancy, labor and delivery, and postpartum experience. So we need to think of this as a multifaceted challenge, and one that requires multifaceted solutions, which we're all going to be talking about today. But this is absolutely a national epidemic. We talk about maternal mortality very often in the news. You may have heard about that in the media or through your communities across healthcare. But we also need to talk about morbidity, the fact that there are many, many more near misses and instances where someone did not receive appropriate care, appropriate attention, responsive and timely care to prevent a serious injury or illness from occurring that was otherwise preventable and shouldn't have happened during a pregnancy or postpartum experience.
Yeah, thanks. That leads really well into what I want to ask Kimberly, which is what prompted you to start Earth App? And just tell me about the story. What motivated you?
Yeah, well, I created Earth, which is like the word birth, but we dropped the B for bias, so it's IRTH. I created Earth because I wish I had it when I was giving birth. I was that person as a journalist by trade who did all the research, read all the reviews, read all those lists of the best of hospitals, went to one of those places and walked out feeling disrespected and traumatized and spent a lot of time blaming myself. What did I do wrong? To go to some place that all the reviews said was a great place, and for me to have such a different experience. But what I learned, which is what we know now, as Melissa is indicating, that people are not being treated the same way, even at the same place. At the time of having my first child, I was not yet married, and I was in graduate school at Columbia, so I was on student insurance, and I was treated like an unwed Black woman with basic insurance. And so what I really would have needed to see was reviews from people like me. And so Earth is the first of its kind Yelp-like platform designed just for Black and brown women and birthing people to find and leave reviews of their OBGYNs, birthing hospitals, and pediatricians. We are all about crowdsourcing and publicly sharing where we're getting good care and where we are not. And then on the back end, we turn these reviews into data. robust patient experience data, which health systems are not getting because folks are not responding to those HCAHPS or those hospital-administered surveys. We can talk about the medical trust gap, but we turn our reviews into data and then that into actionable strategies to literally help hospitals improve their care by listening to the Black and brown folks who are being disproportionately harmed by the current system. So we're excited. I'm proud to have created a solution to a problem that I personally experienced, and we're excited that we're working with health systems in 8 states.
It's amazing. And I know you've talked about it as a green book for Black birthing people, and I think that's just so powerful and also sad, that it's needed. But
it is needed,
powerful.
but it is our digital green book for safe Black birth, right? We know that my parents and my grandparents literally needed tools for where they could travel safely. And so now we've created our digital green book for birth, and we're excited about its promise.
Yeah. And Simone, what drew you in? I know you have a personal story as well, and that kind of the loneliness you felt, if you can share that.
Yeah, sure. I mean, you see 3 Black women here today, and I can tell you that it's our lived experiences that sent us into the realm of starting and building a solution to solve something very personal for us, but also for generations in front of us. I had my first, and I'll take you back to 2016, my first pregnancy loss in 2016. I actually was very well insured. I was a tech executive at a very fast growing startup, and I had the best health insurance. I was seeing one of the top OBGYNs in New York City, and yet I left that 13-minute appointment after finding out that there was no heartbeat, which does happen, but it had never happened to me. And I left that doctor's appointment with no medical follow-up, no emotional or mental health support. And I did what 85% of all Americans do. I went to Dr. Google. And there is where I found things, very simple things that weren't offered to me. The kinds of things like blood work and specific sonogram for my own health and also for future healthy pregnancies. And so I called my own care plan back into my doctor's office. And I didn't know the language at the time, but what I had done was advocate for myself. But I didn't feel like I was being taken care of. I was actually mad as hell. And I took that frustration in a very deep, dark, emotional place, and I stayed on the internet, and I happened to stumble onto a doula board. I'm really aging myself here because it wasn't interactive back then, right? It was some stranger on the internet who had also had a pregnancy loss, but it was only doulas that were responding to this person. And I started to read through this loving, inclusive, caring thread. And I didn't even know what a doula was really, like the majority of people, although we're all in the headlines now. But I can tell you that it was that emotional solvency, that very human, universal experience that we all have of feeling better, that made me quit my job, become a doula myself full time, and had the idea for Poppy Seed Health to simply deliver on-demand emotional and mental health support, which we do very quickly in about under 10 seconds. And we've done that by building one of the largest gig economy workforce in the country with doulas, midwives, and nurses who are leveraging our technology to do the work that they love, to be able to deliver that emotional and mental health support on demand in acute need. And they're all non-clinical today with what we do. We're really the frontliners on feelings. And just lastly there, because I think it's a stat that most people are really appalled to hear and also surprised to hear, but mental health related conditions are the #1 reason for maternal mortality in our country. #1 reason, 20% of that is suicide. So when people ask me why I'm building this, I'm building it selfishly for me, but also for everyone that's suffering in silence.
Thank you. I want to talk about the role of hospitals and health systems. I'm going to start with you, Kimberly, and then you, Melissa. You're dealing with poor outcomes. You're dealing with things that hospital systems don't want to talk about and be transparent with. And you've gone from having, I think, them being like mad and quaking in their boots about Earth to partnering with some. So can you tell me about that evolution?
Yeah, I think, hospitals have taught me lots of great sayings. One of them is you can't change what you can't see. And what isn't being measured can't be managed. And so I simply asked them those questions about what they're doing about perceived experiences of bias and racism. I asked them questions about what exactly is the percentage of Black and brown respondents to their hospital administered surveys. Is that reflective of the communities that they serve? And somewhere within this line of inquiry, we get to a point where they recognize that that they need Earth and that they don't have the data. The fact of the matter is that when we talk about maternal mortality and even morbidity, that is the floor, right? That is not the ceiling. And I say to hospitals all the time, just because you didn't kill us or nearly kill us doesn't mean that we have the experience that we deserve. And so we need to raise the bar and actually figure out what makes a 5-star experience for Black and brown birthing people. I'll settle for a 4. We know our system needs work. But we can help you define that and then hold that to the standard. The other thing that I remind hospitals is that the reason why Black and brown folks are not responding to their surveys, and our community tells us this all the time, is that they don't know where those surveys are going. They don't know if anyone's reading them. They don't know if anyone cares. Many people tell us that they don't know if they're being tracked and they have to return to these health systems for taking care of themselves and their children, so they simply don't respond, right? And so that's part of the trust gap. But transparency is the fastest way to repair trust, right? In any relationship where trust has been broken, I'm asking anyone in a relationship to co-sign, someone's going to have to be transparent for that relationship, for that trust to be restored. And so we actually offer them an opportunity to repair their relationship with communities by being transparent. And that's been an invitation that we're excited that many hospitals see. We also offer them an opportunity to be the first Earth-approved hospital. We think that our accreditation is the most important one, right? The fact that the community is saying that they feel seen, heard, and respected in your facility is for us the most important badge of approval that you can earn.
Yeah.
And so between the carrots and the sticks, we find a way to work together. And the hospital is actually a partner in creating these solutions, executing what we learn, implementing the strategies, and then again, earning something at the end of it.
That's amazing. Yeah, we'd love your questions too, if you want to chime in. But Melissa, let me ask you, you've worked in tech, you've worked in a lot of big businesses. Like how are you partnering with some of the different sectors in our health system?
Well, Mommy partners with insurance companies, health systems, large networks of hospitals, and large medical groups to provide wraparound prenatal and postpartum support. And we support families all the way from conception through baby's first birthday. We do that as a team of maternity care providers that complement the obstetric and pediatric care that is traditionally provided by an MD, possibly a midwife or family practitioner. But what we find is that one way that we can be a part of a solution that augments and improves the course of care, the experience of care, and ultimately the clinical outcomes for Black birthing individuals, and then more broadly for all birthing individuals across the country, is through the inclusion of wraparound maternity services. That includes, for example, doula care, lactation support, mental health and nutrition coaching, social needs care coordination, and also remote patient monitoring performed by registered nurses certified in obstetrics. So these are all traditional service lines that are very common in maternity, but often not standardized at the level of, you can think of it sort of as enterprise healthcare. So not every hospital has all of those service lines. Not every insurance company covers the benefits that include those kinds of services. What we're doing is making it very easy for very large healthcare organizations to have a plug-and-play solution that turns on those service lines for their entire birthing population. Because we have such a strong focus on health equity and a very particular lens of inclusion and active listening to the needs of families and birthing individuals who have been historically marginalized and underserved, we are especially effective at producing those kinds of clinical outcomes that we know are possible across these populations when folks are seen, heard, and supported. So we work with lots of different kinds of organizations and lots of populations, but we have purpose-built our solution to reach the folks that, as you've heard from Kimberly, are often the most difficult to reach because that trust has been broken. So it's so important to have different kinds of solutions. We're just one layer of this model, very focused on care delivery. That's what our organization
does. And I know some
does.
hospitals that have partnered with you have said that you're actually helping fill gaps because we have all these provider shortages.
And
that's amazing.
ultimately saving lives because it is very much the role of the frontline providers, as you've heard from Simone as well, that are providing that support, that extra touch point, that extra check-in, that catch the concern that might have otherwise gone overlooked or not known at all by the traditional medical institution, simply because there were limits to access to care that someone had, or the issue showed up between their time gestation appointments.
Yeah, great. I think we have a question in the audience.
Yes, we have a question here from Yaya, who's one of our STAT scholarship winners.
Okay.
Hi, I'm a medical student from Minneapolis at the University of Minnesota. My question is, we had a session in my global health elective from the Earth app, actually. This is one of my sessions, and it was very interesting. But my question is, are there any future efforts to work with medical schools and nursing schools? Because I know we focused a lot on hospitals, and all of these problems stem from early on in education. So are there any future efforts or plans to work with education or medical schools in general?
Yes, thank you for that question. Thank you for being in medical school. We have a 4-year commitment in Minneapolis, starting with Hennepin Health. So, of course, right, we know that our database has many uses, right? And part of that could be potential for provider education, certainly student education. And so, yes, that is certainly on our roadmap. And I will say that one of the things that we do right now is that in our Earth App reviews, we often see a lot of comments about residents. And so we take that back to those residency programs when we're working and when we're analyzing our data. And so right now we are responding specifically to concerns and things that we're seeing in the reviews. And we know that our database can be instructive. And there are several partners across the country that we're in conversation with about using some of our data to actually be more instructive earlier on in medical school. So we're excited about that.
That's great.
And you need more than just one session. That is for sure.
Yeah, bring that back to your teachers. We have a question here from David Patterson from Colorado State University.
Hi, can you speak a little to your fundraising experience?
Sure. I'll take that one. So we are a venture-backed health tech company. And that didn't come so easy. I think there was someone on the stage earlier today that said, we didn't really have to fundraise. I mean, they kind of just came to us. So I wish, historically, that is how it was. But look, we sit at the intersection of being, I think we all identify as women and also as Black women. And we know those abysmal stats that about 2% of all venture funding goes to women overall and less to Black women. But I will tell you a very quick story, and that is that, so I had that first pregnancy loss in 2016. I've had many since, but I actually didn't start building Poppy Seed Health until 2019, and we were scrappy MVPing on WhatsApp, really getting to that product market fit and figuring out, is this a venture backable business? My entire background is in building startups, like rocket ship startups. So I knew some of the underbellies and the pitfalls, but we were one of those companies that when we all went into isolation across the country in March, early March, my last human hug outside of my own household was with a friend who was a VC, just to get some warm feedback. And it just so happened that birthing people across the country did not have people that could support them in the hospitals. It was a very uncertain time for us all. Instead of raising around, we went heads down at Poppy. We grew 143% overnight. And by the time I picked my head back up and a few months later actually went out and had some of the data points that were on our roadmap that we weren't even thinking that we would get. Until then, we had a product that people were paying for, and we had a product that larger healthcare systems and health plans wanted to pay for. And we built community, which is the most important thing. That infrastructure and tech coming together with community made a huge difference. We were able to raise in about 3 months, and we built 3 products in 6 months because we knew exactly what we were building. Yet, in that year, and this is not something that I was number 88, the 88th Black woman in the US to raise more than $1 million in funding. That's not don't clap for that. Like that's abysmal, right? I know my partner here, Melissa, also has raised millions of dollars, but it's hard fought. And so looking at venture, but also looking at other sources of funding are so incredibly important. And I told you the story about the product because we have to work even harder to show this product market fit. And it's just constantly an uphill battle.
I'd love to ask you, Melissa, I mean, you announced $9 million in funding recently, 2 years ago. Big names, Serena Williams, Mark Cuban, Goldman Sachs. Can you talk about that and how you've achieved that kind of success?
Well, as Simone says, it's absolutely hard fought. I'm proud of the progress that we've made with our company and the funding that we have achieved to date to further our mission of making the U.S. the best place in the world to give birth. But I also recognize that there are companies that have raised much more in funding, in VC funding. There are a number of companies now that are private equity backed that have access to a lot more in terms of resources to tackle challenges across the women's health spectrum. But maternal health in particular is a really unique space. From a VC standpoint, it's one that gets a lot of attention, a lot of talk, but still truly it doesn't have the VC backing that it needs to be able to flourish as a market. There are a lot of great solutions out there. There are more coming in all the time, again, due to the attention that this issue does receive, but it's really still not matched against the amount of resources that would be needed for organizations like ours and others to be able to fully commercialize and scale these solutions in market. One thing that's quite unique about the solutions, I think I can speak for the three of us and sort of our cohort, we all know each other, is that we actually, as Simone said, we have the data to show that what we're doing is actually working. We've had that for quite a while. That's something that's quite unique about the founders in this space, is that we've had to be extremely product oriented and deliver what folks are needing and show those results very early on, because the pathway to funding has always had a few extra hurdles in it for founders like us with solutions like ours. That's just the reality of being in this space. I don't see that changing as quickly as I'd like it to, but I think that there are lots of folks in the room that can be a part of the solution. And Simone noted that it's not just venture capital that should be and could be available to folks working in women's health broadly and maternal health specifically. There's lots of different avenues for funding and partnering with organizations like ours to help commercialize and scale these solutions that have already been demonstrated to work.
Yeah, so opportunity here. And Nick, I have to ask a favor. I can't see the timer because of the stage configuration. So
We're at 7 minutes.
we have 7 minutes left.
Yes. and we have a
Okay,
question over here.
great. Okay, let's take that
Great.
question.
Go right ahead.
Hi, you've talked about product market fit. Can you talk a bit about any unexpected barrier to adoption for your technologies?
Yeah, I'll go first on that one. So we are really proud to be building poppy seed health for as many people as possible, right? One of the things that I didn't mention is when I said I quit my job, I became a doula myself, and then I started Poppy Seed Health. So I was supporting clients that were across a full spectrum, people who were experiencing homelessness, who were unhoused, who had transportation insecurity, to people who were living in mansions and didn't have health insurance by choice and seeing the best doctors. And what that showed me was that and we'll talk a bit more about this in terms of trust, is that not everyone will answer the same questions at the same time. And so when we put our product into the market, when Poppy Seed Health actually launched, we realized that no one was getting past question 4. We're like, why isn't anyone getting past question 4? Well, it's because it was the insurance question. Even though anyone on Medicaid was able to get Poppy Seed Health for free, we had to change that question because it's a trust question. And that kind of trust question, we redid our entire self-reporting onboarding to make sure that we were making people feel like they could trust us before they got into a chat. And we know within 17 seconds or so whether or not someone will stay in that chat. We know the number one predictor for people to to use poppy seed health and to see the outcomes on the other side for them is if they get into a chat with one of our advocates. So we had to remove those barriers very early on. And as a truly a pure tech company first, that's expensive. Paying developers a few $1,000s every couple of weeks or so to have to, reconfigure the Tetris roadmap and be that responsive and agile can be really expensive, especially early on. So trust questions, number one thing for us.
Yeah.
I will
Can I
say
jump in?
I will say that one of our biggest barriers is probably cultural. First of all, just to the other conversation, now Earth is a project of a technology nonprofit, right? So I get to learn from my sisters who are in the VC back world, but we're in the grant funded back world. And I think that what we learned was that our community actually had not been socialized to think that their story mattered. They had been so beat down that what happened to them didn't matter. There's a terrible narrative in Black maternal health that you should be lucky to be alive and your baby's alive. And so when they have these traumatic experiences, but yet they are alive, they were like, I just want to move on, right? They don't want to think about it. They just want to keep it pushing, as they say, right? And so for us to actually let them know that their story was valued was one of our biggest barriers, for them to trust us and for them to want to share, because sometimes we're asking them to share something that may be a little bit traumatic, right, in their Earth App review. So we activated local Earth ambassadors. We work with birth workers in 12 cities who help us in the community. They are our trusted advocates. They are in the community helping people complete their Earth App reviews, talking about our product. I let them know that I read every Earth review. My therapist tells me not to, but I do it anyway. But that your story matters to my whole team and to everyone. And this is the movement that we're building in every community that we're in the ground. We now have reviews from 46 states, and we're really proud to create the message to our community that in Earth, your story matters, but that is something they have not heard. So that has been our biggest barrier.
That's beautiful. Melissa, how about you?
Oh, I think it's so powerful to hear that there are things that can, even within tech, with the best intentions, can actually create additional barriers to access to support. And we experienced that as well. And interestingly, one of our questions was zip code. So you heard from Simone and on insurance. And these are the kinds of things that through really precision, product management, you could say, and looking at the data, understanding how to create pathways to access care. And especially for us, because we're so oriented around care delivery itself, we are a tech-enabled healthcare services organization. So first and foremost, we want to make sure people can actually get access to the care that we're providing. And if people are getting hung up on a zip code question, in maybe another setting, you might say, oh, well, maybe it's there's something about the field, the text field and typing in, or there's something about the interface, or it's not showing up correctly, or it looks different on mobile versus web. But we tested all of that, found that, no, that wasn't the issue. It was the question itself. And that we are talking about reaching communities, reaching people in communities that have been historically marginalized by their zip code. One of our biggest projects to date has been with MedStar Health System across the DMV market, and specifically supporting Black birthing individuals in the DC metro area across wards 5, 7, and 8, historically Black communities, which there are no birth centers in any of those wards. And so if you are in a zip code associated with those wards, there's already a feeling that someone has written you off, the system has written you off, and not provided for you to have access to this care in your own community. You may be traveling by multiple modes of transportation through multiple communities just to be able to get to an obstetric appointment, or to be able to get to a birthing facility for a safe, joyous, and healthy birth experience, of which when you get there, you still don't know exactly what kind of treatment you're going to experience.
Yeah.
And so imagine just the zip
stop so
code being.
we're running out.
Yeah,
We
go ahead.
want to get to the last wrap-up questions. We just had a panel with startups, and I know people are thinking about how to improve healthcare, what opportunities are out there. And so I want to ask you, Kimberly, is there space in this for others? You've got 3 incredible business models here.
Absolutely. I mean, this is an all hands on deck problem that requires all hands on deck solutions. But I do think it's important to consider whose hands are going to be joining the deck. We know that there's a lot of commercial interest, a lot of folks coming into the space purely because of, a potential for profit. I get these messages on LinkedIn literally every day. People who have no history working on this issue, have no connection to community, are not proximate founders, but see a potential monetary or profit motive and all of a sudden care about maternal mortality and maternal morbidity. And for me, that's not the way forward, right? There are so many folks who do have that experience who are here. Those should be resourced and make sure those solutions are properly funded. And then we can actually look at what is actually necessary, because a lot of things are already being done in community, but people haven't looked. There's been a lot of arrogance to assume this isn't happening instead of the cultural humility to ask who is doing this already and how can that be built upon.
Right. And I think the last thing, what do we want to end on is joy, right? This
Absolutely.
is a really tough problem, but it just seems like there's a lot of optimism, would you say, Simone?
Yeah. Look, I think there's optimism mostly because we've all taken really bold steps to making space for people to be able to show up and share their stories and also be much more open. Like, I'm very thankful that we are in the age where, and the stage and the places where we can participate in our care. This is no longer one directional. It is bi-directional care, right? We can participate and collaborate in our own healthcare and have the tools and be empowered to be able to say things to our providers and our clinical teams that say, like, that didn't feel great, or I'm wondering about this, and not be on the offensive or defensive. And I really believe deeply and truly that it starts with our feelings first, right? And that emotional and mental health support, the thing that usually causes so much trauma, and you don't even know that that's where it starts, but knowing that you have a pathway forward, and also that you're owning, you have ownership over your own care and over your own bodily autonomy and decisions is really important.
And all these incredible tools that you three have created. All right,
Thank
please join
you.
me in thanking our panelists. Thank you.
Please welcome to the stage Professor and Chief Research Informatics Officer at UCSF, Dr. Ida Sim, Managing Director of Human First, acquired by Icon, Andy Korovos, and to moderate, Mario Aguilar, Health Tech Correspondent at STAT.
Hello. 36 hours ago, I was the patient. I was in the emergency room at New York Presbyterian, and I was like, "Doctor, do whatever you need to do. I have to do this panel in San Francisco." So they gave me this wearable device. But today we are going to talk about other ones. Unlike a lot of the stuff that we talked about today, there's probably a lot of the technology that we're going to talk about today. It's these. How many of you have one of these? A wearable device, ring, watch. Your phone might actually be serving this purpose. How many of you are doing that for some kind of health reason? That means the marketing worked. Today, we're going to find out whether there's anything else to that. Before we get any further, first, Andy, these devices are measuring stuff.
Mm-hmm.
How do we know that what they're measuring is true, and should we trust them?
That is a great question. So for folks who haven't met me, I'm Andy, and I was the CEO of Human First. We just sold the company to Icon, so I'm now managing director there. In a past life, I worked at the FDA in the digital health unit. And one of the big frustrations that I had when I was working at the FDA, I was an EIR there, is people would ask, is this validated? And the big question often is, what does validation mean? So if you're a software engineer, the way you validate software could be very different from how you might validate genomics data or how you might validate like a blood-based biomarker. And so we first had to figure out what that meant. So when I left, we found a number of different folks because these sensors, they don't know if you've taken a step. They look at your height, weight, age, they look at the gyroscope and accelerometer, and then that predicts whether or not that thing is a step. So effectively, we split out this validation question into, has it been verified? Has it been analytically validated? And then has it been clinically validated? So that's what's called a V3 process. So I know we're going way too deep here, but I'm going to just let everybody know if, should we finish or should we go to the next
go ahead.
one?
Finish.
All right. Because I know all of you are asking. So, okay, this is your cocktail question. Verification. If somebody drops the sensor, does it register something? Analytical validation is if you walk 100 steps, does it measure 100 steps? Clinical validation is, does a change in your 100 steps mean something for your depression or for your PTSD or something else? And so being able to say, is it true in what context and at what level requires scientists, clinicians, ethicists, lots of different people understanding that context. Many of you are part of that question. And so it's really on a spectrum. So thank you for letting me intro in a very nerdy way.
Well, and I think just important to highlight, who is making the decision about what we decide to measure right now?
So there are many people who are making different types of decisions. Some people might think that the FDA or your regulator makes that decision. But what the regulators do is they're just evaluating your marketing of that decision. So somebody is making a drug or they're making a device and then they propose some sort of marketing around that, and then the regulator is deciding whether or not that marketing is permitted. So what is it, the gatekeeper? Is it the creator of the game? And then is it the person then who chooses to use that product, the one who's actually like deciding that? But what I can tell you is very rarely is it the patient in that whole set of developer, regulator, and implementer of that process.
And I guess so. We can measure things. Let's give them that much. How are these things that we're measuring being used today in care? And both from your perspective as a clinician, but also how are patients using these things?
This is not a marketing success. It's really not being used in the clinical environments that I'm part of, and I'm a professor at UCSF. I'm a primary care clinician. My patients really run the gamut from professors and people who are working in tech in San Francisco. Many of them are elderly Chinese-speaking patients. It's really not used that much at all. I don't routinely use sensor data, Oura Rings, Apple Watches. A few patients might come in and say, here's the heart rate trace. Yesterday, I saw a patient with type 2 diabetes who has a continuous glucose monitor. I know we want to talk about that. And so she's been tracking her blood sugar every 5 minutes, and it's poorly controlled. She's been under the care of an endocrinologist, and sat with her for almost an hour yesterday. I couldn't get to her CGM data. She had it on her phone, but the report goes into a website that I didn't have the login to, and it hadn't been downloaded into my electronic medical record. So all this track data, I didn't have it. And actually, even if there were a decision support that said, well, for this person's diabetes, she should have been on this set of drugs, she had pancreatitis, a history of pancreatitis, neuroendocrine tumor status post-Whipple resection. She had renal failure as well.
So you can't just say, well, how do we treat her diabetes? We have to treat the whole person. And I think that's kind of where I'm seeing a mismatch between what the digital health sort of ecosystem is addressing, which is how do we have solutions or sensors for one disease, and yet, we don't treat diseases, we treat people, right? And each of us have our own unique set of conditions. One day, tomorrow I might have different diseases than I had yesterday. And what we need are tools that help us optimize across all our conditions and not just each individual's, disease. And I think that's kind of where the mismatch has been. And I'd love to see the ecosystem going forward think much more holistically about what it is we're trying to optimize.
Well, it seems like in some ways there's a mismatch there between this vision that you're presenting, which is very optimistic and beautiful, but it seems like the breakdown is happening way before that if you cannot even get at the data, right?
Oh, yeah. Yeah, but I think there have been more standards that are, have been propounded, the Smart on Fire. I think the uptake of FHIR is a lot better. I think the US CDI, the US Core Data Interoperability Data Set, that actually all of us here right now, in a matter of seconds, you can use either your Apple phone or your Android phone and get your core electronic medical record data from practically any healthcare system in the US. You can do that right now. We just don't tell people we don't know what to do with it. But I think the pipes are there. The data is somewhat flowing. I think a lot of the digital data needs to be standardized, but it's starting. I think that the pipes and the infrastructure is starting for us to get to that kind of more composable, modular, holistic vision.
Andy, your company helps a sort of different, still patients in some ways, but you work for big drug manufacturers who need to measure things in their clinical trials. And I think first it'd be great to just hear about some of the novel ways that they've come of measuring things, either the Duchenne example or nocturnal scratch and atopic dermatitis, but then maybe paint for me a vision for how some of that data eventually makes its way, or these tools that are being developed in that context by the world's biggest corporations makes it to IDA's patients as well, to more general healthcare context.
Yeah, definitely. So for folks who don't know, and I assume most of you do, but for folks who haven't been as close to drug discovery, so we work in research, which means that we don't have patients directly. We might have participants in a clinical trial. So that means that the type of patients that we would work with are generally a very clear population group. There's inclusion-exclusion criteria, and we're part of generally what's called life sciences, less than on the healthcare side. So with part of that, we work with predominantly pharma companies, but often biotech companies as well, and they're designing what's called a clinical trial. And in that clinical trial, you have something called a protocol. And in the protocol, you effectively set the rules of the game, where you're going to have a drug or some sort of intervention, and then you measure the outcomes of how that might work. So when people are designing trials, they often look at the old tools that people have been using in the past, because if you change the endpoint, do you know if the drug didn't work, or was the endpoint not the right endpoint? And so it can be really tricky. So one of the things that's hard that I'm excited about is if we only measure whether or not you died, then you can't really develop new types of drugs on that, because you're just going to try to optimize, can I have you live 3 months, 5 months, 10 months longer, not can you pick up your grandkid, can you sleep better? And if you think about pharma companies, they're not bad. If someone's like, why aren't you measuring sleep? Imagine you're sick and you're in a clinical trial and you're trying to live your best life. And Pfizer's like, hey, how'd you sleep last night? And you're like, terrible. And you're like, how'd you sleep last night? You're like, still bad. Why are you still asking me this data? And then everyone's like, why are the patient diaries so bad? And you're like, they're terrible to fill out. But of course, I'm very supportive of patient diaries, and I'm supportive of clinical outcome assessments, because I hope we can track them, and there's a whole movement to make these more accessible to people. But people want to be normal people and not have to track these things. So collecting passive data can be really powerful for folks. And so, for example, to put that into context, Duchenne's muscular dystrophy. The primary endpoint in Duchenne's is a 6-minute walk test, which means you get up and you do effectively a walk around a track, or some pathway if they have a pathway. And 70% of men who have Duchenne's are in a wheelchair. So they are excluded from their clinical trial just because of the endpoint in their trial. So if you wanted to shift to something like a different type of performance outcome, people are looking at using an upper arm mobility performance measure. And if you change that, then you can actually include more people into the clinical trial and pass it on. I'm happy to go and share more examples, but there have been over 100 pharma sponsors and biotech sponsors that have now used digital measures and submitted them to agencies, which is really exciting to me. Trials can take a long time to go through, but that's going to be a really robust set of evidence. And, you know, when you think about endpoints, you don't have Pfizer blood pressure and Novartis blood pressure and AstraZeneca blood pressure. As we develop these measures over time, they eventually will hit clinical care. And when we first had blood pressure, no one even knew what that was. Can you imagine the first person who thought about like a blood pressure measurement? You had to develop a set of evidence around like what that meant in context, and that's what the industry is starting to do now, and it's definitely in the early days.
Ida, what do you think of that? Is it going to trickle down?
It's a trickle all over. I think the notion of common data elements is really important. And, you know, we're moving to this world of real world evidence where we shouldn't only be asking questions, what works and what doesn't work and for whom in the clinical research setting. It's not like once you've figured out Duchenne that you then come into the clinic. We don't ask any more questions. I have a ton of questions. I want to ask every day. And I would like to get answers as a process of care. So this notion of real-world evidence, of the learning health system. So there's thinking about these variables that Andy's talking about. They should be variables that we collect in healthcare as well. Collect once, use multiple times. Collect once, use for clinical care. Collect once, use for research. Collect once, use for patients to take care of themselves. 40% of Americans have 2 or more chronic conditions. That's heart, lung, cancer, diabetes. And I'm a primary care doc, but I will tell you, I do not manage chronic conditions because it's my patients who manage the chronic conditions, and we're doing so little to help the people who really manage disease. So I think as we start thinking about variables and how we capture them, whether they're active, whether they're passive, it's a conversation amongst all the stakeholders together. And I think sometimes it gets hard because the regulatory science has a certain need, pharma has a certain need, investors have a certain need, and those of us on the messy front line of clinical care have different needs. But you know, if we could knit it together, that would be, I'm on the possibilistic, optimistic side today. That's the vision that I think we should be going towards.
Nick, you have somebody?
Dr. Sim, I was a long COVID patient, and I used my Garmin to convince my doctors in 2021 that I actually had something wrong with me. And so I relied on a device that isn't necessarily most commonly used as part of the V3 framework, which I love. What does a system look like for you where people are using devices that they wear all the time in their regular life to convince doctors or show that data to you? I know you had the CGM example.
Yeah, I think it's a really important point that I learned from sitting down with a patient for a long time, was that oftentimes patients have a story about their condition, and it's hard for doctors to get the story, but if there's data, then they see the story. And I think that's part of what these tools and technologies allow us to do, is to allow us to tell stories to each other in a way that helps what we each need to do. And unfortunately, for people who have complex diseases like long COVID, sometimes we do need that story before the health system even can listen. So I think the power of data is really important. But in some sense, going back to your question, Mario, is data in and of itself is a choice. What you collect, who you collect it for, the patient makes the decision about which devices they wear and which they choose to share. And there's this real signal in there, what people choose to track.
Can I respond to that? So one of the big things I struggled with is so when I first started solving this problem, I was like, who needs regulators? You know, we should just go straight to the patient. There's so many more things. There's so many roadblocks. And then of course, plot twist, I ended up at the FDA, but I was like, we don't need this anymore. These are just we should all just be able to use our own tools. The patient will see you now, and then let's move forward with that. But then I was like, well, how do I know if these things are any good? And what are they actually measuring? And then I saw a study that really chilled me to the bone, because I'm a software engineer and I love open source. I want to give away everything for free, release everything for researchers. Let's do that. I'm obviously not great for VC, but it all worked out. And so the thing that struck me is, if somebody sleeps badly and then you tell them they slept great, they perform better on cognitive tests. If you sleep well and then you tell them you sleep badly, they perform worse. So when you're measuring these tools and then your Oura rings you did well, or you didn't do great, or you have some, something, your performance can change. And so what ends up happening, or I don't know if this is still true if you're a product manager out there, know this. What ends up happening is that people who measure without having a clinical reason to do so have higher rates of anxiety and lower social well-being. And so we ended up building a product that's just for researchers. And part of that kills my soul because of where we originally started. But it was also where do you draw the line to make sure that the things that you're doing are in the right context for the right pro-social behavior? And I struggle with that every day.
But I think part of this story there is that you've got your V1, V2, and V3. I think we have to think about model evaluation, which is just if we're talking about AI, for example, your AI model, and is it accurate? Does it perform well? But then you have to evaluate the solution, which is not just the measuring of the sleep, but what it's telling the person, right? So that's the solution. But I think there's another level, which, especially in a complex organizations like a hospital or a clinic, it's the overall system function. Because that AI model, if we think about, and we heard the bridge thing before, it's not just, well, is that accurate, but how does it change the dynamic between the doctor and the patient? And then how does it change the overall system? And I think we tend to think of these solutions in some ways like a drug. A drug is a fixed molecular entity. It goes through FDA regulation, it's done, you throw it out there, that's it, move on. But especially with AI and with these sensors that are always changing, or algorithms that are always changing, it's not a fixed molecular entity. And we need to continue to monitor, and we need to monitor it within the system and this human interaction with the device, right? Is how do you respond when you're told that you're sleeping well, when you're not sleeping well? So it's a whole set of evaluation methodologies I think we need to build. I'm very excited about going beyond the simple randomized trial. There are many other statistical methods, machine learning methods, causal inference. We're looking at that very closely in a new PhD program that I co-direct between UCSF and UC Berkeley. We just need to be thinking much more deeply about how we ask questions and what we ask questions of, and the methods that we use to get the kinds of answers that we really want.
Well, and I think what you both just said is that giving these devices to people and showing them their data is interventional in itself, right?
It is, very much so.
As you were saying before, you don't treat chronic conditions. People treat their own chronic conditions, and I guess how do you think about designing these devices and what they give to people, right? Not patients, so that they actually get better, and so it's not just a product that's being thrown out there randomly and giving people possibly the wrong advice.
Participatory design, I'm sure people have heard about that. I think whether we really do that or not, it also depends on the investment community and what they're supporting. And then, of course, bringing in communities that have been marginalized into the process. And I think that's very hard. I think we talk a lot about it. I don't know that we know how to do it. I worry a lot with AI that it's hard to reach out to communities that have a deep, deep distrust of science and AI and machines. And how do we bring them in? Because I think this is a very powerful technology, but if we don't have the right people at the table from the get-go, I don't think we'd be able to do a very good job of that.
Yeah. And I think it takes everyone to be an active participant in this. So a number of years ago, we started to see that some of the sensors weren't performing as well on lighter color skin as they were on darker color skin. And one of the things that was interesting for me about that is like not many people were talking about it. And so I ended up finding a researcher who put together a study, and then we pitched it to STAT, and then STAT was one of the first people that really covered this, which was great. And so I think people forget that like if you're in this room, you're part of that process. So if you're seeing things that you need to elevate or want to talk to, like you might have your friends in the room who can create that amplification, and we're all kind of like building this thing right now together, so you're on board.
We have an audience question right over here.
Sure.
Hi. Yeah, so I went to my doctor's and I gave him data from my wearable device, and I was like so proud of myself, you know? I was like doing everything right. And he looks at the data and he's like, what am I supposed to do with this?
Yep.
I'm like, dude, that's your job, right? And so I guess my question for you guys is like, whose job is it? Is it the regulators? Is it the doctors? Is it the health systems? Like, you know, who I guess is at the start of it all?
You know, I would say that the CGM data that I didn't get at, that wasn't in the medical record, I did have my patient's phone, so I was scrolling through her phone and looking at the data. That kind of high-frequency data for glucose measurements is not something I, as a primary care doctor, have been taught how to use. So I actually did not really know how to use it, honestly. So we're doing a project with the Division of Endocrinology at UCSF. And I've asked them, well, how do you use the data? And they say, well, we actually have a biomarker, which is the area under the curve for the 2 hours after, you know, a meal, whatever it is, the biomarker is. And if we have that, then this is how we use it. So they do have, you know, an algorithm, but what they do is they look at the numbers and they calculate the area under the curve for the 2 hours. And you're like, well, why can't we do that? And maybe we use it as a regulatory outcome. Maybe we use it as a care outcome. So I think it's a partnership with the clinicians and the data scientists and the sensor people. And we don't often sit in the same room, and we don't talk the same language, and there's a lot of impedance mismatch. But I think it's a joint effort.
I can share a few things that were surprising to me along my journey. I think, you know, I came from Silicon Valley where there's a lot of like, regulators are bad, we should deregulate like across healthcare and everything else, right? That's a very American thing, like let's have fewer regulations. But you forget the regulations are in because we needed to build trust in a system that lacked trust. Like we're running experiments on humans in clinical trials, that's a big deal. And yes, there's a lot of like bloated regulations, but one thing when you say, maybe ask like, whose job is it? Many of you know, but maybe you don't know, the FDA does not regulate doctors. Yep. Doctors are able to do anything that they want. The FDA is responsible for, it's a marketing agency. The way that the FTC is looking at marketing of products, the FDA is looking at marketing of medical products. And so it's largely just regulating what people claim to do. You can use things off label, you can do other things. And so I think that can be very confusing for people. In particular, there's different levels of products. So something that's FDA approved is very different from FDA cleared. And so if something has like a 510K, all you had to show was it looked like this other thing called a predicate and like no clinical data. And so people say things like the Apple Watch is FDA approved. It's not. It's FDA cleared, but it's also not the watch. It's the algorithms that sit on top of those. And so it's just it's like a hard thing to figure out the right balance of like allowing people to make their own choices, but then also like having a lot of noise in the system. I personally am very pro like more of a universal healthcare model where you have somebody who's like looking end to end and you're not doing all this caveat emptor things, but I know that's probably politically impossible here.
I think this fear of the fire hose is a very real one. And I think we're still in early days, and I think the model right now is we just give you the data and the doc knows what to do with it. We don't. But it does tell a good story sometimes, and I think we need to boil that data down into actionable digital biomarkers or biomarkers that help us tell a story that fit the picture together. And I think we're just not there yet. Because we just need to have different people in the room.
Which is you. You should be part of these conversations, and we're not there yet because you'll be the people that help us get there.
So we're reporters here, or I am anyway, and some of the other people are. And so this this panel is framed, I think, in a very typical like journalism way, which is like there's a battle, right? There's a battle between academia and industry, and there's like, you know, heads are butting. And I guess we're talking like everybody should get along, you know, that's basically the message here. I guess, so where is the perception that there is this battle happening coming from?
I don't know. I haven't heard that. I don't think there is.
So we made it up, is what you're saying.
Yeah, because it's journalism and it's better and it's more fun. No, I think I've been reflecting on the you know, this question about academia and industry, and you know, I've had this new graduate program that's UCSF and Berkeley. And you know, you all know that academia has come up with algorithms and digital biomarkers and sensors and drugs and great things. Academia also came up with a very powerful idea of open source software and open platforms. One of the most impactful ideas has been Jupyter, which is one of nature's top 10 codes in science. And it's a scientific notebook platform, as some of you know. And Jupyter has really driven many different types of sciences, climate, chemistry, all kinds, where scientists are sharing code and sharing data. And companies are built on this platform. And so you have this sort of smooth transition between open environments and academic environments that then transition into closed and proprietary and commercial, and it works. It works in like all parts of science and biotech. And yet, healthcare being 20% of the GDP, most of my colleagues had never heard of Jupyter. So I'm working with Fernando Perez, the person who founded Jupyter. We're making Jupyter Health, which will have data privacy, the ability to bring in secure sensor data. It's going to be FireAware. It's going to have open shared code and shared data sets so we can kind of do this validation, new digital biomarkers that we can test. And if it works, somebody can go commercialize it. So I don't see it as a battle at all. I think platforms like Jupyter and Jupyter Health are the bridge so that we can go back and forth, because that's how our people go back and forth. That's how our ideas go back and forth. And now we can have the technology and the software and the code go and the data go back and forth in safe ways. I don't think it's a battle at all. Sorry to take away your dramatic arc.
I have one for you on this
Okay.
one. Okay. Has anyone Googled the definition or looked up the Oxford English Dictionary definition of nature? So the word nature, you can look it up, of Oxford English Dictionary is like the system of animals, plants, blah, blah, of the natural kingdom. And then at the end it says, in opposition to humans and humankind.
Wow.
And I was like, wow, if we view nature literally as in opposition to humans, of course we have pillaging and we view it as like an other. And I think it's so human to want to create the other. Like if I really am honest with myself, I love a nemesis. I love having a nemesis because it creates something for you to push off of. And the nemesis reflects something in you, right? And so I think as we think about like the other, it's good in a system to have another and to have something else, because the thing I value the least probably is harmony, because I just don't believe in it. I don't believe it's all the same. I think you need somebody who is caring about security where someone else cares about data and somebody else has something else, and it creates like a stability in the system when you have kind of like this othering. I would prefer nature probably to be part of the human system, but like we're all part of some system together, and you have different agitators, and some of them are maybe more problematic for your state than for other ones. But it's good to kind of, I think, know who those actors are so we can all like push towards some greater outcome if we're all at least aligned in that form.
On that deeply philosophical note, it's been a pleasure to be a fly on the wall for this conversation. So thank you very much for coming.
Thank you all so much. Give them another round of applause. And Mario, we hope you get better soon. And with that, we are at our last coffee break of the day. Go out there, go get your steps in, go get some coffee, go mingle, maybe find a new nemesis. I don't know. But we'll see you back here at 4:30 for a fireside chat with Adam Feuerstein. That's Mr. Biotech AF himself, with Robert Bloom, CEO of Cytokinetics, and then Matt Harper is going to end off the day with a panel on drug development and AI. So we'll see you at 4:30. How's it going, everybody? Again, you guys have been such an incredible crowd. The questions we're getting, fantastic. So we're resuming the programming. If you can hear me, please make your way back. We've got 2 more excellent sessions. And then you guys get like the longest possible coffee break, which is the reception afterwards. But how's everyone doing so far? How are the energy levels? Can I get a little feel? How's it going? Good. Let's pick it up. Let's pick it up a little. Yeah, all right. Okay. So I'm very excited and I'm very happy that you all decided to spend your day with us. We know there are other conferences going on right now and such, but they're not like us. We really do it big here at STAT. We have fun. So thank you all so much for coming. I think we're having a good amount of people coming back in. If you can hear me, come on. We're trying to get back with the programming. Wonderful. Awesome. Okay, well, welcome back, everybody. Now, here to kick off the final part of the programming at this year's STAT Breakthrough West, please welcome to the stage Robert Blum, President and CEO of Cytokinetics, and to moderate, Adam Feuerstein, Senior Writer for Biotech at STAT.
Robert was chatting in the green room, and I had to Robert, we're on stage. Come on. Take a seat.
Thank you.
Oh, I think I'm sitting on this side. I'm being directed.
Hello.
Robert, how are you?
Very good, thank you.
Robert just concluded his board meeting, right, Robert? So
2.5 day board meeting. I'm a little wigged out.
So the acquisition is finalized. We're going to announce it here.
Maybe.
East Coast, wake up.
We'll
right?
see. We'll see how this goes.
So I don't know. Do we want to start? Is there anything you want to say to me first,
There's
Robert?
something I've been dying to say to you.
For like 2 years now?
At least
Maybe?
2 years.
Okay,
now.
go ahead. I'm going to let you start.
So it was about 2 years ago that I woke up one morning and I saw that Adam had designated me not one of the worst biotech CEOs, as I recall, but was making a case to be one of the worst.
You were making a case for it.
Making a case to be one of the worst biotech CEOs, which I promptly sent your article to our board, as well as to my mom and my wife and daughters.
Your mom didn't let me know about this.
Were you to make your way to Chicago, I think my mom might be gunning for you.
All right. I'll keep that in mind. I'm there in a couple of weeks.
My daughters, similarly. My wife might agree with you. But I took your article, to be quite fair, I took your article and I pinned it on a board in my office, sort of like locker room inspiration.
Perfect.
And in the intervening 2 years, I'm hopeful that I'm making a case that maybe I don't qualify anymore.
So for people who don't know, because I've been doing this a long time, I do put together two lists every year of the worst and the best CEOs in biopharma. And yeah, so this was back in 2022 where you were doing some things and people were a little bit unhappy with you, and so you were like a contender. But to be fair, you weren't on the list that year.
I didn't make the list.
You did not, so that was cool.
What do they call it when you're kind of a runner-up?
But you're eligible now maybe for the best list, so that's good.
That's
right?
what I'm aspiring for.
But I appreciate that this has been motivation for you. So I'm glad we can clear that air. So let's talk about cytokinetics. Let's talk about aficamten, which is your drug for heart disease. That lots going on with you guys these days. Obviously, starting back in December when you had the positive phase 3 study results. After a long development period, these things take a long time, and I know that was a lot of work. And now you're kind of gearing up. So why don't you just give people like a thumbnail sketch of aficamten, what it does, the disease you're treating is obstructive HCM. Maybe just give a brief explanation of kind of what the drug does.
Sure. So aficamten is a small molecule inhibitor of an enzyme called cardiac myosin. Myosin powers the contractility of your heart muscle. And by inhibiting this enzyme, it suppresses cardiac contractility or the mechanics of cardiac performance. And that's therapeutically gainful in a disease called obstructive hypertrophic cardiomyopathy, where there's excessive contractility resulting in high pressure gradients for patients who can suffer high symptom burden, even mortality risk. And the goal there is by suppressing cardiac function, suppressing cardiac performance, reducing pressure gradients, these patients can live a more normal life, improved quality of life, lesser breathlessness, and better exercise capacity, exercise stamina.
So phase 3 study results came out in December. It was like right at the end of the year. You're headed now to the FDA, right? So you're going to be submitting it to the FDA when?
So the goal is to be submitting a rolling submission to the FDA in Q3.
And what's in terms of like market, like how big is this indication?
So it depends who you ask. We look at it as could be as many as 150 to 200,000 symptomatic eligible patients. Today, there aren't that many diagnosed, but we believe there are more prevalent than currently symptomatic and diagnosed. It qualifies as an orphan designated disease, and we have orphan designation for aficamten.
So what has made your company and what you're doing so interesting to a lot of people is just that there's a sort of a precedent. There's a drug out there called mavacamten or Camzyos that was developed by a company called MyoKardia, which actually originally came out of Cytokinetics, that was bought by Bristol Myers Squibb. They're on the market. And a lot of the debate has been around, the difference. Now, obviously, these two drugs have not been tested against each other, but that doesn't stop people from making the comparisons between aficamten and mavacamten. Tell us a little bit about why you think your drug is the better drug.
Sure. So I won't say better. I'm not going to make a comparison.
Sure.
But I do think it has next-in-class properties. So starting with our spin-out of MyoKardia, if I might go back. So there was a time in all biotech companies' lives where you have to make choices about which programs you advance, which ones maybe you don't. And we were advancing a myosin activator called omecamtiv mecarbil for the potential treatment of heart failure, where cardiac contractility is suppressed and you want to augment it. And as a company, we had limited access to capital. We had to make some tough choices. We worked with Third Rock Ventures to form a new company called MyoKardia, which was capitalized by research and compounds arising out of our program in cardiac myosin inhibition. And Third Rock sponsored our chemists to optimize these compounds. The company incubated in our labs for 18 or so months before it spun out, started hiring its own people. One of the compounds that we contributed was called mavacamten, and they then developed it very successfully, I might add, to the point where it was successful in clinical trials. BMS acquired MyoKardia for $13 billion. During that period, MyoKardia elected, with its own then independent management, to pursue myosin activators in its collaboration with Sanofi, and we thought, well, heck, that's not really very nice. They're competing with us. So we went back into the laboratory and thought, well, we know mavacamten, it's a good drug, but we think it has certain liabilities that we could perhaps come up with a better next-in-class compound. And we believe we have done that. Aficamten was designed to have a shorter half-life, a flatter relationship between its exposure, pharmacokinetics, and pharmacodynamic effects, less in the way of reproductive toxicology, no clinically meaningful drug-drug interactions. So we developed it as a potential next-in-class compound, as may ultimately become physicians' choice for this category of medicines. And in this trial, Sequoia, which read out by top-line press release in December, we only presented the data and published them Monday this week, this past Monday. That study demonstrates what we hope to be a next-in-class profile, one that would be enabling of labeling, that would be differentiated risk mitigation strategy that would be different, perhaps even efficacy that's different. The study was very positive, hit on its primary endpoint with large magnitude effect, hit on all 10 pre-specified secondary endpoints. And we go forward with hopes that we could submit it to FDA. Ultimately, it would be labeled as could be useful in enabling of more patients to get this medicine, more patients and physicians to be comfortable with it than is currently the case with maybe 5 to 10% of patients getting mavacamten today.
And one of the key issues there is the risk mitigation, right? With Camzyos, there's a REMS plan in patients. If their ejection fraction falls below a certain threshold, they have to go off the drug. Is that correct? And so is the idea with your drug is that maybe you can dose down a patient instead of having them stopping the drug? Maybe that's a... someone wants to buy the company.
No, not quite
okay,
yet.
Sorry.
I'll keep you posted.
Stand down, people. Stand down.
My bad. This is where I need help. Got it.
But it's that risk mitigation, right? That's one of the key, maybe differentiating factors between your drug and the Bristol drug.
Exactly. So our hypothesis right now in our base case scenario is that based on the profile evidence, not only in the phase 3 study, but also an ongoing open label extension, we've not seen any patients who had to dose interrupt. We, with aficamten, are not seeing any patients who are developing heart failure symptoms, even when there's the occasional EF excursion. EF stands for ejection fraction. Aficamten and mavacamten produce a pronounced effect on reducing gradients that comes with an effect of reducing ejection fraction. You can get too much of a good thing that way, and you can overshoot. With aficamten, the drug has rapid onset, rapid reversibility. A down titration seems to be sufficient to be enabling of safe use, such that one doesn't need to stop the drug and restart it down the road. And we hope FDA will be accepting of this as a strategy with this next-in-class drug to be avoiding what could be a restrictive REMS program.
So we've been joking about the acquisition thing. Obviously, the stock went from about 40 to 80 on the results. It went up to about 100 in early January on the speculation, right, on whether or not Cytokinetics would be up for sale. Somebody, a pharma company, would come in and acquire it, just like Bristol did with myocardia. How do you think about what you want to do with this drug? Commercializing it yourself, putting the company up for sale, or doing something, a transaction like that?
So if you look at this company from its origins, and this is our 26th year, we've always been focused to a business model that's somewhat old school. We were talking in the green room about Genentech and my roots in this industry that go back into the early 1980s. In building this company, I took what were hopefully lessons from other companies that preceded Cytokinetics in ways that produced enduring value for shareholders and patients. And one of the things I've learned along the way, and all of my experiences prior to Cytokinetics also tie to cardiology, is that in order to build something meaningfully valuable, you have to have a portfolio built in a particular biology and pharmacology. And at Cytokinetics, from its first beginnings in 1997, 1998, we've been focused on this science and the goal to produce a multitude of products built around it. So we've always had intention to focus to this biology, this science, this clinical research, and ultimately commercialize that ourselves. My background started in pharmaceutical sales. So I've always had a view to how we can build a valuable commercial business rooted in this same science. It's interesting, as we had positive phase 3 data, all of a sudden people started looking at us as an acquisition target, and we were rumored, and there's articles in many different publications about what were speculations around our M&A thesis. And we have engaged in lots of business development discussions, and as I've always said, as CEO, I have an obligation to be a good fiduciary. Anyone knocks on our door, we open it, we talk to them, and we consider what's in the best interest of shareholders. But at the same time, we're pushing forward, as we always have, with the original intention to build a commercial business. And that's not something new. That's not something that's a result of a failed M&A dialogue. It's something that enables us to control our own destiny until such time as it may not be in our best interests or those of shareholders to do that. And we are continuing to execute on plans that have been anchored into our business plan from the beginning as long as that makes sense to maximize shareholder value. So we're readying to go commercial, we're readying to launch, we're readying to do that not only in North America, but also in Europe, because we can, and we can do it with a limited sales and marketing infrastructure. We believe that there's right now roughly 400 doctors who are accountable for 80% of the Camzyos prescriptions. At most, 8,000 to 10,000 cardiologists would be writers of these potential new medicines. And with a sales force, much like I've built in 2 prior companies, which went from, in those cases, next in class to best in class. Similarly, at Cytokinetics, I think we can, with roughly 150 salespeople at most, we can build a formidable commercial business.
So that's interesting you say that, because conceptually, I think people, when people think about cardiovascular disease and that as a commercial market, people think about it as a pharma market. It's big studies, oftentimes big outcome studies, big marketing sales forces. Where it's more difficult for a biotech company, even if they successfully develop a drug, to sort of have the balance sheet and the infrastructure to sort of do that. And in this case, obviously, there is a pharma company out there who's marketing a drug. But do you feel like you can do those sorts of things? Do you think you can compete against?
Unequivocally, yes. It's true, most biopharma companies have been focused to cardiovascular segments where they do need large sales forces to compete, oftentimes with sales forces even much larger, and competition of generics. That's not the case here, and I think here again, borrowing a page from the playbook of other biopharma companies that have preceded us, look at Vertex in cystic fibrosis as an example. You can build a franchise model in a specialty care setting where you can, with limited investment, have a high return on sales. And I think we can do that here. The key being you have to have a cohesive R&D and commercial corporate development strategy. I think we do. You have to have a multitude of products that ultimately will be marketed to the same customer segment. And I think here, specialty cardiologists who treat the most severe of ill cardiovascular patients, you can do just that. And I think we're on our way to build what I think can be a company that can compete effectively. But however, it's not our strategy to compete directly with BMS. And in that way, we learn from BMS. If you look at how they went to market with Eliquis against other anticoagulants, it was all about growing the category. And ultimately, they got dominant share in a much larger category. Here again, I hope we can do something similar.
So we mentioned the stock price over $100 in January. It's down to about 60 right now. So you've kind of lost some of that value. You talk about shareholder value being important, and having that fiduciary responsibility. What do you think the market is seeing in the stock today versus like maybe what they're missing? Like what reverses that? What brings the stock back up to? I'm assuming you think it's undervalued.
Yeah, definitely. There's a bear thesis that says we're not going to have a differentiated REMS program because more often than not, FDA looks at a similar mechanism of action and they paint a one-size-fits-all REMS over that. I don't think that's legitimate in this case because FDA has already permitted us a different dosing strategy and it worked. And therefore, it stands to reason that since we've had no dose interruptions, we've had no heart failure related episodes, it works well enough, and in the open label extension even better, absent reproductive toxicology, absent DDIs. We believe the base case expectation should be a differentiated REMS. Some hedge funds, maybe with some nefarious motivations, are perpetuating a different narrative, and that's fine, that's their business. But I think it's reasonable to assume a base case that we should have a differentiated label.
And you're going to, speaking about that, you're going back to the FDA, you're going to have a meeting with the FDA to talk specifically about risk mitigation and the REMS program, is that correct?
We have a Type B meeting coming up in this quarter where that's the goal. We're going to paint different scenarios, understand what are their sensitivities in each case. From that, we'll make a decision about how to approach risk mitigation, how to approach a potential REMS. We'll submit the NDA. Ultimately, we won't get feedback from FDA until probably the mid-cycle review meeting, and we'll then have a more clear view as to whether they're accepting of our rationale.
So do you think you're going to say anything publicly about, at some point, about that, the outcome of that meeting, and what the FDA is thinking about the REMS plan before there's an actual decision?
No, because I actually think were we to say anything, it could be deemed misleading. Until FDA receives our application, it's on file, they're doing their review. Anything we might interpret from our meeting could be misread or misunderstood, misleading. And frankly, if we're going to be negotiating with FDA, I don't think I want to play that out in the public domain.
So let me ask you, so you mentioned this is a company, Cytokinetics. You've been there almost from the very, very beginning, 1998. What have you learned? I mean, and there's been a lot of ups and downs in Cytokinetics over that time. What do you think you've learned from, I mean, I could ask you maybe like how many drugs do you think that have gone through the pipeline at Cytokinetics in all that time? Do you even know what's that number? What is that?
So Cytokinetics has had some notable setbacks, and I've learned some things from those. We've developed 2 medicines through phase 3 in ALS, and we failed. And that was extraordinarily difficult to admit. We actually are publishing a book this week that will be available on Amazon, and it chronicles our history, our struggles in ALS, what it's taught us, what we hopefully can teach other companies who are going down that same path, and how we can express our gratitude to the ALS community for what it taught us as we now apply those learnings to other therapeutic areas. But that was an extraordinarily difficult time. We did that on our own. Similarly, we had a drug that was the subject of 32 clinical trials in heart failure, including an 8,000 patient clinical trial that lasted several years in partnership with Amgen, where that study positive, p less than 0.05 on a hard clinical endpoint, was not sufficient for FDA to approve the drug, but rather they wanted to see a confirmatory study. And that was an extremely long, arduous development program. It started in the early 2000s, and we now need to figure out what are we going to do with that, because it was a positive phase 3 study, as large as you can imagine. And here's a case where one of the learnings, we were partnered with Amgen. Amgen entered into a partnership with us in 2006 under the leadership of Roger Perlmutter, then at the time 2 other heads of R&D since then, and Amgen evolved over the course of those many years to be a different company with a different interest set, different commitments, and over time we became less persuasive in the context of that collaboration. And some of the things that we knew better to do in that phase 3 study, we weren't able to sufficiently persuade Amgen to do. And exactly as we predicted happened. We had a modest effect on the primary endpoint, but it was substantially amplified, more pronounced, as one looked at sicker patients. And we knew better. We knew the biology was teaching us to focus to a sicker cohort of patients, but we weren't sufficiently able to persuade Amgen to do that. And as we then saw, we hit the primary endpoint, but not with sufficient magnitude of effect. So it's now incumbent upon us to think about what to do next. I learned lessons there about collaboration agreements and what one should do to protect the downside, how to think about partnering, where on a go-forward basis, Cytokinetics will probably not put itself in a situation where we don't have recourse.
Well, one of the lessons I think people might have wanted you to learn from that was just to sort of discontinue development of that drug, particularly when Amgen walked away, but you continued on it. I mean, do you regret that decision at all? Like, what, or is that
Which
something?
decision?
To continue to develop the drug, to bring it to the FDA, even when Amgen walked away.
Not at all. Not at all. In fact, in some ways, the best deal we ever did is the deal I regret the most, because I do think the science and the biology teach us what we should be doing, and unfortunately, in that case, the decisions were made away from the science and more as were driven by some of the commercial upside that might have existed if the trial had had a larger effect on mortality. But if you look at the half of patients in that study that were sicker, you see a doubling of the treatment effect, as would have been compelling enough for FDA.
Would you go back to revisit ALS?
We're doing additional research in ALS, but with different mechanism of action compounds.
It's a tough disease to crack.
It's the worst disease, and we know so little about the etiology and pathophysiology that, unfortunately, there's more failure after failure after failure until we understand more of the biology behind it.
So you've been doing this a really long time. Again, we talked about you're like an OG, biotech OG. What does the final scene of the Robert Blum Cytokinetics movie look like? How does this end for you? Like, how do you want this to, what's the finale?
So we were talking in the green room about people that were involved in mentoring me in my early career, people like Bob Swanson, founder of Genentech. And when I was in high school, he took Genentech public, and I remember reading in Business Week about that and thought, how cool is that you can build a business around biology and you can help patients at the same time. I'm hopeful that I'll leave behind some legacy of an enduring value for science and patients. Cytokinetics, whether it's an independent company or part of someone else, I hope will be one of those exemplars of good companies doing good things for science, for patients, and it doesn't stop at getting drugs approved. Over the years, I've learned a lot about what ultimately matters here, and I think it's more and more about addressing inequities of healthcare and access to these medicines, not just making them affordable, but making them accessible. And I hope Cytokinetics will be punching above its weight class and an exemplar of that too, that if we go to market, that we're addressing some of those gaps in healthcare in the areas that we can operate.
And I'll be delighted to put you on my best CEO list at some point.
That's ultimately what I'm aiming for.
Robert, thanks so much for your time. It was great talking to you.
Appreciate it. Thank you.
All right, that was a great session. It's one more. Just getting some chairs up on the stage, and we'll announce the next panel. All right. Thanks to Robert and Adam. Here to join me for our final session, please welcome to the stage Dr. Daphne Koller, CEO and founder of Incitro. Dr. Derek Lowe, Director of Discovery Sciences at Novartis and author of In the Pipeline, which I know all of you read. And Dr. Vijay Pandey, the General Partner at Andreessen Horowitz. Guys? And we're going to talk about AI again. Get your questions ready, because I think this is going to be a really fun crew to ask questions of. Derek, you've been wonderful today in being here and in asking questions and thinking about a lot of the stuff. And you've always been wonderful in the way you write about it, in kind of representing, I think, the view from the bench about a lot of these technologies. So I'm going to start with you by asking you to throw down the gauntlet. What is it that, after hearing all this stuff about inflection points and different places in the value chain, in the drug development process, that AI might have an effect? What is it that you would most like to get across?
Well, the thing I'd most likely to see is the thing I'm least likely to get, to be honest, because I think that the ability of AI to help us out is almost inversely proportional to the value of the problems that can help with now. Now, I don't want to sound like too much of a wet blanket, because I don't think there's any logical or philosophical or mathematical reason why AI and ML techniques can't be incredibly valuable, but it's going to be very difficult, and we need a lot more data and a lot more understanding to get that value out of them. So I'm a short-term pessimist and a long-term optimist. I would love to have better target selection. I would love to have predictive human tox. These are ridiculously hard problems, though, so I'm going to have to settle for things less than that, and we'll work our way up to them.
Daphne, you've talked a lot about exactly that issue, about the differences in places in the chain. Let's give the audience a little bit of a thought there. I mean, you obviously, you seem to think this stuff is going to work because you're spending all your time doing it. You could be back working on Coursera right now. You found it.
Yeah. Thanks, Matt. So I think, Derek in some ways is right. There's, if you think about the value chain, there's these three big buckets that we like to divide this into, which is the early discovery of, if you will, therapeutic hypotheses. What do we want to target and which patient? And then taking those targets and turning them into molecules. And then finally, can we accelerate clinical development by picking the right patients and not picking the wrong patients and so on. And the vast majority of the work that's been done in AI has been on that middle bucket because it's a well-defined problem for which, by and large, reasonable data sets exist. But Derek is right that the real value that could be created here is actually in the earliest stages, because that's when you are deciding where you want to aim your cannonball, if you will. And if you aim it in the wrong direction, you're going to fail in phase 2 or worse in phase 3 because you picked a target that just doesn't do anything in the context of the disease. And Derek is also exactly right that data that is exactly on target, excuse the pun, of figuring out this is a good gene to modulate in the context of a disease. You don't get nicely labeled training data of that kind, but that's where a little bit of human creativity, I think, can really help combined with machine learning. So what we're trying to do, for example, at In Citro, is leverage large human genetic cohorts, human genotype, phenotype cohorts. And we've all seen the incredible work by Matt Nelson and others that shows that the delta in probability of success for targets that have human genetic support is, depending on exactly how you look, is 2.6x, sometimes as much as 4x. I view human genetics as like the early precursor to AI, and what I think is that we could use AI to help us better interrogate and extract patterns in complex high-content phenotypes, like imaging, like transcriptomics, where people can, a pathologist, you give them a whole slide pathology image of billions and billions of pixels, and they will give you 3 ordinal values, and they will be kind of right maybe on a good day, and not the same as what you get from the same pathologist a week later. A machine can see tremendous amounts of information in those images and in radiology images and in blood transcriptomics and in blood proteomics. And those are phenotypes that you can now link back to human genetics, which is a ground truth for causality. And that is a place where you can start to get not quite ground truth of this is a target that will work in a patient, but certainly increasing the probability of success in a way that maybe is commensurate with what we get from human genetics already, but with a much richer set of phenotypes. That's a place where I think where AI can help today in getting us to better targets in the context of diseases with unmet need.
But how do we know, Vijay, if it's working? I mean, isn't that the fundamental problem here when we talk about target discovery and shooting the cannonball? This is a cannonball that you shoot now and it lands in 10 years.
Yeah. Well, so I think there's 3 parts. I mean, first off, actually, I think the dark secret about this panel is I think we're actually not that much in disagreement in terms of like.
Sorry, Matt.
Well, no, I have. That's my next question.
Yeah, and we'll get to that. But I think following what Derek said, like in terms of short-term pessimism, long-term optimism, like how will we know? Well, what is different now than the way we did things before is that we are gradually moving, probably over a period of a decade, from something that looks more artisanal to something that looks more engineered. AI is a big part of that, but so is all the massive advances in biology in terms of robotics and gene editing and all the things that like Daphne and others can do in the lab that you couldn't do before. All that massive data needs AI, and AI needs the massive data. So how will we know? Well, there'll be these intermediate readouts along the way. When you engineer something, you don't just build it and then cross your fingers and hope it works. Like maybe one of the greatest examples of engineering was the Apollo mission to go to the moon. They didn't go to the moon on Apollo 1. Mm-hmm. They landed on the moon on Apollo 11. They gradually did more and more and more, tested along the way, and then when they got there happened to be success. But if there wasn't success in some part, they could fix it. Actually, Apollo 1 blew up on the launch pad. Mm-hmm. So it's something where that is what engineering is going to be like. We're going to find mistakes along the way. We're going to improve them. And that's fundamentally different than a discovery process where if it doesn't work, we just give up and we move to something else.
I get the feeling, though, Derek, that, I mean, you're not a venture capitalist and he is.
Yep.
But I get the feeling that if you were, you probably wouldn't be funding AI companies right now, and you are.
Well, that's a good question,
I don't
actually.
know.
Let's see.
I don't know because it depends on how much money I had at my disposal. Because I would like to.
Well, let's pretend you're Bob Nelson.
Ooh. That would require a number of differences in this world that we live in. But I would actually put some money down here and there because it's so early. That's what people, especially if you listen to a conference like this, you get the impression that all this is about to happen next week. You better get off your butt because here it comes. We're still very early in the era of AI. We have so much more to do and so much more to learn. And right now, it's impossible to say which of these things are going to start emitting magic sparks. Some of them are. So I actually would be putting some money down, but I would not be throwing $1 billion behind any one idea because I don't think we know enough to say what that idea is.
Well, I think there is an urgency, which is that this is not going to happen overnight. But if you wait 10 years to get deep into AI, you're going to be screwed.
Yeah, I can't gainsay that. So it's somewhere you have to. This is why being a venture capitalist is not always easy. Most of the time, it's just trivial.
Yeah. Well, you should try it. You should try it. Yeah.
Well, I noticed that even when it goes bad, a lot of them get nice clothes and houses. So
I wasn't going to bring
assets
that up.
under management. Yeah.
But it's true that you cannot ignore this right now. So I don't want to come across as someone who's like, I've been down that road. Because sure, I've been burned by computational promises a lot of times over the last 35 years. But computational biology and chemistry have advanced tremendously over that time. And I am not going to stand in front of a train that is being powered by advances in software and hardware.
And biology, because I
Yes.
think to VJ's point, look, AI broadly has been on an exponential curve. It's been on an exponential curve for decades. And exponential curves are these tricky things where when you're early in the curve, it looks really flat and boring and barely linear. And everyone's like, oh my God, this is progressing so slowly, it's never going to go anywhere. And then as the exponential curve is starting to really, take over and hit that inflection point, everyone's like, oh my God, we're on this exponential curve. That's what happened to AI in 2023 with ChatGPT. But you could have seen that coming in 2012. So I think in biology, we're about, I would say, 5 to 7 years behind that exponential curve that we're seeing in AI broadly. And the reason we're 5 to 7 years behind is largely because, to Derek's point, of limited amounts of data that are available. And that amount of data is being collected and it's increasing. And there's more new technologies, various types of microscopy and single cell transcriptomics and now proteomics and all sorts of stuff that's hugely increasing the amount of data that's available to these AI algorithms. And without AI, we will never be able to interrogate those data sets because they're far beyond what a human mind can encompass. And so we're kind of looking at the flat part of the exponential curve right now in biology, and you can kind of see a gradient, but it's nowhere close to where the ChatGPT for natural languages because we don't have web-scale data for biology. But that's coming. And as it comes, I think we will, will be more perceptibly on that exponential curve.
So, but you also worried publicly about hype.
I am very worried about hype. So is Derek.
Yeah, well, we know Derek, but so why are you worried about hype if we are a relatively small time in drug industry terms? I mean, I've been doing this for 20 years.
Because people think that it's going to happen tomorrow. People think it's going to, it's here any day now. And then there's going to be the inevitable Apollo 1s that burst up, but that burst on the landing pad. And people are going to say, see, we told you this was never going to work. And I think as long as you're optimistic but measured and say, look, what we're doing here is really hard and it should be done slowly and carefully because you're intervening in humans and you're putting stuff in a human and that can kill them. And so you need to be cautious, you need to be measured, and you still need to be optimistic because it will, in 10-year time frame, transform how we discover and develop medicines. But I don't want people to think that it's here next week, so that when it's not here next week or when there is a clinical failure of an AI-discovered drug, whatever the heck that means, then it's not like, see, we told you this was never going to work.
Well, there's an opposing force, too, that I think we don't really appreciate, which is that I think there's also a moving of the goalposts. in that you talked about like this middle area. We both talked about it, that the real hard problem is understanding biology, but being able to use computation to drug something faster, that's cool, but not as interesting to you. For the longest time, that was the problem.
True.
And so that was the problem that you felt burned about decades ago. Now I think we're getting to the point where we can do that, but now it feels like, oh, okay, we can do that, but that's not so interesting. It is a bit of, like, we have made real distinct progress.
Oh, yeah. I think that happens.
I want to ask Vijay, though,
Yeah.
how do you recognize the Apollo ones? It feels like we're not just going to have one thing blow up. It feels like a lot of things might blow up.
Yeah.
And you're the person on this stage who's actually in the business of giving money to people who you think won't blow up and not giving money to people who will. So how are you thinking about that?
Yeah, I mean, and so this is
as someone
basically-
who did a lot of this AI stuff before he started.
Yeah, I mean, this is a question of how to do venture capital, which is a longer discussion. But naturally, when we evaluate team and technology and what they're going after, therapeutic areas, and each one of those are things you can evaluate, especially if you understand AI yourself. And that's something that I have experience with, and we've built a team to be able to do that.
What's the worst AI biotech pitch you've seen?
Well, so the worst AI. So I don't know if you people remember, like around 1999 or 2000. That was .com was everywhere,
yes.
and like actually there was this one company that had nothing to do with the internet that changed their name to something .com, and their stock went up. And so like AI is in almost all the pitches we see now, and some of it is genuine AI, some of it is machine learning. There was one bit of AI that was basically an expert system, which is like 3 if then else statements. And so like everything is AI.
Yeah.
And so that those are the downsides.
Yeah.
Audience question?
Yes, we have a question here from Joel Shore from Deep Genomics.
Thanks. So I wanted to double click on something that you said, Daphne, but I guess it's for everyone. What would have to happen in the world to make you feel like the ChatGPT moment for AI and drug development was happening now? Or put another way, like what would need to start happening so that you feel like we're off this linear part of the exponential curve when it comes to this field?
There is no linear part of the exponential curve. The exponential curve is an exponential curve. It just appears linear because you interpolate it, and people interpolate the progress from last year to this year, and it appears to be, diminishingly small.
How do we know we're about to go straight up instead of thinking we're looking out there? When am I looking like
But
this?
it always looks linear is the problem.
Well, but you can see that the slope is.
Yes,
So,
we have puny brains, but how do you know when the curve is going up?
So I think one should. It's important to disentangle the different parts of the drug discovery pipeline, as we've already discussed, right? I mean, I think that we're already starting to hit that exponential moment in the taking a target and turning it into chemical matter. It's not quite there. I mean, people who make protein therapeutics can now make really cool protein shapes entirely de novo. I think that's really cool. Can you actually use that to drug a patient? Is it going to be immunogenic? Is it going to be stable? Is it going to aggregate? There's a whole bunch of things that Derek can speak to much more eloquently than I can, which we haven't seen yet, but they don't seem to be like so far out in the horizon that we're not
insurmountable.
Yeah, exactly. So I think we're kind of starting to see that inflection point on certain types of therapeutic modality classes, and that sort of turning targets into drugs type of effort.
Yeah.
I think where we're going to start to see the inflection point in the early part of the process is when you're going to have multiple novel biologic insights that are AI enabled. And I really want to make sure that we use that word, because insights don't come from an AI and go directly into drug discovery. It's an interplay between an AI and a person, which is why I said earlier that I don't know what the heck an AI-discovered drug is, because there's a person in the loop no matter what, so it's only a matter of degree. And the more the AI helps, and in discovering hypotheses that without the AI, the person would not have been able to see that, that's when you're going to start to see more and more targets, more and more therapeutic hypotheses that are making their way into clinical development and hopefully actually helping us address patients that are with unmet needs. So what would be the real validation of this? I would say if you have a drug that actually is successful, let's say in phase 2 clinical trials, human POC, in a disease that has not been cracked by humans before.
So drugs are whatever we're all waiting for, right? And what's going to happen is that something will come out, but be like, but AI came up with the target, but we could have come up with a target, or it'll be easy to point at things, and then there'll be fewer and fewer things to point, and eventually it's like, well, of course AI comes up with drugs. Like, why would you expect a human being to be able to do all that and load up all that data in your head? It's crazy.
Yeah.
So we saw the same thing with trading on Wall Street.
Yes.
Like in 20 years, it went from there's no way a computer could be as good as an expert trader to like there's no way a human being could beat a computer. And it will be 20 years, and it'll just be gradual, and there'll be a certain point where it will qualitatively shift over.
It's
Well,
been
Derek, I
every
wanna know
single
what-
thing in AI has been like that, by the way. There was a time when like people said there's no way a computer will ever beat a person in chess. And now it's like,
Or Go,
can a
or-
person ever beat a computer at chess? Every single thing has been like that.
First time I used an AI transcript, it was terrible. Now I use them every single time. Derek, looking at this now, what looks like it might be good enough to use? Is any of this stuff, you've written a lot about things that say they're AI developed drugs, but the targets are well known. Or
I think that, what Daphne was talking about with protein-based drugs, I think that is probably the furthest along right now, because the universe of protein structure, although huge and terrifyingly vast, is not as big as the universe of small molecule structure, and especially of small molecule protein interactions. There are only about 20 amino acids, and they tend to form the same kinds of angles and the same kinds of inter and intramolecular interactions over and over. That we also had the advantage of a tremendous set of very beautifully curated data, that is, say, the PDB. I got a lot of calls after AlphaFold first came out from journalists saying, what's the next AlphaFold? And I'm like, I'm not sure, because we don't have too many other databases that are as large and as well curated as the PDB. We keep talking about all the data that we need for this, which is absolutely true, but it needs to be good data. We have a lot of crappy data right now, but that's not enough to help. In vitro assays, they're all taken by different people at different times under different conditions and reported different ways to different degrees of accuracy and thoroughness. You can't use that. You're almost going to have to go back and recapitulate a lot of things in your own hands to get data that you think are clean enough for an ML or AI to really work on. Garbage in, garbage out just is turbocharged under these conditions.
Yeah, I think the fact is you're going to have to generate your own data.
Yes. That's what it comes down to.
Yep.
Matt, we have several audience questions. The first one
Great.
over here.
We'll take them quickly.
Hi. Looking over the next 5 to 10 years, I'm wondering how you think about sort of who wins from this, or kind of where value accrues. Because I think on the discovery side, for example, it's possible to imagine that you have hundreds more drugs that, or targets that you have, but you don't have the clinical capacity to test them, or the healthcare system doesn't have the capacity to absorb all these new medicines, and so maybe you just shifted value to like another spot in the funnel. I'm curious how you're thinking about that.
Well, we should be so lucky as to have so many medicines that new truly effective medicines that the healthcare system.
We'll find a way to deal with that.
Does access to data flip the ecosystem further away from small biotech startups and more towards large pharmaceutical companies who should have been collecting this data?
Yeah, but they were not collecting it to go into AI.
No, they weren't.
So that they were running programs.
Right.
And to Derek's point about you have each experiment was done by a different person in a different way, and the data was collected and annotated differently. That happens within pharma companies just as much as it happens in the broader ecosystem.
Maybe more.
Oh, yes.
And they don't like to share with their people across the hallway any more than they like to share with the rest of the world. So I don't actually think that big pharma has an advantage here. I would actually argue that in some ways they might have a disadvantage because there's so much entrenchment, and this is how we do things. That for example, the very concept that you might need to start with a blank slate and generate data for the purpose of training AI models is completely foreign to most companies. And by the way, when you design an experiment for training an AI system, it's completely different than the experiment that you would design for, hypothesis testing.
You learn from failures,
right?
Not just
exactly.
For
We've spent decades getting rid of all our negative results and pretending they aren't there. That was a very bad idea.
Well, okay, we're going to go fast.
We
Next
have a
one.
question in the back here.
Hey, hi. So question is,
You talked about protein therapeutics being the most advanced for AI-enabled insights. What are the least advanced modalities today for that?
Derek first.
Small molecule protein interactions, but even worse are small molecule RNA or small molecule DNA interactions. That's probably the toughest one right there. We just don't have good enough data sets to really get a handle on that. People are trying, but I'd say that's the one that's in the back.
Lightning answers from each of you on that?
No, I agree with that. I agree with that.
Okay. Next.
Oh, right over here. Sorry.
Nick's just teleporting.
Hey, thank you guys so much for being here. My question is around like assessing algorithms when they don't have the biological validation, when it's still maybe like pre-seed or seed stage. Like, how do you go about like seeing how good it is when sometimes they make their own tests and pass that with a high bar?
Well, yeah. So there are benchmarks and benchmark data sets that they could put through. And first off, if they haven't done that, that's already kind of suspicious because either they don't know enough to do that or they've chosen not to do that. And then if they have gone through the benchmarks, we can compare. But then finally, also, you have a sense of novelty. Are they really doing something new? And most of there's like, 450 AI and drug design companies, and many of them are using more or less off-the-shelf algorithms and off-the-shelf data. And those are the ones that are just not interesting.
He helped develop the off-the-shelf stuff. So.
We have a question in the front here.
Yeah, I have a question to everyone. It's more about colorful ribbons, which has this nice-looking protein structures, which seem to be well-funded now, and it's about also target discovery, right? So, like now we can generate these proteins. We can generate them go anywhere in the cell, right? Anywhere in the cell, we have cell trillions of epitopes, shapes, conformation, hypotheses. Do you think now it's a moment where we can go to the biology, go to all of the complexity, think of all the hypotheses we can generate about the cell and really accelerate the way we do target discovery?
So that is the founding premise for in vitro, is that the capabilities that cell biologists and bioengineers have been developing for the last 10, 15 years have given us an unprecedented ability to interrogate the connection between causal interventions in the cell and downstream consequences. And there's just so many tools that are incredible that have been developed. Their ability to take induced pluripotent stem cells and differentiate them into different lineages, the ability to do single cell omics of different modalities, imaging of fixed cells, of live cells. We have so much ability to interrogate causal biology in whole new ways that I think it's just a matter of having the discipline and the resources to generate that data and do something interesting with it. Now, I do think, and that's also been something that's driven our strategy, you can get so far with cell biology, but at the end of the day, you also have to close the translatability gap because you're ultimately not curing cells, you're curing humans, and that's much more complicated. And so that's where potentially the interplay with, human clinical data and human genetics allows you to kind of bridge between those two modalities. And I think there's a real opportunity because that too is an increasing amount of data.
To try to make this a little more concrete, actually, Daphne's in vitro, I wrote a story about you at the beginning of the year and had my favorite example so far of something that someone might have been able to do with AI, because I don't really know if it worked or not, but that if it's true, you did something really cool, which was that you were able to use AI to find a relationship between bone mineral density and liver disease. Then use the bone mineral density to find a genetic target for liver disease, and then test that in other biological models that it actually seemed to work. And that strikes me as something that a person wouldn't do, right? So that's a cool idea. That's where this gets me excited. Now the problem, and what I'd love to know what Derek thinks, is what do you have to know to be convinced that actually worked and that you didn't just create a bone mineral density drug for liver disease?
Yeah, it's tough because it's like we were talking about a little while ago. You have to prove those things in the clinic in real humans. That's where the rubber really meets the road on these hypotheses, because we already send a lot of really neat hypotheses into phase 2 and they die. We're going to be
if you're lucky, otherwise they go into phase 3 and die.
Right, exactly. Yeah, God help you. So we're going to be trying out a lot of really interesting hypotheses that are aided by AI-type discovery. I can't wait to see what the actual success rates are. I hope they're higher, but there are going to be things that we probably wouldn't have tried otherwise. So I'm actually really happy about that.
Yeah, I mean,
but Vijay and Daphne, in that situation, couldn't things get worse before they get better? Couldn't we have a lot of AI-discovered drugs that are actually less likely to succeed because we're still learning what we're doing?
When you're making a drug, you're doing it with AI, you're doing a superset of what you're doing before. So I don't think there's any new downside or failure mode.
I mean, it can't get much worse.
Yeah. The big issue, the big issue is literally that. I mean, is that the bar is so low right now with 85% failing that right now even something that makes a 5% difference would be vastly material.
So look, all of the things that we're pushing forward have been vetted through the traditional ways in which you vet new therapeutic hypotheses. So that same target that you just alluded to, which by the way wasn't quite bone mineral density, it was a DEXA scan that actually saw the liver in ways that people won't be able. So it wasn't that we were kind of
So it was actually a little bit of finding the red dot on the radiogram. You know, that classic example of the AI was finding the marks.
It's not
made by
that.
the-
It's
No,
not
it's
that.
not that.
It's not that.
You're actually reading liver fat from a DEXA scan in a way that a person would never be able to read liver fat from a
okay.
DEXA scan.
Okay.
And by the way we know that, and we've tested this in multiple
Right.
different ways, including the standard one, which is on held out patients. But we also basically ablated the human body. We showed the computer the left side and the right side. The liver, for all of you who don't know, is on the right side. And if you tried to impute liver fat from the left side, you got basically random results. From the right side, you got the same accuracy that you got from the whole body. It's actually seeing the liver. But then we did all the standard things, which is we tested the target in human genetics, we tested it in all the cell-based systems, including immortalized hepatocytes, primary hepatocytes, and then we tested it in an obese mouse model, and it reduced liver fat in the standard metrics that are held up in the clinic. Now, it's not a human, but we're doing non-human
But the
primate
original
results
data
later
was
this
non-human.
year, and that's getting pretty close. Non-human primate in an obese animal, I don't have those results yet, so I can't tell you it's going to work. But sure, you can do bad science with AI in the same way that you could do bad science without AI. In fact, you can probably do more bad science with
Right,
AI.
well, that's kind of what I'm worried about.
But you could also do better science with AI, and that's where it comes time to, for people like Vijay to decide where they want to put their dollars.
We have a question in the back here, Matt.
All right.
Hi. So Vijay actually had an interaction with Derek around essentially saying, hey, you're kind of moving the goalposts. It used to be that it was hard to find drugs, and now you're saying, oh, that's not good enough. Now we really need to have the targets, so that's the only way I'm going to be convinced that this is really, and you wrote an article just this week essentially saying until it finds a new target, I'm less convinced, sort of. And so I'm wondering how you react to that, and why it's not, okay, there are hundreds of targets. I saw a recent paper that said there's like 400 targets in cancer that have a biomarker. That would keep us busy for years.
Yeah.
Why is that not good enough?
Well, I was mostly unimpressed by the claim that there were so many targets that had been discovered by AI. When you look at the article in question and the targets are things like EGFR and LRRK2, it's like, oh, please stop
I've heard
this.
of that.
Yeah, exactly. Your rumors.
Yeah.
But so that's what didn't impress me. But Vijay's point about moving the goalposts is absolutely right. I have a presentation I give on this where I point out that a lot of things that we use constantly, people would have been stunned at, say back in the 70s. They would have looked at your map function on your cell phone and thought that this was general artificial intelligence. Like, oh my God, this is an intelligent machine. For some reason, right now it's only talking about streets, but it knows everything. It would have convinced people immediately. So we get used to these things, and we use them, and then we take them for granted, and we move on to another level and to another level. I don't make my own glassware, but organic chemists used to. I don't have to synthesize my own reagents, but they used to. I used to have to run chromatography columns, packing them by hand and cutting fractions. No one does that now, not in the industrialized world. We don't consider that fit work for a human being. There's a lot of other things that we're doing now that eventually are not going to be considered fit for humans, but perfect good fodder for robots and computers.
I don't know, that was a mic drop.
Yeah, no.
They had you at chromatography.
Yeah. God.
But there was also, there was something else in that question, which is that the biggest opportunity here is what you're doing for improving the process, which is having better targets so fewer drugs fail?
I think the middle bucket is there's plenty of things to do there too in terms of compounds, targets that are biologically validated and that we haven't hit yet. I think the exciting thing is really understanding human biology.
Yeah. Right, but there's always the problem that the lowest hanging fruit is also the stuff with the least benefit, right? Like the best fruit's at the top of the tree.
I mean, there's new modalities that can go after targets that have been validated for a while, and we just haven't had anything to go to hit those. So I think there's and we've seen that, for example, with siRNA, first hitting targets that you couldn't hit in any other way.
Right.
I think there's a question to my mind, which we haven't seen yet, whether these companies that design new drugs, new molecules from traditional modalities, small molecules, large molecules, but with AI are able to hit undruggable things. And that I haven't seen yet. Yeah. And I think that would be a really interesting proof, a demonstration that you are actually able to take something that no one's been able to hit before and hit it for the first time. That being said, we have lots of conversations with modality companies, both with traditional modalities as well as more novel modalities, and they all run out of targets at some point because there's the ones that are the perfect thing for their technology and they check those off, and then after they hit number 3, they're like, okay, now I got to go read the literature to find the next tranche of targets that are not as well validated, and then they come talk to us because they're always looking for things that are truly novel that their technology can crack open. And so I think novel therapeutic hypotheses is one of the things that is the scarcest commodity in this ecosystem.
Derek?
Yeah, Daphne's right about the targets that we already know about but can't drug. If someone uses some sort of AI technique to come up with a really solid C-mix small molecule, P53, or a really good selective phosphatase inhibitor, these things are really hard. And if I see some progress on that, I'll be impressed.
And I mean, Derek, I think I remember talking with you 15 years ago about how all of the top-selling drugs in the industry are better versions of something that worked first.
Right, and that's something that Daphne mentioned, the new modalities we've got. I've been so happy to be able to stay in this industry long enough to see all these things come up because it was getting pretty boring having one kinase inhibitor after the other. Now with all there's cell and gene therapies, which are not so small molecule, but things like targeted protein degradation and bifunctionals and a lot of other things that would have gotten you laughed out of the industry back when I started. I am so happy to see these things all hitting at the same time. It's never happened before.
Kinase inhibitors are still my favorite.
We have one more audience question right over here.
So the case is pretty compelling that understanding biology and systematically applying machine learning to a lot more data can get us a lot of targets and maybe new molecules in different ways, right? But we still run into, and like the whole day has been basically around that, right? Stopping almost at phase 1. We still run into the problem that once you enter the clinic, it becomes a lot harder, right? And I work in psychiatric disorders developing new drugs with I know, tell me about it. With a precision approach, right? Huge swaths of people who we don't understand biologically.
Yes.
How do we, and on what timescale, address that issue?
So I think that's a really great question, and I think there are opportunities there as well. But first and foremost, let me just say that, look, still, even in this case, a lot of the challenge that we have in clinical development is that we are going after targets that just don't do anything in the disease in question. Now, I think that here, just the precision approach that you alluded to, figuring out what is the right group of patients in which a drug might work, that is something that we've done precious little of in psychiatric disease, and frankly, in any disease outside of oncology. And so it's time for us to take what we've done in oncology, which is, this is not breast disease, this is not breast cancer. This is a specific subtype of breast cancer, and you're not gonna get a PARP inhibitor unless you have a DNA damage response type of cancer, because otherwise it's not gonna help you. And that's what allowed us to move away from that lowest common denominator of just blanket chemotherapy. So we need to do the same in psychiatric disease and in neurodegeneration and frankly in metabolic disease as well, and really move to a much more well-defined, biologically well-defined patient population. Having said that, the endpoints that you have in psychiatric disease, my heart goes out to you.
Those are particularly challenging.
Those are.
If you think about sort of clinical development more broadly, what you're describing could be very powerful.
Yeah.
And actually doesn't stop in clinical development. I mean, it goes on even to helping patients on
100%.
you know,
yeah.
on the other
The
side.
label needs to be defined biologically as
Yes.
it is in oncology.
Exactly. We're going to have a lot more diseases than we used to think we have. You know, schizophrenia, come on. If there is a disease called schizophrenia, there must be 120 types of it, minimum. But we just don't know quite how to tell.
Exactly. And I think that will increase hugely the probability of success. It will make trials smaller and more effective because you're going to see effect sizes without necessarily recruiting thousands of patients, I hope. I think there's work to be done on better clinical endpoints that are more objective, more well-defined. We're starting to see some of that with the biomarker work in neurodegeneration. I think that's hugely exciting because it's going to move us away from endpoints like, how do you feel today? Are you feeling better than how you felt 3 months ago?
But I think everything in DSMR is like that.
Yeah.
Yeah.
So I don't want to quite end there. So very quickly from each of you, what's your biggest hope for all this AI stuff? We come back in 10 years. Derek?
New targets for very difficult to treat diseases that we look at and say, my God, I never would have thought of that.
BJ?
If it's a mindset shift that we really are shifting towards really thinking about this as an engineering problem, a data problem. That mindset shift and cultural shift alone will be hard, but I think if once we do that, AI will only be part of that shift and hopefully will be the catalyst for it.
Daphne?
So agreeing with both of my co-panelists and adding to that the ability to use AI to really disentangle the heterogeneity of human disease so that you could actually go after patient populations that are clear and well-defined with therapeutic hypotheses that have a large and maybe even curative effect size, that would be my hope.
All right. Thank you very much to all three of you. Thank you to all of you. There's a little bit more left, and we'll open the bar. Thank you.
For sponsored remarks, please welcome to the stage Dr. Pierre Theodore, Head of Patient Impact and Health Equity at Genentech.
Good evening, everyone, and I get to be one of the last speakers between you and cocktails this evening. And first of all, I want to start by saying that this has been an extraordinary day. I want to thank the STAT organizers for really an extraordinary job in covering a full range of topics at the cutting edge of healthcare. I don't think we can really underestimate the complexity, but also the promise that we are currently facing in healthcare. And I wanted to provide one small anecdote to suggest that we truly do live in a revolutionary period. So by way of background, I'm trained as a cardiothoracic surgery, and a few years ago, I began to do robotic surgery, and I was invited by one of my mentors to join him in performing the resection of a right upper lobe for lung cancer. What I didn't realize is that he had superb physician assistants and surgical technicians that placed the robotic arms into the anesthetized patient's body. So that then when we walked into the room, we simply sat down at the console. So that means that we never touched the patient. We manipulated the arms of the robot. The tumor was removed and taken out of the patient. And then we walked back to the lounge and we were talking. And I said, think about this for a second. In the 100,000 years of our species, whenever has a tumor simply been removed from the body without an individual actually touching that patient at all? So it's really an extraordinary step. So I think those kinds of stories remind me that we really find ourselves at a revolutionary time. This next slide that I put up, I actually made in the back today because I was thinking, how would you summarize all that we talked about today? And I think many of you are going to be familiar with a paradigm that's something similar to this, where we talk about where we start with data and it moves into information, and then eventually, if we're lucky, that translates into knowledge and ultimately into wisdom. And what I would suggest, and some of this was touched on in the last panel, is that movement from this sort of holy trinity of large data sets and new models by our computer scientists and availability of GPUs and TPUs for the analysis of the data, moving beyond that into information to get to those last two levels will require us to think about what are the values that we really hold in healthcare. Values like equity and equality and justice and fairness and understanding which patients are included and which patients are left behind. What are our shared values? And that's what allows us to translate into these upper levels, hopefully leading to wisdom. We heard about maternal mortality, for example, today. What could be a better example? Taking back-end data from the experience of patients, turning that into actionable information that can be used by the residents, can be used by healthcare systems in order to improve the outcomes for women who are pregnant. So I would encourage each of you to think very carefully about the values that you all hold, reflect, of course, on the technical elements that we discussed today. And I want to thank the organizers again for allowing us at Genentech to be sponsors of this event. And I wish you a fantastic evening. Thank you. Good evening.
So, I told you we were going to open the bar. You went there first. Thank you to all of you. Thank you to each and every one of you who stuck it out. This has been an amazing day. It's been great to have you. All the questions have been on point and smart and trenchant and all those other words that are synonyms for the last 3 words I used. But thank you, thank you, thank you. We're thrilled to have all of you. We also have some other thank yous we want to make.
Yes, we want to say a big thank you to our stat team, to all of our moderators here. A thank you to Britt Cipriano. I wonder if the people can come out. Britt Cipriano.
Can we drag you guys out, or are you not going to do that this time?
Maybe she hears us. But if
Yeah,
not,
they're not coming
to
out.
Captain McPhail, to Julia Baker, to Caitlin Clark, to Alex Howley, and see you all in Boston in the fall.
I'd also like to thank again our summit sponsors for making this possible. Thank you to our presenting sponsor, Genentech, and our premium sponsors, the Chan Zuckerberg Initiative and Gilead Sciences. And I'd like to propose a simple toast to the future of medicine. So you can all toast back. It's right out that door. Thank you very much.
Thank you all so much. Thank you for being here. And a thank you again to our wonderful stat team, Britt Cipriano, right over there.